Hello everyone. Can you hear me?
Yes, sir.
Yes, sir.
This light is better or check the other light? Which one is better?
The first one, sir.
First one. Okay. Ready? Okay, can we start, guys? Hello, can you hear me?
Yes, sir. Yes, sir.
Yes, sir.
See, before we talk about the gait training in hemiplegic, I want you to just understand how do we look at the gait. The way we have been taught in the college was more of the focus on kinetics and kinematics mainly, and we sometimes focus too much on how does the angle of hip, knee and ankle is moving and what muscles are contracting, and we forget on the overall purpose of the gait. So that is why today I am going to talk a little bit more about the gait analysis first. Light is क्यों वर्क करते अर्धा तोंडावर यायला अर्ध हे खाली तरी करण्यात होतं खाली कर थोडंसं वर्क डोळ्यावर येतं माझ्या ठीक आहे जास्त वर केलं ओके हो दे Okay, so today I'm going to talk about how to look at the gait differently. We are going to discuss a little bit about gait analysis also, and today there will be a lot of videos about initial phase walking, like assisted walking in hemiplegic and brain injury when there is no control or very minimum control. In that case, what are the permutation combination you can do? So today there were two patients supposed to come, but because of some issue they couldn't come. One got fit and one person's BP was low, so both of them are not coming today. So fortunately, we'll have more time to discuss about lot of videos. So initially, I'm going to give a little bit introduction about the gait analysis and how to look at the different way at the same gait what we have studied in the college. Most of you have seen the gait analysis video on YouTube, and you may have a little bit idea what I'm going to talk right now. How many of you have watched my gait analysis video on YouTube? Gait Made Easy.
Sir, I have watched that thing. So have I, sir.
Okay, only 2 people has watched, then good, no problem. Those who have not watched the video, you will get a better perspective because traditionally we have looked at the gait very differently, and today I am going to change a little bit of your concepts. So if you do not understand something or if you do not agree with my point of view, you can stop and then ask your question. Okay. So basically, if you look this gait analysis, this is how the overall picture usually been showed in the gait analysis. We are going to discuss this picture later on more in more detail, but you need to understand these are the kinematics and this is the muscle work. Also remember that more than the muscle work, there are some of the forces which are not so active forces, or these are forces which is governed by the physics or gravity or momentum. That also plays a very huge role in our walking. And sometimes we miss these non-active participants, or so-called, these are called as passive forces, which are acting on the body in our walking. And whenever we are training neurological patients, actually the most important thing which we miss in our treatment is these passive forces, which are freely available, and it is always dependent on how do you manage it and how do you use for your benefit. So now we are going to talk about this in the end, about this in detail. So please understand, as you know, the gait is divided into stance and swing phase. So these multiple phases are easy, or these are meant to make you understand how does the muscle work happens in different phases, but do not get too much stuck into this concept. And the more you look at individual phases, you are actually bifurcating the overall purpose of the gait. And this is how the 3D gait analysis will show you the muscle work. If you look at this, it is basically the flow of wave from one. This is the basically sagittal plane analysis. This is hip, knee, and ankle. So here we are not going to study in individual phases. We are going to study the whole pattern of movement. And basically, it is a wave of movement which is flowing from one position to the another position. And that wave, it doesn't stop. It goes by one by one. So whenever we are analyzing the patient, we should always focus on the wave more than the so-called individual joint kinetics and kinematics in different phases. These phases are important, but as an overall, we are supposed to study them as an overall wave. So if you define the gait, basically in a broader perspective, we call it as a bipedal, biphasic forward propulsion. So bipedal because both only two legs are involved. Biphasic, swing phase and stance phase. Propulsive, propulsion of center of gravity. So this propulsion is very important word, forward propulsion. In that also the word important is the forward propulsion of the center of human body. So here we are not talking about the propulsion of the leg or upper limb or lower limb. Look at the word, the forward propulsion of the center of body. So whenever you are looking into walking, our objective is to how do I forward propel my center of gravity as a whole. Whole body should be considered as a whole whenever you are teaching somebody walking, in which there is alternate sinus movement of different segment of body. So because there is cyclic movement of right left, that is going to be there with the least expenditure of energy. So in this the keywords bipedal, biphasic, forward propulsion, and there has to be minimum energy expenditure. These are the keywords which we are supposed to look into gait whenever you are teaching somebody any walking or gait. These are the important point we have to look at first. Another way to describe or define the gait was it was highly synchronous, soundless, and rhythmic cyclic movement of the locomotor system of the body. So here they are looking at the whole body as a locomotor system. Whenever we look at the body as a locomotor system, we only consider the lower body and we forget about the upper body. But basically, it is a whole body acting as a locomotor system. so as to propel the center of body forward with minimum energy expenditure. So you can see that in both the terminologies or both the definition, the forward propulsion of center of body is more focused, more than how do you step or what is the kinematics and kinetics of the upper limb and lower limb. So basically it's a translatory progression of the body as a whole produced by coordinated rotatory movement of body segment. So whenever we are looking at the body, we have to consider body as a segment. We are going to divide the body into two segments, the upper body segment and lower body segment. In lower body also, right and left segment can be separated. So here we are not thinking as a hip, knee or ankle, but as a whole segment. And in the lower limb also there are three segments. Now in the body, the upper body and lower body is divided in two parts. The lower body is supposed to be a transporter and the upper body is supposed to be the passenger. A transporter is the person or the area which actually transport you from one place to another. That is the major objective of the lower body. And the upper body is supposed to be a passenger. In normal circumstances, what is the expectation of passenger? Whenever any passenger is sitting in the car, the minimum expenditure of the passenger is that he should be comfortable and he should not have a lot of movement while he is traveling. So the more he get less movement or the more he feels stable, we consider that transporter or that car as a very good car, like you can say luxury car. All these luxury cars, they are basically focusing on the convenience and comfort of the passenger. So here, when we are moving the lower body, the upper body, which is a passenger, they should be in a comfortable position and there should not be a lot of movement in the upper body. So that point you should consider. So transporter and passenger, this is how we classify the two part of the segments of the body in walking. So why do we study gait? So whenever you are analyzing the gait, every disease affects the gait. Ultimate measure of correct management by analysis of the gait, we can focus what to correct in typical management. We can be used as a pre-post operative or documentation or outcome measure, or improvement of gait is one of the prime importance in any patient's demand or goal. So that is why we need to learn and understand how to talk about the gait or how to analyze the gait. In this, the purpose of gait is the most important. So this slide is the most important for today's lecture. Whenever we are talking about the purpose of gait is not to do the hip deflection and dorsiflexion of the ankle and move from one place to another. But the bigger purpose is support head, arm and trunk, that is HAT, which is the passenger. So first purpose, the gait should support the upper body, which is the passenger. Then maintenance of upright posture and balance of the body. So whenever you are moving from one place to another, you should be able to maintain the upright posture. And while you are moving from this one place to another, this is a dynamic balance which is required in the body. Next important thing is achieve safe ground clearance and gentle heel or toe landing. It depends on how do you walk. Basically, ground clearance has to be safe and effective, and there should be gentle heel slide. You don't want heavy landing on the foot or the toe. Next, generation of mechanical energy to maintain the present forward velocity or to increase the forward velocity. So in walking, we are not supposed to focus on the active energy. We are supposed to focus on the mechanical energy, which will maintain the forward velocity. So whatever the velocity you are working, the gait should keep maintaining that velocity. Or if you want to increase the velocity or you want to increase the speed, you can increase the speed. Next is absorption of mechanical energy for shock, absorption and stability, or to decrease the forward velocity of the body. Another next purpose of the gait is that whenever you are landing or whenever you are going in the stance space, you should focus on shock absorption and providing stability. So whenever the foot is landing, like in last lecture you have studied that I used the terminology where the foot is not forming a good base of support. So in walking also, if the foot or the area in contact with the ground, if that area doesn't absorb the shock or doesn't provide stable balance, then the forward velocity will be reduced, or it may get hampered, or to decrease the forward velocity of the body. So the same landing can be used to reduce the forward velocity. Like somebody is walking very fast, like ataxic patient or a forward bending patient, or Parkinson patient, they walk very fast. So they should learn how to reduce the forward velocity of the body also. So this is what is more important. Like, so whenever you make any patient walk with AFOs, especially static AFOs, this shock absorption mechanism is gone, and so-called the compression which is happening at the foot ankle interaction, which absorbs the forces, is gone. And that is why the walking with the static AFOs or mechanical AFOs looks very uncomfortable or abnormal. So our devices, suppose such as assisted devices, should be such aligned that they should absorb the shock, or they should provide at least stability during the landing or stance phase. So what are the two functional tasks of the gait? So whenever you are looking at the walking, you have to look at the two important component or important purposes along with this in walking. So as a therapist, we have to look at that, how the lower limb are acting as a weight, how they are accepting the weight, and what is the weight acceptance phase, which is your stance phase. And then there is a single limb support, which is where we are on mid stance phase, and limb advancement. These are the three component we are supposed to look in the gait. So weight acceptance, in the weight acceptance, what is the initial limb stability? Like suppose somebody is walking with the static AFO, and the posterior part of the AFO is curved too much. AFO static or dynamic and AFO. So if the initial limb stability is not good, or if the person is landing on the forefoot, or they are walking on the front foot or lateral border, all they are basically trying to give less initial limb stability. If the initial limb stability is not good, obviously the shock absorption will be affected, and then preserve momentum of progression. And whatever the momentum which is happening, it has to be preserved. Can you see my leg now?
Yes, sir.
Okay.
Yes, sir.
Listen. So basically, whenever we're walking, initial limb stability, the weight acceptance. So in that, initial limb stability is very important. So what is the initial limb stability or initial contact? So if your initial contact is this way and it goes smooth, and this is how basically there is a limb advancement. So the foot, ankle foot interaction, and this is how we absorb the shock. Imagine now initial limb contact is not on the heel, it is on the lateral border. So obviously see, the weight acceptance will be affected. Or you go on the toes. So this also is giving a bad support. Or if you are having, the person is working with a lot of external rotation. So in all these cases, the shock absorption mechanism is not going to be good. And if, like when we go here, basically we call this is going down, which is basically absorption or shock absorption. Or a simple way, it is loading in the spring. When you load the spring, it absorbs energy, and when you release, the energy will be released from the spring. So similarly, so what are the momentum we are generating? So this is the compression. So up to this is compression, and then the mid stance, and then you get release. So if the compression part is not good, so there will be less absorption of energy. If there will be less absorption, there will be less release of the energy. And if there is less release of the energy, the opposite leg, which is supposed to be going forward, it doesn't happen. So that is why most of our hemiplegic, they walk like this. This is the paralytic leg, So they keep the affected leg forward, but the paralytic normal leg is always by the side. So they walk with short steps on the unaffected side. They get a big step and short step on this. Why? Because the absorption mechanism is not good. So obviously the release mechanism is not good. So it is not only just weakness of the plantar flexor, but because absorption and release, if that is affected, so indirectly the push-up phase is going to get affected. So what I'm trying to tell you, I'm not talking about the muscle work here, I'm talking about the mechanical energy, absorption and release. So mechanical absorption and release. So these are the three important words like initial contact, absorption of the forces, and then preserve the momentum of the progression. So imagine camera touch कर वो दोनों touch कर मोटा कर दाबो दोनों green वर था green चेक कर touch कर. So now imagine, so basically this is a FRO. So if I land like this, okay, so the moment I land, there are possibility I go this way or this way, because this supposed to be the natural progression of momentum where I go in little bit flexion. That doesn't happen. Now imagine the surface is very unstable. So whenever they land, this is how the hemiplegic leg gets turned out, and we think it is external rotator or action or weakness of interrotator. No, because it is mechanics. This is the area is curved. So whenever you load, there is a possibility of that area going this way or this way. But because this leg is supported here, there is less chance that the foot will go like this. There is no chance that foot will go like this. So that is how it goes in this or that direction. So whenever you are using any AFO, always remember that the shock absorption phase and forward propulsion is going to get affected. And now because see, I am stepping here and this is how it is locked. Now look at my left leg stepping. It is bound to get affected because I am not getting a typical push-ups. So if you don't get a typical push-up, this same thing happens with FRO or static AFO. So this for FRO, this is a mechanical advantageous position because that is what you want to lock the knee. But in some cases, if you don't want to lock the knee, the stepping is going to get reduced. So please understand that whenever you use AFOs, you are actually causing reduction in the dynamics of the foot and ankle. Shoe insert. Split and छोटे AFOs पण आहे. इथे ठेवलं छोटा कपड्यामध्ये. So now next part is single leg support.
Sir. Hello, sir.
Go ahead.
Sorry, sir, I missed the last part. What you said, your finishing sentence regarding the three phases.
Basically, if you give static AFOs, you need to remember that this shock absorption and preserving momentum, these two will be getting affected. If your objective is to preserve these two, or you want to increase the speed of walking, or if you want to maintain the dynamics, then you should always question, should I give AFOs or not? Or whenever you give AFO or any static mechanics or mechanical devices which will restrict the ankle movement, you need to understand these two are going to go away, and there will be compensatory mechanisms or gait deviation will be there. So the gait deviation were not caused by the hemiplegia, but they were caused by the mechanical device. See, basically.
But we are going to use this for temporary purpose, right? So
Sorry?
Once we stop using it and train without that, then they will regain it, right?
Obviously. But the problem is that most of us, we start doing gait analysis with the AFO also, and we blame some muscles that they are not working properly or something is wrong. But there is nothing wrong. It is biomechanics is found wrong. Like look at this. This is such a curved AFO. So now whenever it lands, it will either go sideways or medially. Medially is not possible. So they goes laterally. And the moment they can go laterally, they pull backward. So the AFO itself causes hyperextension of the knee also, especially in hypotonic stages. It pulls, or this is how they land on lateral border. So the dynamics is gone. That is what I wanted to understand that. So whenever you analyze this patient's gait with the AFOs, you need to understand this thing will be not there, and we should not consider that as a problematic. Or our aim is to provide that, like we want to provide a stable foot. We may compromise on the speed of walking, we may compromise on the momentum of the walking, we may compromise on the opposite step length, but we want stable foot. Okay, so like this is a limited range dynamic AFO. There is the adjustment here. So the moment I remove this, so if I give little bit momentum here, so obviously I am restoring the now momentum. This is a this AFO is giving you a stable foot, but it is also allowing the absorption of the movement, because on the mid stance the tibia moves over the fixed foot. So that is where we are allowing here. Okay? So if you stop this, that momentum will be gone. Okay. Instead of that, if you look at these AFOs, so now this the supporting surface, it provides a stable base, but it also allows dynamic movement, and it prevents only foot drop. So your choice should be this AFO, static AFO, or dynamic AFO. This is called as shoe insert or lift leg split. So this can prevent dynamics, but it may not give plantar fascial support or the strength which is required to lock the knee or keep the leg in extended position. So based on your weakness, your choice will keep on changing. So the point of I wanted to make here is that we are focusing on too much of mechanical forces than the muscle work first. So if your mechanical devices are not good or they are causing some different biomechanical changes, then you need to analyze based on that, not based on the muscle work. Okay. The next is a forward progression of body weight over the stationary foot while maintaining the stability. So how do you define mid stance or single limb support? So whenever you are looking at the single limb support, I use this word. So you are the tibia or the whole body is moving over a stable foot or fixed foot. The foot is stable there, it has to maintain stability, and the tibia has to move over the foot. So whenever we go initial contact, and this is loading response. From loading response only the tibia moving over the foot keeps going, and you go to the mid stance. So in single limb stance, the body is over a very small area, and that stable part of the foot should be stable. If the foot forms then only the hip, knee, and ankle will be stable. So single limb staff is very important for us, and we are going to do a lot of training for single limb staffs in the hemiplegic. Then limb advancement. So we don't call that as a swing phase or stance phase. Basically, swing phase is nothing but the limb is advancing forward. So limb advancements can be occur by two ways. So the limb advancement, it moves forward, and the important part, it prepares for the next initial contact. Sometimes whenever we are focusing on the swing phase, we focus too much on hip flexion. Like you must have seen that people whenever they are training, they teach people doing hip flexion up to this much degree. We do not require that much hip flexion for swing phase. The concept of swing phase is basically limb advancement. Once you take off, it is advancing forward, and the second part is more important. It prepares for the next initial contact. Like a lot of people train for swing phase, but they never train for the next initial contact. So if you do too much of flexion and the timing is very small, so you may not be able to land for the next initial contact. So instead of that, if you just clear and just focus on next initial contact, like how will you land next is more important than doing hip flexion. We just want the foot clearance without any drag. If the person does food clearance without any drug, that is sufficient enough as a treatment. Now, whenever we are going to talk about the muscle work now, this was a general perspective. What is the physics part of it? Now I'm going to give you a very simple principles. How does the muscle works in Gait? Most of this principle you must have heard in our previous lecture, especially in the upper limb course. But this simple principle, like how some muscle work and who stimulates the muscle, is the point I'm trying to make it here. So I am going to give you some basic fundamental principles here. So whenever we are looking at the Gait, we are supposed to look at the Gait with loading concept and unloading concept, and based on that we have to define the muscle work. So remember, whenever you are in loading or weight bearing, the extensors group of muscle work, and whenever you are in unloading, the flexor group of muscle work. So you don't have to remember if it is quadricep, plantar flexor, dorsal, doesn't matter. So whenever you are loading, if you analyze the posture, if the posture is in loading or weight bearing state, that means extensor group of muscle or anti-gravity group of muscle are working. So that is what you have to remember. And whenever you are unloading, the flexor group of muscle work. So this is the most important concept here you have to remember. Next, direction of muscle and what is the direction of movement. Suppose the movement is occurring in the same direction of the muscle contraction, then it is the same direction. And if the movement is occurring in the opposite direction of the muscle contraction, then it is the opposite direction. Imagine. Now suppose I am doing elbow flexion. What is the which muscle is working? Is bicep. If bicep is working and the movement is flexion only, and what is the natural course of bicep is flexion. So it is the same direction movement. Okay. So whenever the movement occurring is in the same direction, if the muscle working is same, then the type of contraction is concentric. And if the movement occurring is extension, but the bicep is contracting, so the movement occurred is opposite. So it is eccentric work. So let me explain you. So now we'll talk about hip flexor here, because if I am going to hip flexion, and because the leg is in the air, imagine the leg is in the air, it is unloading. So if it is unloading, which muscle are going to work? Flexors. Because you are in the air, hip flexors are going to work, and the direction of movement is flexion. This is how it is happening. Like we started from 20 degrees of hip extension to 30 degrees of hip flexion. So movement occurred is flexion. So if it is flexion, then concentric muscle. Okay. And when I am going down, now from 30 degree, I am going to 20 degrees of flexion. From 30 degrees of flexion, I am going to 20 degrees of flexion. So movement occurred is 30 flexion to 20 degree flexion. So the movement occurred is extension. We move from more flexion to less flexion. But now the muscle is, because the leg is in the air, the muscle acting will be flexors. So hip flexors are here, but you are moving in extension. So it is the opposite direction of movement. And that is why the muscle work will be eccentric. Everybody is okay with this?
Yes, sir.
Now I want you to switch on your microphones. So I am going to show you different movement and postures, and you need to tell me what kind of movement happened. And if it is the, you have to talk about what is the movement. It is a flexion movement or extension movement. Second, type of if it is the same direction or opposite direction, then what is the muscle work, which muscle is working, and fourth is what is the type of contraction. Remember, one,
flexor or extensor.
Wait. I'll show you the movement. So first you have to talk what is the movement. Movement, muscle work, same direction or opposite direction, and last type of contraction. These are the four things you have to remember. So I'm going to show you different activities, and then you tell me what is the muscle work. Now we are in 30 degrees of knee flexion. 20 degrees of knee flexion. 0 degrees of knee flexion. Okay, let me explain you. Then you take away your microphones and then you talk. Okay, let me explain you first. because somebody's sound is cracking and then it will spoil everybody's sound effect. Okay. So we are in 0 degrees of knee flexion. From there, we are going to 20 degrees of knee flexion. Okay. So this is the movement I got 0 degrees of knee flexion to 20 degrees of movement knee flexion. So what is the movement?
Flexion.
Knee flexion.
Everybody is okay with the no, don't use the word knee flexion or anything. It's a, what is the movement? From 0 degrees of flexion, we move to 20 degrees of flexion. Movement is
Flexion.
flexion. Very good. Now, which muscle will contract in this position?
Hamstrings.
Extensors.
Sir, hello.
Quadriceps.
Sir, it is
The
quadricep
loading.
quadricep extensors are working towards ground.
Okay. See, guys, somebody said hamstrings. I gave you first principle. Whenever you are in loading, which muscle are supposed to work?
Extensor.
Extensors.
Which muscle will work right now here?
Quadriceps.
Movement happened was
Flexion.
Flexion.
working is extensor.
Extensors.
Type of movement is same direction or opposite direction?
Opposite direction.
Opposite direction.
Opposite direction.
Type of contraction will be
Eccentric.
Eccentric.
eccentric. Okay, clear. Now same example. So continue from 20 degrees of flexion. I go to 0 degrees of flexion. Okay. From 20 degrees of flexion, I go to 0 degrees of flexion. So movement happened is
Extension.
extension. Muscle working on
Quadriceps.
Quadriceps.
Quadriceps, guys. I want you to use only flexor or extension. Okay. Extensor. So movement occurred is extension. Muscle working on extension. So same direction or opposite direction?
Same direction.
Direction.
Direction. So type of contraction?
Concentric.
Concentric.
Concentric. Clear?
Done.
Yes, sir.
Done.
So this is the basic fundamental principle. Now you can switch off your mics. And if there is no movement, like in swing phase, the ankle is neutral only. So if there is no movement, so type of muscle contraction will be isometric. And depends on which position you are. If you are in the air, it will be flexor isometric. If you are loading, it will be extensor isometric. Okay. Now this is the bridge and tentacle principle. So you know as the tentacle principles. So because one part is touched and other part is free. So whenever there is a tentacle, then depends on what is the position. If you move forward, upward group of muscle are going to work. So if I bend forward, upward group of muscle will be extensors, back extensors. Okay. And if I move backward, again upward group of muscle. So in tentacle principle, it is always the upward group of muscle or so-called anti-gravity group of muscle, which will not allow you to fall forward or backward. That is going to work. So here to prevent the fall, the back extensors are supposed to work. Here to prevent the fall, the abdominals are supposed to work. Here in the ankle, it will be plantar flexor. Here in the ankle, it will be dorsiflexor. So basically, whenever you are in tentacle principle, it is upward group of muscle. And whenever in the bridge principle, like now I am leaning forward. Whenever I am leaning forward, which group of muscle we're going to work here? All back extensors here. And the moment I touch the hand,
Flexor.
it forms a bridge here. So the moment it forms a bridge, the downward group of muscle also, the abdomen is going to work here. So this is how the muscle work changes. Okay. So tentacles, upward group of muscle, bridge, downward group of muscle. Okay. That is the third principle. So in the gait, we will see there are a lot of muscles are inactive. They are not always continuously contracting. So there are other forces which are also required, or they are called as external forces. Internal forces is your muscle work, and external forces is all these forces. So the other forces which are working is the line of gravity, momentum, gravity, and pendulum. And that is what we are going to discuss in the lecture now, how they work. So please understand what is movement arm. Basically, this is one joint, this is one lever, second lever, and this is the joint. And this is the force of muscle contraction. So the force vector, it is a perpendicular distance from the force vector. So the perpendicular distance from the joint to the force vector is the moment arm. Okay. So please understand, it is a perpendicular distance from the force vector to the joint, that is called as moment arm. So look at this example. So this is suppose elbow, because this is extended position, the force of contraction of the bicep will be like this. You can look at this problem as a bicep, or you can look at the problem as a gravity. Whenever you look at the problem or the force vector of the bicep, the force vector of the bicep keeps on changing, and it is not so much important. The more force vector which is more important is the gravity. So whenever I analyze any muscle work, I always analyze the muscle work with respect to the gravity. Why? Anyone?
Because it is constant and it remains the same in any position.
So it is constant, very good. The value is always exactly, we know it. Also, we know what is the direction of the moment arm. Like if you look at the bicep here, bicep force vector will keep on changing. Like in this angle it will be straight, in this angle a little bit oblique. So the bicep vector will keep on changing, and it is very difficult for us to analyze the moment arm. And the most important, that is not the important movement arm or the force vector we are supposed to talk about. All the movement which we do in our body is always with respect to the gravity. And what is our force vector? What is the moment arm with respect to the force vector of gravity is more important. So all this angle what I showed you here is basically the force vector of the gravity. And what is the force vector line of gravity?
Vertical down.
Vertically down. It is always vertical is more important, and it is always downward. So we know what is the force vector. So if this is the area, now depends on where is the center of mass, accordingly the force vector line will go like this. So here the more the joint is extended, the moment arm or the center of mass will be less here, and that is how the force vector will be more closer to the joint. So the moment arm will be less here. So there will be less muscle work required. The more the moment arm goes away from the joint, the more and more muscle work will be required. So for muscle,
So how the center of mass is decided?
center of mass. Okay, center of mass is basically, it is always located approximately at the center or towards the larger size area. Like in forearm, like look at the forearm. So from here to here. So if you look at the center, it will be close to the center. Now because the size is smaller here and size is bigger, so it will be more little bit closer to the larger area. So basically, what is center of mass? It is a point from where the mass is equally distributed on both the sides. And on average, we always think that the center of mass is at the center of the segment, and we are assuming that segment is equal in size in both the side and equal in mass at both the side. So if you look at the forearm, the center of mass will be approximately here. So when I am extended, the center of mass and line of gravity will be here. So I don't require more force. The moment I go up, the moment arm will keep on changing, and the muscle work required will be more. So bending here will be more difficult. So muscle contraction is equal to moment arm into weight.
Okay.
So that is how we concentrate on the movement arm. So for as a therapist, our objective is to keep the movement arm as minimum as possible. Why?
Less muscle.
Energy conservation.
Very good. That is a very, very apt word. There are two words: energy reduction or energy conservation. So conservation, basically, I don't want to reduce every time. We have to conserve the energy so that we can utilize it in other way. As a human behavior, all of us, we always want to work less. Any of you like to work hard and want to do a lot of muscle work without any purpose, when you can do the same thing with minimum muscle work? What do you like?
Less work.
Less work, because human behavior, we always want to work less and get more result. Yeah. And that is very, very natural. Less effort and more result is a natural human behavior, and that is what our muscles also do naturally. So please understand this. Now look at this. Like, because in standing position, the center of mass passes through the hip, knee and ankle. So the muscle work required in standing is very less. Compared to that, the moment you bend forward, the momentum keep on increasing. So the muscle work required will be more. Like in squat to stand will require a lot of muscle work because the momentum is increased. So that means muscle work is increased. So muscle work is equal to movement arm into the weight. So that is the muscle work definition. So the more the movement arm, more is the muscle work. If you reduce the muscle momentum to 0, you don't require muscle work at all. Like in standing, the line of gravity passes through the hip, knee, and anterior to the ankle. So only muscle work required is the ankle, hip and knee, because the momentum is 0. You don't require a lot of muscle work in the hip and knee when you are standing. Make sense? Now look at the lower explanation here. So whenever these weightlifting guys, they try to keep the line of gravity within the base of support, and they try to keep the movement of knee and hips in the same length. Now imagine, so I'm doing weightlifting. So the more I go here like this, so it is equal. Now imagine I reduce the momentum of the hip, it is more closer to the hip, and increase the momentum of the knee. So I require more muscle work in the quadricep. Or I do other way around. I increase the momentum of the hip more and reduce the momentum of the knee. So knee will work less and hip will work more. So that is why whenever we are doing lifting, this is what happens with our patients or therapists getting back pain, because we are not using a good momentum of the hip. Or you must have studied. So whenever you are lifting any object, we should keep the object more closer to the body. So by keeping the center of mass more closer to the body, we are reducing the momentum of the object, and that is how it is more easy to lift. Like, so if I hold object like this, the momentum is here, so too much effort. But if I hold like this, again, because the center of mass is there, it is more closer. And if I hold closer, it is less momentum, less muscle work. So this is what we do. Look at our hemiplegic, how do they stand? They stand like this. So what are they doing technically? This is how they walk on the affected side. Anyone?
So they are not reducing the momentum.
They are increasing the moment.
Sorry?
They are increasing the momentum, that is the bending through their back. So the momentum is increasing.
So they are increasing the momentum of the hip. So that means they want to increase their hip extensor work. Actually, there is one more thing they are trying to do it there. For example,
They want to use the less energy, sir,
how? That is the important question.
because they are not using the hip, knee, ankle. They are putting into neutral. No energy working there. So with just minimum bending with the trunk, they are doing that walking purpose.
But by that statement, see, standing here is less muscle work. Standing here is more muscle work. Why our patient will try to increase that muscle work? So by the only concept of movement arm, we are not able to reduce the muscle work. So there is one more concept we have taken to account. Now look at this example also. So the movement arm, the center of mass is in the center. So both the movement arm are equal. But the moment you go forward, the movement arm of this area will increase and cause more effort on the back. So there is one more force which is there, which is effective and always available, free and equal to all of us. So like earlier we said, the force of gravity, which is always constant and in one direction, which is downward direction. That is what we understood. But there is one more important thing. We should look at the line of gravity as one sec. See, understand guys, line of gravity is also force. To extend our knee also we require force, which is quadricep force. You can use your own quadricep force or you can use external force. So what our hemiplegic patient does, because they don't have quadricep force and they cannot lock here in this position, in flex position, everything is going to collapse. So what they do, they use line of gravity as a force to extend their knee. So by bending forward, the center of or line of gravity bends forward or falls forward, but line of gravity falling forward, that line of gravity itself acts as an extensor force in the knee, and that is how they lock the knee, and they hang on the posterior ligament of the knee, and here also they hang on something, the posterior ligaments here, and that is how it is a locked in position, and I can rely on that very well, and I don't require muscle work at the knee, ankle or hip. So basically our hemiplegic are so smart, they know that there is a gravity force which is frequently available there. It is always free, and direction I know. So what I have to do, I have to just throw the line of gravity forward, and by throwing the line of gravity forward, muscle work changes. Now understand this. So when the line of gravity passes through this, no muscle work is required. The moment it goes forward or backward, like it goes backward, if the line of gravity goes backward, that means this is going to collapse. So the anterior group of muscle or the quadriceps is supposed to work here. Okay, so the more the line of gravity backward, the quadriceps has to work, and that is what our hemiplegic do not have control. So they don't like this position. They don't want to stay in this position. So what they do, they throw the body forward. By throwing the body forward, what happens? The line of gravity goes forward, and it creates an extensor movement here and flexion movement here. So by creating a flexion movement here, we are technically creating the extension movement in the knee, and that is how we are locking the knee, or we are trying to extend the knee. So our patients basically they use line of gravity as a force of contraction to lock the knee. Everybody is okay with this?
Yes, sir.
So can you explain again?
If the line of gravity falls behind the knee, like this example, it isn't behind the knee. So again, we only looked at the body or gravity as a line of gravity, but there is one thing also we are missing. Whenever we are looking at the muscle work, our brain never ever decides muscle work. Please remember this. We have misunderstood that our brain decides which muscle works or which muscle don't work. Brain does not decide the muscle work. Can anyone tell me who decides the muscle work? Which muscle to work?
So program patterns in the brain.
Program pattern in the brain. Anyone else?
Line of gravity.
Sir,
Line of gravity or koi?
Sir, postural anticipatory postural reactions, postural all these. I mean, this is anticipatory work, na, sir. We do in response to activity.
Basically, what I am trying to tell you is, you do not require a brain at all to contract or not to contract any muscle. So we do not require brain. We do not require any postural reaction. Nothing. Any muscle to contract or which muscle to contract or which muscle not to contract is only decided by gravity. And in gravity, based on, now gravity is the bigger factor. Gravity can have different. So what is the line of gravity? What is momentum of the gravity? What is your alignment of your body with respect to gravity? Based on that, all the muscle will decide. Our brain never decides which muscle to contract. Okay?
Okay, sir. Right.
Any question in this? I am going to explain that in detail. Don't worry. Okay? Shall I explain?
Yes, sir.
Yes, sir.
So understand here. So whenever I am in this position, based on my line of gravity. So gravity is force which is equally available. What is the direction of gravity's force?
Downward.
Vertically
Downward.
So what is the objective of gravity? To pull everything downward. Okay. So what,
Yes, sir.
What is our objective as humans?
Protect ourselves.
We have to keep upright.
Protect us. Right.
So we have to keep upright. So because gravity is going downward, we have to keep upright. So the body's muscle will automatically act based on how to keep upright. Now imagine if the knee is in flexion, line of gravity falls behind. So if the line of gravity falling behind, what movement it is creating in the knee?
Flexion.
So it is creating flexion movement. So by creating a flexion, you collapse. So if I shift the line of gravity forward, what movement it is creating in the knee?
extension.
Extensors.
Creating extension movement. So by creating extension movement, you are causing extension. So by just switching the line of gravity forward or backward, you are creating different kind of movement, extension movement or flexion movement. So by just manipulating this, you change the muscle work. Okay. Now, see, when I bend forward, when I bend it forward, all backward group of muscle are going to work. If I lean backward, all anterior group of muscle are going to work. So my brain doesn't get so much time to think, oh, I moved backward, so you have to react your flexor. We don't get that much time. It is only gravity based on muscle pull, the muscle work automatically changes. Okay?
Okay.
Because imagine gymnast people, they move so fast, and for a normal population, from toe to the head, the maximum speed which is dorsal column track is 120 meters per second, and our body is 175 meters. So at least it will take 1 second to reach to the brain. But gymnasts, they move so fast, and the muscle work automatically occurs. So it is not the sensory feedback which gives your brain to contract or not contract. It happens subcortically, automatically, with respect to the response to the gravity. Line of gravity, momentum, and alignment. When I say alignment, understand what is alignment when I mean. What is my respective position of hip, knee, and ankle, or one segment with the other, that is alignment. Like this is a hip flexion alignment, hip extension alignment, flex posture alignment, inclined alignment. Now I'm inclined forward. So alignment is always with respect to two things. A relation of one segment with another is also alignment, and alignment with related to verticality. So whenever I say orientation or alignment, these are the two things you have to focus. Alignment, relation of one part to another, and next is orientation. Orientation, whenever we are talking of orientation, we are always talking alignment with respect to the verticality. So this is vertical alignment or vertical orientation. This is inclined orientation. It is more inclined orientation. This is horizontal orientation. So based on that, because the more I change the orientation, what am I changing?
line of gravity also.
Line of gravity changing. If your line of gravity changing, what is changing?
Momentum.
Momentum is changing. What is changing?
Muscle. Energy required.
Energy required. So more and more muscle required. Make sense?
Sir.
Okay?
Yes, sir. Yes, sir.
So that is what I am trying to tell you that. So we do not require brain for any muscle to contract or not to contract. Are you with me?
Yes.
Yes, sir. Yes, sir.
Now last 4 lecture I taught you how to activate all the muscle, and I am today saying that we don't require brain to activate any muscle. Any contradiction? Don't you think it is a self-contradictory?
Both are correct. Like both the things are correct.
Yeah, both are correct, but it is always depends on what you assume is right or wrong. So our any assessment or treatment based on what is the assumption. If you assume that we require brain as a control mechanism, you will focus on treating brain-related problem, or you focus on strength training. And if you assume that it is gravity, physics, external forces, alignment, orientation are the problem, then what you will do the treatment?
Change the
These
orientation
factors.
and
With respect to orientation
external
and alignment.
factors.
So we'll play with these external factors first, not to work on strengthening of plantar flexor, quadricep, or hip extensions. Are you with me?
Yes,
Yes,
sir.
sir.
Clear,
Sir,
everyone?
can I ask something?
Now please go ahead, Sona.
When the hemiplegic used to go for the hyperextension of the knee at the time of the loading or loading to mid stance. So at that time only, they used to go for the hyperextension of the knee, isn't it, sir?
Yes.
Okay. So at that time, is it basically because of the lateral shifting towards the limb? That is the lateral shifting of the weight at that affected limb.
Okay. I will tell you why in hypotonia especially, or weak patient, why they go in extension. Okay. Whenever you are analyzing the posture, you always.
No, sir. My question is that you are saying that they used to lean forward, then that's why they used to go for the hyperextension.
Right.
So, but hemiplegic, I have not seen so many that they used to lean forward. They used to either they have to side shift affected side or other way. Sideways they used to shift.
No, see, these are the different ways they compensate for the weakness. Okay. One of the way to compensate for the weakness is forward bending. Okay. If they walk slower, there are two possibilities. They either shift sideways or they shift frontways. Because front anteroposterior stability is not good. When they walk slow, they walk sideways or they shift sideways. So by shifting the weight sideways, they are actually not taking weight on the affected leg. They are doing one leg stance on the unaffected side. They are only walking with the one leg, and they are only using that as a base of support. But the moment they start loading on the affected leg, they lean forward and try to extend the knee. That is how they compensate, and that is why most of the either they lean forward or they just extend the hip backward. So they are just pulling backward. So when they load, this is how basically they step, and this is how they load. They may not bend forward, but if you pull backward, line of gravity is going anterior. So when I say you require extensor momentum, you don't require this much of flexion to create extensor momentum. By just doing this also, you are getting extensor momentum. The line of gravity from here has to just shift a little bit forward. Even 1 centimeter, half centimeter is good enough to create the momentum. So the line of gravity has to just shift anterior to the center of mass or the anterior to the joint axis. And the moment it shifts anterior, it creates extensor momentum.
Okay, sir.
Okay.
So sometimes they keep their entire body weight behind also, as in they lean behind.
They only lean behind if you are standing in the behind. Human behavior, we always lean on the side or area or the area which is supporting us. If you stand behind, they lean behind. If you don't stand behind, they don't lean behind. They bend forward.
No, sir, without standing also, they keep their entire body weight behind.
Okay.
As in my case, when the patient was
Your patient video, I will show you how does he walks. Basically, he doesn't lean behind. He walks. He doesn't take weight on this leg. He leans behind, and basically, he's not allowing the line of gravity to go forward. So basically, he's on walking on the leg, one leg, and he's using extensor force. So he doesn't want to work on this leg also. Here, he's creating an extension momentum. So the hip also is not working. So knee also not working. So he's walking with the less muscle work on the unaffected side.
Okay.
He's so smart so that he doesn't want to work on the unaffected side also more. So there also he's creating extensor momentum in the hip. Make sense?
Okay, sir. Yes.
So there are a lot of variations. Whenever you analyze, don't analyze only with the one point. That is why I give you multiple analytical points. Like, is this the problem? Is the momentum is the problem? Is the line of gravity is the problem? Is the center of mass is the problem? Or what is the alignment with respect to the joint? Or what is their adaptation? Like, what are they doing? So whenever you draw a line of gravity, you should, like your patient, whenever he stands, the line of gravity actually falls here on the left leg, not on the middle.
Yeah.
It is never ever here. So when the more the line of gravity falls here, those patient does a lot of flexion. If the line of gravity falls here, they don't do a lot of flexion. They walk like this. Okay.
Okay.
So you should align where is the line of gravity falling. The more it goes, they create momentum, flexor momentum in the hip and extensor momentum in the knee. The more the line of gravity goes here, they create extensor momentum on this side, and they don't do anything on the unaffected side. They just drag.
Sir, but he doesn't even try to shift his weights on the affected side.
Why?
Because of fear, maybe.
Because the right leg is not reliable. Do you always date an unreliable boyfriend?
No.
Nobody dates. Like तुमने quote सुना होगा. Behind every successful man, there is a woman, right?
Yes.
But the fact is, like, because movement don't run behind unsuccessful man.
Yes.
So it may not be true that because of the woman, the man has become successful, because woman only run behind a successful man. Only stupid girl, they learn behind a unsuccessful man. And that unsuccessful man always good in something, like a bad boy. He's good in fighting, like the Tufan picture, recent Tufan. He's a gunda. So he was good in gundagiri. So that is why he was successful in gundagiri. So that is why the doctor leaned behind him. So women always run behind successful men.
How does it relate with the patient?
It is related based on reliability.
Okay.
Human behavior, we always rely on something which is reliable. We do not rely on something which is unreliable. If the foot is not forming a good base of support, if the right leg or paralytic leg is weak, it is not reliable, will you rely on that leg?
Got that, sir.
No. So why will our patient rely on that leg?
No.
But if you give a system a mechanical support which will make him rely on that leg. Suppose example, for example, okay, I don't use that as a treatment, but for example, if you give a KFO which locks the knee and ankle into mechanical lock position, now he has to only manage him. There are 3 joints of freedom of movement was there. Now there are 2 are gone. So only one freedom of movement is he has to manage his hip. So he will have at least 70% reliability on the affected leg.
Yes.
Make sense?
Yes, sir.
Make sense? Now you had made that patient walk on stairs also,
Yes.
and you saw that how fearful is he while he's stepping, and the leg is falling into external rotation.
Yes.
I'm going to discuss that case when I'm going to discuss all the patients' video. So that time I will discuss, or others want to see that video right now? Others?
Yes, sir.
Yes, sir.
Yes, sir.
This is Sunya's patient. Now look at this. Now today's video is much better. He's actually relying on that leg, and see how he's inclining his body forward.
So this is not today's video. अभी तो और भी better हो गया है. ये
हाँ.
पहले का ही है.
So,
जून का है.
हमारा last में मैंने जो वीडियो शेयर किया था उससे थोड़ा बेटर ही है वीडियो.
हाँ.
Okay.
ये
He's
जून का
actually
है.
relying something on that leg. So there is a little bit stability, and he's not using cane also, and he's so much confident. Now look at the right opposite leg step length. Okay. Look at left leg is so big. The heel is ahead of the right toe, but the left foot is always to the left, or it is going partially forward to the left leg. It never goes beyond the left leg. Why? Because the left leg is not so much reliable to take a bigger step. And you can
Yes.
see that the leg is always in external rotation.
Yes, sir.
Why? Why the leg is in external rotation?
Base of support, sir. To increase it.
Okay, good. How many of you think that there is external rotators are active, or internal rotators are inactive or weak or something related to the muscle work? Anybody want to blame the muscle work?
So the internal rotators are weak.
That is where we do the common mistake.
Is it because of
excuse
the
me, sir.
alignment of
Alignment
the foot?
is also issue.
So the role of the ankle is to provide stability and to provide more base of support. That's what he wanted to use. That by doing it external rotation, he's increasing his base of
If you
support.
are only talking about the ankle is in anyways it is same base. If it is inter-rotator or external rotator.
So you get a more base by doing a little bit outside.
So is it the external rotation happening at the foot?
No, so at the hip it is happening, of course.
So the blame is to the hip, not the foot. Okay.
Yeah.
So basically, whenever you feel unstable or you are not confident, what we do, human being normally we increase the
Base.
Wider base of support.
increase the base of support. So
Or
external rotation, we understand this word. External rotation is a strategy. Okay, is a treatment strategy either used by therapist or by automatically by the patient as a treatment or stability strategy. So external rotation is a stability strategy. Because he is still not stable, he is doing external rotating and increasing a larger base. If he takes a smaller base, he will not be reliable on the affected leg. Okay. Now look at how he climbs the stairs here. Okay. Look at so much of external rotation. What is the problem and what is the treatment? Come on.
It's not shifting weight.
इनका तुम्हारा हेडफोन पे यूज करने लगता है आपका कर बहुत सुनाई दे रहा है.
Sir, am I audible now?
हाँ, better now.
Yeah, sir. So maybe here, when the patient is ascending the step with the affected leg, the foot placement is not proper. That is, he is not placing the heel first. the complete foot placement is not there on the upper stair. So maybe that is what is the alignment is changing. And maybe because of that, the leg is going into complete external rotation.
So you want to blame ankle or hip?
Sir, basically the alignment, if the foot position, that is the placement is corrected, the entire limb will be in a proper position, I guess.
So if you think that is the problem, what is the solution?
Sir, maybe before in the initial phases of training, if I am supporting the leg, the affected one, and if I am placing the foot in a proper way on the upper stair, and just making the patient repeat that movement first and the weight bearing movement, maybe that will help the patient learn that movement in a better way.
No, you are training the swing phase or stance phase of the stair gate.
Stance phase of the affected leg.
So, so how will you place that? Where will be your hand?
Sir, I'll support the ankle and one leg on ankle and one on the knee. So that way I can first just stabilize that foot and I can ask the patient to step up with the unaffected leg on the other stair, practice that movement, and maybe then with the affected side and then the complete stair climb.
See, one hand is right. If you go at the ankle, who is going to manage his upper body? He's going to fall or he will be scared because you are focusing so much downward. Your whole body is bent downward and his upper body is free. So he will not be very confident to do that way. One hand is wrong.
Sir, if I'm using my leg, actually I have one same patient whose leg is completely hypotonic. So in that patient, the stair climbing, what I do is basically I use an AFO for the limb, dynamic AFO, and using my leg, how do I explain this? Okay, so with my knee, I'll control the knee position. Basically, I place my knee behind the patient's knee and
behind or sideways?
Sideways and behind, basically posterolateral aspect way.
Mm-hmm.
And then with the hand, I support the upper limb and the upper body, and I try to propel the weight ahead on the leg, and then ask the patient to climb the stair. So that gives me a better result. That is what I felt in my patient. So, is it the right way?
Yeah, it is the right way. But basically, only if you require more assistance, then you need to give that much. Otherwise, no need. Like there are other solutions. Like Sonia has partially done this, but she's not giving too much of assistance. Like look at where is left hand of Sonia is going. So she's touching the hand. This is what, see, when she pushed here, look at this now. That is the treatment strategy. She she's supposed to so much adduct the hip. The more she puts the knee into adduction, the foot will become more aligned here. Okay. And he will get more weight bearing through that. And the right hand, I think she's kept on the pelvis here. And that is also a very good strategy. Like no, her hand is here. So never hold the hand like this is the paralytic hand. Never hold the paralytic hand. If he falls, this is your anchor point and we will call dislocation. The right hand should be on the pelvis here on the opposite side. And this is here. So you get a compression from right to left. Now watch this. Raju. So right by also. So what is supposed to be done? Now this is a small step. We'll show you the large step also. The therapist stands behind. Left hand is here on the pelvis. Right hand is on the knee. And my left shoulder is on the trunk. So look at this 3-point pressure. So I am now rigid, stable here. So this is how I am supported here. So this hand gives pressure from this into the right leg. So this is how. So I get a good pressure here and I can support here also. And if this is the paralytic hand, this can hand here or you can let it be like this and now step up. Up and down. So this is how we can align. So most commonly what common mistake therapist does, instead of keeping the hand above the knee, they go below the knee. And when you do the below knee position, the person basically go just you go like this, because always remember human behavior. If you give support anterior to the tibia, the person will keep going forward on the tibia. You don't want that, okay? I will show you the higher stepper one sec. So your hand should be above the lower end of the thigh, not on the tibia. Why?
So tibia has to translate forward to step up. So if by keeping the hand down, we are blocking that movement, what naturally should happen.
Sir, we are also stretching the
No, we are
quadriceps to
not blocking
contract.
actually. We are allowing that movement. Blocking is not the problem. Yes, Somnath, or what was that? Vikrant?
Sir, we can facilitate the stretch reflex to contract the quadriceps here.
Sorry?
We can facilitate the stretch reflex for the quadriceps to step up.
Step effect नहीं समझा मुझे.
Stretch reflex, sir. By putting
Stretch reflex. No. Stretch reflex नहीं. Always, guys, stretch reflex is not the solution in this kind of situation. We use only stretch reflex for initiation of movement. Whenever you go for such a complex movement or large movement or very movement, stretch reflex doesn't work here. But there is something else works here.
So you
always remember this. Right leg up.
Compression knee to ankle.
Very good. Compression.
Knee to ankle.
Compression. So which direction I will get a compression?
Vertical downward, sir.
This compression is good or this compression is good?
Sir, towards the ankle.
Towards the ankle.
Yes.
And if you go this way, this will give either this will push the patient backward and the patient will feel unstable. If you stop this movement, like suppose this will go like this. So if you keep below the tibia, okay. But if I look at my hand position, so you keep here and press into and this direction into the hip and the ankle also. We can go both way. So the left hand is from left to the right hip, knee, and from right to the foot. So this is how we get there. And this is how by giving compression you are like what is happening when you are stepping. Basically you are getting compression here and the body moves forward. By pushing through this, what are you giving stimulus? Compression in the knee and ankle. So knee and ankle, knee and ankle, knee and ankle. This will not give you compression. You are taking away the compression from the joint. So this is the position. Go upward and downward. Go upward and downward. What Sonia is supposed to do, because the leg is going outward, just put into adduction, hand here and compress. This is what Twinkle was trying to tell you, that we'll just work first here, step up, step down, or what Twinkle did, she kept the knee like this and then go. Okay. By keeping the knee sometime behind, you stop the extension momentum. So keep sideways, and you don't need to push also. Just keep sideways. It is called as constraint. So you don't allow the tibia to go sideways or knee to go sideways. You may not push it. You just hold it here and just go upward. So you give a constraint that the tibia doesn't fall out. Make sense?
Yes, sir. So this is what I exactly did in my patient.
If the ankle is very clear, the knee may go in also. So in that case, you have to hold like this and go upward and downward. Make sense?
Okay, sir.
Yes, sir.
Sir, point of compressions initially would be the great toe, then it should be to lateral malleolus, no? Towards the lateral malleolus.
नहीं, great toe कभी भी नहीं रहेगा अपना point of compression.
No.
Ankle.
You are compressing towards the great toe. Once the patient is going forward, that time your
great toe नहीं बच्चा. Great toe बहुत आगे हो गया. Great toe पे compression बहुत rare जाता है. It is only going to the hind foot, mid foot, or the ankle. Unless and until your foot is in little bit plantar flexion, then only it will go up to the great toe. Otherwise, the you may say direction is towards the great toe, but the compression is not going to the great toe. Okay.
I am saying the direction of the foot towards the great toe, then it's towards the lateral malleolus.
No, I don't. I use this both the word because they can be misguiding for students. So if you say towards the great toe, they will think that I have to give compression in the great toe and they will cause more stimulation of great toe and it will cause extensor spasticity. You say going towards the ankle, compression towards the ankle, or you say midfoot is better, safer word. So there is a less chances of error.
Okay.
So whenever you are using this kind of clue, maybe the direction is looking towards the great toe in the beginning, but the more it extends, it keeps on shifting backward. So the word is only towards the ankle.
Okay. Okay.
Okay. So the point I was trying to make here is that we require a lot of muscle external forces. They are the forces which are responsible for contraction or not contraction of some group of muscle, and they are the biggest stimulant of muscle contraction. And we think our brain is required for muscle contraction, but I assume and I believe that we don't require brain to do most of the activity unless and until it is a new movement or a complex movement. Manasi asked me what is motor learning yesterday. Manasi, are you there?
Sir, I'm there, sir.
Okay, so understand there are two words. What is called as motor learning and motor relearning. So motor learning or we require guys, everyone please put on mute. Mute kar sakte. क्या बता रहा था? हाँ, learning and unlearning. Sorry, relearning. Motor learning only requires, or we require cognitive learning only when we are guys one sec, सब लोग notation कर रहे हैं कुछ ना कुछ. How do I stop people from doing notations? Notation must stop करो. Okay. Okay, so we require motor learning only when we are cognitively involved in something which is new and complex. Then only we require motor learning. Other thing is all motor relearning. Whatever is there, we are just relearning it. Okay. So in day-to-day activity, we require cognitive functioning or your brain to be get involved only when you are in a new environment, new situation, new activity or more complex activity. Then only brain will kick in. Otherwise, most of the things are acting at a subcortical level. Understand the word subcortical. That means we are not using our brain, so-called the intelligent brain. Whatever we are using is the hindbrain and the spinal cord, which is acting at a subcortical layer. You don't require analytical thinking for that. It only acts in response to what is the alignment of the gravity, line of gravity, orientation, alignment of different joint with respect to each other, what is the muscle alignment with respect to joint. Based on that, the muscle will automatically act. Okay.
Right, sir.
So look at this example. So based on where is the movement arm, accordingly muscle work will change. The green part is showing the center of gravity, and this is the alignment. If it goes forward like this, so the ground directions forces will push into extension. So the foot or AFO is going to create an extension movement arm here. Or if there is a foot is flail, it will create a flexor movement arm. So based on the mechanical support or not support, your movement arm will go into flexion or extension. Like if this AFO is rigid, it will create extension movement arm. And if the foot is flail and it doesn't support the tibia forward, the body weight will try to bend the knee and move the tibia forward, and it will create a flexor movement arm. Or if the center of mass shifts backward like this, it will also create the flexor movement arm. So this is what we are trying to study here. Whenever you land or initial contact, the line of gravity passes behind the knee, and that is why our quadriceps are required. Earlier I already told you one of the mechanism how to understand which muscle work. because it line of gravity falls behind, the knee is supposed to buckle. So which muscle will stop from not buckling?
Quadriceps.
So
Quadriceps.
yes, the line of gravity is forward to the hip. Which muscle? So the line of gravity is creating flexor movement arm.
Glutes.
So the muscle has to create a
Extensor.
Glutes.
extensor movement arm. So movement. Sorry. So basically, based on the gravity line, we decide to create a opposite force, or we may not decide to create. Like suppose the line of gravity is falling anterior to the knee, and here what movement it is creating? Extensor. And what movement we require there is extension. So do we require quadriceps there?
No, sir. No.
Yes, sir.
No,
We
sir.
don't require quadriceps.
No, sir,
because
nothing. Static.
the extension part is carried by
Line of gravity.
line of gravity. Okay. Or here you can see that the here line of gravity is falling behind the knee. So the extensor movement arm is created in the hip is extension. So do we require hip extensor to create extension?
No.
No.
No. So you understood how I am trying to tell you that we do not require muscle work to actually walk in most of the time.
Right.
Yes.
Mainly in mid stance.
Sorry?
Mainly in mid stance it's given.
No, we'll talk about. Example अभी mid stance की दिए है.
Right, sir.
We'll talk about that. So larger the movement arm, line of gravity more backward, more muscle work required. Lesser the movement arm, less muscle work required. So like in crouch patient, they require more quadriceps and plantar flexor work and hip extensor work, whereas less crouch, less muscle work required. Or if the line of gravity goes forward, we don't require any muscle work in quadriceps. Okay. So this is how the crouch people will be like this. By giving a AFO, you are creating a extension momentum. The line of gravity was here. It passes through the knee or anterior to the knee. So FRO, static UFO will get the line of gravity through the knee, and FRO will get the line of gravity forward to the knee. Are you with me, guys?
Yes, sir.
Yes, sir.
Now we are going to study different muscles, muscle work at different angle. So the lower part is showing the angle of hip, knee, and ankle. This is hip kinetics. This is the newer classification. IC is initial contact, loading response, mid stance like this. Okay, terminal stance. This is how the different phases here. And here we are going to study from initial contact to the loading response. So for initial contact from here to here, we are going to go like this. Okay, here to here. Okay, so look at this. So at initial contact, what was the hip range? 30 degree. So from 30 degree, we move to 20 degree here. So what movement happened, guys?
Extensor movement.
Extensor movement.
Extension.
So a movement happened is extensor. Okay, which muscle are supposed to work in this position? Loading, initial contact to loading response.
Quadriceps.
Extensors.
Hip extensors. Hip extensors. Don't use word quadricep or that. You say only extensor or flexor. Okay.
Okay, sir.
So you will require what muscle working here will be?
Hip extensors.
Hip
Extensors. So movement happened is extension and muscle working are extensor. So type of muscle कौन से direction?
Concentric.
Because it is same direction.
Same direction.
Direction. This is the direction. Okay. Same direction. So concentric. Understood?
Yes,
sir.
Now from 0 to 15 degree, movement happened is
Flexion.
flexion. And muscle working are
Extensor.
because you are in bed bearing. So direction will be
Opposite.
opposite. The type of muscle contraction?
Eccentric.
Very good. Now ankle. Now ankle moves in two ways. Okay. First it goes in extension and then followed by flexion. So from 0 it goes in 15 degrees of extension. The movement happened is
Extension.
and which muscle are supposed to work?
Extensor.
Eccentric dorsiflexor, sir.
No, but which muscle? Dorsiflexor. Why dorsiflexor?
Eccentric towards ground, sir.
Yeah.
No, I understood that, but why dorsiflexor? Fundamental principle कौन सा यूज किया हमने?
लोडिंग फेस में है.
Wait one sec, guys. See, because initial contact to loading response. So because the foot was in the air, that is why the dorsiflexor contracted there. Okay. The moment the foot will touch, extensor will contract, because the first fundamental principle I told you, whenever you are loading, flexors, loading extensor work and unloading flexors work.
Flexor.
Okay. Because we are here, because the foot was in the air, from the air it is going down, which is extension. So from neutral it is going to plantar flexion, that is 15 degrees of extension. So because the movement happened was extension, but the muscle, because it was in the air, flexor. So the direction of movement will be
Opposite.
So type of contraction will be
Eccentric.
eccentric. So from now 15 degrees of extension, we are going to 15 degrees of flexion. So movement happened is
Flexion.
muscle working,
Extensor.
Flexion.
by extensors.
Flexion.
Loading.
Plantar flexors.
Okay, anybody says flexors are working here? No. Why extensors are working here or plantar flexors are working here?
Loading.
Because loading. Perfect.
Loading.
So loading, extensors are working. So now the direction of movement is
Opposite.
Opposite.
so type of muscle contraction.
Eccentric.
Easy.
Yes.
Yes, sir.
So if you know the kinematics, you can know what is muscle work. आपने को already पता है which muscle are supposed to work. You have to just find out what direction and you will understand what is the type of contraction. Make sense?
Yes.
Easy. Anybody has any doubt? Next. So now we are going to from loading response to mid stance. Okay. So for loading response to mid stance, we moved from 20 degrees of knee flexion to 5 degrees of knee flexion in mid stance. So movement happened is
Tension.
extension. Okay. So which muscle are supposed to work here?
Extensor.
Extensors. And type of muscle work will be, so because what is the direction here? Opposite or same?
Same direction.
Same. So type will be
Concentric.
concentric. Now here from 15 degrees of flexion we move to the 5 degrees of flexion in the knee. So it is movement is
Extension.
Extension.
who is supposed to work?
Extensors.
Extensor supposed to work. So type of muscle contraction will be concentric. In ankle, movement happened is 15 degrees of flexion to 5 degrees of flexion. Movement happened is extension. Muscle working are
Extensors.
type of muscle contraction concentric. Okay. But why there are two red cross there on the hip and knee? Anyone?
Line of gravity comes into picture. Line of gravity comes into picture.
Perfect. So you guys are now attending. So as I said, from loading response. So this is initial contact, plantar flexion, loading response. We got here. From here we are going straight. So now what happens? Because gait is a momentum, it is continuously happening like this. So at hip, we were 30 degrees of flexion, going to 20 degrees of flexion. From there, we are going to 5 degrees of extension, flexion or 0 degrees of flexion. So here we got extension, but this extension is not actually caused by extensors concentric contraction. Because we are in momentum like this, the upper body, which is a passenger, is in motion, it itself will push you into extension. Or there is a continuous movement like this, the hip extension is caused by momentum. Which force we are using here?
Gravity.
Momentum. Okay, not gravity, momentum here. Okay. In knee also, from here we gone into extension. So here also the knee extension is caused by momentum and the line of gravity which is helping you towards the extension. So hip and knee extension is passively caused, not by any muscle force. Okay.
Sir, I have a doubt.
Clear?
Sir, I have a doubt.
Yes, go ahead, please.
So momentum happens only with fast movements, or does it happen even if the patient is walking slow? Momentum normally happens with quick movements, right? Like fast movements.
Yeah, you are absolutely right. It only happens with when the momentum is created, like you are in a fast movement. Most of our hemiplegics, they walk slow or they don't generate momentum. Like after every step, they stop.
Yes.
The moment you stop, the momentum is gone. So in our hemiplegic, that muscle contraction is required.
Yes.
Okay. Next. So this is where from here the hip is moved into extension and knee also moved into extension. So it is the momentum which caused the extension of hip and knee, not the contraction of quadricep. Clear?
Yes.
Yes,
Sir.
sir.
So now mid stance to the terminal stance. So from 5 degree, we move to minus 20 degrees of hip extension. So
Concentric.
नहीं sequence तोड़ना नहीं है विक्रांत.
Yes, sir. Yes, sir.
Movement
Movement
happened
extension.
Movement happened
Extension.
Which muscle are supposed to work?
Extensors are working.
Extensors. Muscle work will be
Concentric.
concentric. Very good. Again knee. Movement happened is extension.
Extension.
Extensors are working. So again concentric. Ankle. Movement happened is extensors and muscle working are extensor concentric. So all are concentric, but again two red zone here. Because the body is moving in the momentum forward, because of the weight of the body and the gravity, it falls forward because it is the momentum plus gravity. The hip goes, it is not the tibia going backward, it is the pelvis going forward. And because the pelvis is going forward, hip goes into extension. So again, this extension is not caused by the hip extensor or the quadricep. Are you with me?
Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir.
Now terminal stance. Terminal stance to the pre-swing. The word itself, pre-swing, means we have to prepare for the swing. So from 20 degrees of flexion, we move to 0 degrees of flexion. Movement happened is
Flexion.
Extension.
flexion. Extension.
Flexion.
Minus 20 से 0 आए हम लोग.
Yes, yes.
Flexion. Muscle working are
So flexor.
Flexors.
we are
Flexion.
still loading. So we are in still weight bearing. So which muscle are the
Extensor.
extensor?
Okay.
So type of muscle work will be
Concentric.
eccentric. Opposite direction.
Eccentric.
Eccentric. Okay. Again, from 0 degrees of flexion to more degrees of flexion. So movement happened is
Flexion.
flexion. Muscle working are
Extensor.
Extensor.
Extensors.
very good. Extensor. So type of muscle contraction will be
Eccentric.
eccentric. From 0 degrees of flexion to minus 20 degrees of flexion. Minus 20 degree extension hoga, sorry. So movement happened is
Extension.
extension.
Flexion.
Which muscle are supposed to work?
Extensor.
Extensors. So type of muscle work will be
Concentric.
concentric. Now here again, you can see that there are two red arrows. So from mid stance, we move to the terminal stance, which is here. And from there, we are going to the pre-swing. So this was the position. From 20 degrees of hip flexion, we move to 0 degrees of hip flexion. From 5 degrees of knee flexion, we move to 40 degrees of knee flexion. So again, this action is caused by,
Momentum.
sorry,
Momentum.
no. See, look at this. From
Pendulum.
Pendulum. More than pendulum.
Gravity, sir.
Gravity.
Gravity.
Gravity is the force which is pulling down. So because this goes down, it is gravity and momentum is basically putting the hip into extension. So I call this Ganpat Patil position. You know Ganpat Patil about that tamasha wala,
Natrang wala, sir.
natrang wala. So Ganpat Patil always. So I call this is let go position. So we don't actually contract any muscle. We let go. We allow the body to fall. Or I call it Ganpat Patil position. So whenever Ganpat Patil, he doesn't contract, like he's not contract eccentrically and then going. Whenever you see Ganpat Patil, he's always let go. Okay, so it is let go. So let go is carried by gravity and some momentum because hip is gone forward. So again, the hip moved from extension to flexion is due to gravity. From knee flexion or extension to flexion, it is gravity. Okay. But here we require plantar flexors. So the push is given by plantar flexors. So that is there, but we don't require knee and hip control or contraction. Okay. So you can see that from this position, it is falling mechanically into flexion. So it is a let go position. Okay. Are you with me?
Yes, sir.
Yes, sir.
So again, we can see that after loading response, hip and knee were zero. They were not acting at all. Only plantar flexors were acting. Otherwise, you can see that all three phases I shared, no, 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 no. Okay. Now pre-swing to the initial swing. So from pre-swing 0 degrees of flexion to 20 degrees of flexion, movement happened is
Flexion.
Flexion.
which muscle are supposed to work?
Flexor.
Flexors.
Flexors.
Concentric.
Type of contraction?
Concentric.
Concentric. So from 40 degrees of flexion, we move to 60 degrees of flexion. Muscle action, movement happened is
Flexion.
Flexion.
flexion. Muscle working?
Flexor.
Flexors.
Flexor.
Concentric.
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 Again, from minus 20 degrees of ankle, which is in plantar flexion, to less plantar flexion. Movement happened is flexion.
Flexion.
Muscle working are
Flexion.
Flexors.
bearing, weight bearing,
Dorsiflexors.
flexors. So dorsiflexors, we are going off now. We are in the air. So it is flexors because we moved from pre-swing to initial swing. So flexors. The type of muscle contraction is
Concentric.
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 So again, here I said no contraction here. Why?
So because the hip movement will automatically help in knee flexion, the momentum that is basically resulting.
Absolutely right.
Propelling.
So understand this. From here, we look at this. The more I cause hip flexion, we automatically go to flexion. Everybody go on mute, please. Hold on. Okay? Because see, I am not doing anything to the knee. By just mechanically pulling this upward, what is happening? Knee flexion. So the knee flexion, which is 40 degree in initial swing, because hip goes into flexion, because of the pendular action, this goes into flexion. Okay? So the more hip goes into flexion, knee goes into flexion. Here, body, walking body, full body.
So can you please repeat?
See, because hip goes into flexion, from 0 degree, hip is gone into 20 degrees of flexion. So the knee goes into 40 degrees of flexion. So this action is because of pendular. So, Raju, तिकडून दोन पेन घेऊन ये रे. दोन पेन. ढक्कन घेऊन आहे. सोबत ढक्कन असलेला पेन. So basically, see guys, I keep this into flexion, okay? And if we don't require something to flex this because this is a pendulum action, the more you flex the knee, hip, the knee will automatically work as a pendulum into vertical position. It will be always like this, okay?
Sir, somebody is waiting. Yes.
Sorry?
Somebody is waiting for the Zoom.
Somebody
He is waiting.
What is it?
Waiting.
Waiting.
Waiting to waiting room.
नहीं कोई नहीं वेटिंग कर रहा है. चार्ट आया लगता है किसी का तो.
Bidat, yes, something. Yes.
नहीं आया.
No, I'm in, sir.
You are in, okay.
Yes.
Okay. See, watch. This is the hip position right now. Suppose this is the hip segment or the femur segment. The more I flex this, what is happening to this level, this leg? It is going to flexion. So neutral, 20 degree flexion, 40 degree flexion, 40 degree flexion, 60 degree flexion knee. So the more the hip goes upward, the knee goes into pendular action and goes into flexion. Are you with me?
Yes, sir.
So whatever the knee flexion we get in swing, it is caused by
Hip flexion.
Active hip movement.
So do we require knee flexor or hamstring for swing phase?
No, sir. We need hip
No,
flexor.
sir.
But traditionally, what we train for swing phase?
Hip.
Knee flexor. We
flexor.
say
Yes.
hamstring is weak, that is why the knee is not flexing. Where should be our treatment protocol more focused on?
Hip flexor.
Hip flexion.
Do we ever treat hip flexor in standing?
Yes, sir.
Yes,
We do
sir.
a lot of knee flexor strengthening, hamstring strengthening, but we do SLR in supine, which is not required. But we don't do hip flexors in standing more frequently. I'm not saying don't do it, I said more frequently. Like we do sometime, we teach them to do the stepping, but I said if you want to strengthen, really strengthen the hip flexor more. Okay, the more you get more hip flexion, your command, I don't tell the person to do the knee flexion. My command is bend your hip more, and knee will automatically bend. Are you with me?
Yes, sir.
Yes, sir.
Yes, sir.
Okay. So that is why I said we do not require quadricep here. So pre-swing to initial swing, we don't require that. And from this is why, because the pendulum, the more hip goes upward, the knee goes into flexion. Understood this? Make drawing 1, 2, pendulum. Okay. So the more the hip goes into flexion, knee automatically goes into the flexion. Okay. So training the swing limb, you don't require so much of hip flexion, knee flexion here. Now initial swing to the mid swing. So the initial swing 20 degrees, we get more flexion. So from less flexion to more flexion. So from 60 degrees of flexion, we go to the less flexion of the knee. From more flexion to the less flexion. Okay. So look at this. What movement happened here is
Flexion.
muscle working are
Exerts.
so type of muscle contraction will be
Concentric.
guys. Concentric. Okay.
Concentric, sir.
Concentric. Barabar hai. From 60 degrees of flexion to 30 degrees of flexion, movement happened is
Extension.
muscle working are
Flexor.
flexor. And type of muscle contraction will be
Eccentric.
eccentric. But again, it doesn't happen because again, pendulum mechanism. So, see, I told you, if the hip goes more into flexion, you get more flexion. Now, because from 20 degree to 30 degree, ulta hua hai kya? So the more hip goes extension, ulta ho gaya hai, from more flexion to less flexion. There is some mistake, guys. Let me correct. I will tell you in next lecture. So basically, the more you go into hip flexion, knee goes into more flexion. Unless the hip flexion, knee automatically goes into extension. So the knee extension which has happened is mechanically again, and we don't require muscle work there. Hip ka kinematics kuch galat hua hai mera. I will check in the book and then confirm with you. Okay. So ankle, because it is neutral, from minus 10 degree it goes to 0. So it maintains into flexion, and in the beginning you require concentric. From initial to mid swing, it is all isometric then. So this is the typical pendular action which happens here. So more the flexion, more the knee flexion. Okay. So hip remains into 30-30, no movement. So no muscle work will be, which muscle work will be working here?
Flexor.
Flexor. So type of muscle contraction?
Isometric.
Isometric.
Knee gone into 30 degree to 0 degrees of extension. Movement happens. Extension. Which muscle are supposed to work now?
Flexor.
Flexor or extensors?
Flexors.
Actually, because the leg is in the air, it's supposed to work as a flexor. But the movement actually happens against the gravity. So that is why it is extensors coming in the beginning. And concentric type of contraction followed by eccentric of hamstring.
Right.
Okay, or that is called a check mechanism. In ankle, there is no movement, so flexors working asymmetrically. So let me explain this contraction. So from mid swing, initial swing, mid swing, we go here, and now tibia is here. So from there, we have to go against gravity. The movement is happening against gravity. So that is why the quadriceps come into picture here. So this is the only exception. The foot is in the air, but the movement is happened against the gravity. That is why the extensors are working. I told you the fundamental principle. Whenever you are loading, extensor work. But because here we are unloading, but the movement is happened against gravity. That is why the extensor came into picture. And here, if the extensor work too much, the tibia can go forward like this. So to stop that, at the end, the hamstring come into check mechanism as a eccentric quadricep and initial contact. So from there, we go to initial contact. So quadriceps work only terminal stance and initial contact. So they keep continue from the terminal swing into the initial contact. So the quadricep action continues from terminal swing to the initial contact. That is the only area we require quadricep. Throughout the gait, quadricep is silent. Are you with me?
Yes, sir.
Yes, sir.
So this is because the movement is happening against gravity. We require quadricep concentric contraction. Okay. And the I don't want, because of the pendular action, because it was in motion, as I told you earlier, the tibia was movement because of pendulum. So if there is too much of pendular action, it can go into extension. Like if you have seen, if you have any of you have seen a mechanical below knee amputation, in that this pendular mechanism occurs a lot, and the tibia moves too much forward. So to stop that, we require hamstring as a check mechanism. Okay. So we require eccentric hamstring. So muscle work. Now see how which muscle works where. So hip extensor, they work from initial contact up to the mid stance, which is being shown in earlier. But if the movement is strong enough, we don't require from here to here, we don't require hip extensor. Okay. If you are in motion, hip flexor, they require from pre-swing up to the terminal swing. Okay. Quadricep, we require only initial contact to the loading response. After that, it is shut off. Again, pre-swing. Basically, this muscle contraction only continues here. But from loading response up to the mid-swing, we do not require quadricep. Like a lot of people, when people are not able to do good mid-stance, we blame quadricep is weak. But actually, we don't require quadricep for mid-stance. Okay. If you are having a good momentum with a walk with a good momentum. Knee flexors, where do we require knee flexor? Only for the check mechanism at the terminal swing. Do we require knee flexor for the mid swing? You can see that whole swing phase we do not require hamstring. Ankle plantar flexor, they start after the loading response and they continue up to the pre-swing. And after that, the quadriceps, plantar flexor are not working. Ankle dorsiflexor, first eccentrically here, and then from pre-swing, it will be all concentric. And in the end, isometric. So if you look at this, quadricep only require for initial contact and terminal swing. Hip extensor from initial contact to the mid stance only. Hip flexor from pre-swing to terminal swing only. In all the graph, the maximum part which is contracting continuously throughout is the ankle. If you can see this, you require continuously either ankle plantar flexor or dorsiflexor are continuously working. So the most important muscle for walking is, or joint which is most important for walking for muscle contraction is
Ankle
and hip.
And the most neglected joint in treatment is
ankle.
So now do you agree with me that why we are going wrong in hemiplegic treatment?
Yes, sir.
This one day, sir.
How many of you have understood this mechanics with this perspective? Earlier, have you studied this same thing with this perspective?
No, sir.
Sir, during the college days.
No, to contract or not contract wala concept.
Sir, never.
We never thought
I've just studied the theory. We never applied it like this
Sir
way.
never understood actually the concept. Now something it went inside the brain.
सर नॉर्मल ह्यूमन बीइंग में मतलब स्टडी किया था, ऐसे हेमिप्लेजिक में नहीं किया था।
ये हम लोग नॉर्मली कर रहे हैं, अभी तक हेमिप्लेजिक को टच नहीं किया बच्चा। हेमिप्लेजिक अगेन वी हैव टू वर्क because hemiplegics they walk, how do they walk?
No momentum.
They walk slow.
Slow.
If they walk slow, do you think momentum will work?
No.
No.
So if the momentum doesn't work, this application goes haywire. That means they have to walk, they have to work a lot of muscle. So what is the treatment solution, guys?
So either to improve the momentum, to make them walk bigger step, or we can improve the muscle work.
Okay, what will be more feasible?
So basically we focus
Momentum, getting momentum.
Or increasing the speed will be more feasible, and that is how normally people walk instead of getting the muscle work. Can you get the muscle work in 1 and 2 days?
Not at all.
No,
In 1 month?
No.
In 6 months?
Maybe.
Not-
It's very
not easy.
difficult.
But can you get the momentum day 1?
Yes.
No.
Yes, sir.
Yes, sir,
Yes.
sure,
Yes,
sir.
Yes.
Sure, sir.
Somebody said no. Why no?
Get it.
It's okay. Who said so no? You can give your analysis.
So we can give our commands that way.
Command will not work, bacha. You have to, the logic, you have to increase the momentum. How is different question?
Increase the speed. I mean,
Speed, increase the speed.
yeah.
So how can you increase the walking speed?
Long step, sir. Long step.
Long step or kuch option?
So treadmill.
Treadmill, sir.
Treadmill or assisted walk, fast assisted walk. Like when you say, Vikrant, bigger step, it is probably affected who got little bit trunk control. If they don't got trunk control, probably taking bigger step is not the solution. Like this girl's patient, Sonia's patient. He may not able to generate fast momentum. So what is the solution?
Treadmill.
Treadmill.
With
Or
harness.
harness. Or I use assisted fast walk.
Body support.
How do I do the assisted fast walk later? Like if you don't have a treadmill, don't say that I don't have a treadmill, I cannot increase the speed, I cannot increase the momentum, so my patient will take more time for recovery. You can't complain like that, okay? You need to find solution how to increase the speed.
So parallel bars will be secured, no, for the patient.
Okay. How many of you want to use parallel bar in hemiplegic?
So I don't want to use. Maybe his hand is also affected, sir.
Yeah, hand is also
How would he?
affected. So
How would he use
he-
his other hand for the holding?
एक hand से भी parallel bar use कर सकते हैं, ऐसा नहीं है कि नहीं कर सकते.
No.
Okay.
So then he'll learn the different strategy altogether by giving more weight on the normal side if he keeps on holding the normal hand.
So his mind will be divided in more things like holding parallel bar, walking.
Human behavior. I told you human behavior and support का concept. What was the human behavior and support concept?
Take more support.
Bend more towards the support.
Less
More
work.
towards the support.
The
Less
more you
work.
give support, they go more on that supporting side.
More on that side.
Okay.
Yeah.
Now in support also there are different variations of support, such as parallel bar is called as a fixed support. He can pull, push, do anything, and nothing will happen. Walker is also support, but is it a fixed support?
No.
No.
He cannot pull. He can push very well, but he cannot pull. Or cane is a stable support? No. So whether you are giving type of support, you need to classify them with fixed support or not fixed support.
So can we give caster walker, like a walker with wheels, to improve the momentum? Like
You may do that, but his body has to cope with that momentum. His stability is not going to be good.
सर साथ में हम भी रहेंगे ना, like we'll be also be.
हाँ वही बोला assisted walk, हमें उसको assisted बोलता. Yes, you can do that, but walker ही सब कुछ नहीं होता बच्चा. कभी-कभी dynamics of walker is not the problem. It is the dynamics of the person and the therapist who are.
So what about backward walker?
Backward walker.
Walker position.
Back walker. You mean back walker?
I mean, yeah, right. Yeah. I'm sorry.
Okay, hemiplegic we don't use
Posterior
posterior walker. I use posterior walker in cerebral palsy child or some head injury or some ataxic patient. And there is a different biomechanics related to posterior walker. If you want to know, I will tell you.
Please tell.
Sir, in
sure.
basic.
When the child walks
Sir,
with hip out.
sir, could you please complete that?
So again, I'll always remember human behavior. Never answer the question unless it is asked. So because nobody is asking, I was keeping
Sir, I
quiet.
said so sure. I wanted to know about the posterior walker.
Okay. Biomechanism of front walker and back walker. Okay. Whenever you use the front walker, look at my hip joint. Okay. What is the alignment in hip joint when I use the front walker?
No, hip is a
Extension.
Extension.
Any walker always introduces flexion. So whenever you walker, you are introducing hip flexion. Okay, because this is how we walk. So the hip is always in
flexion.
And if somebody has a hip extension, you will correct. So if you allow that hip flexion, if you allow that deflection, either he will collapse or he will take too much lean on the front walker. So in some patient, I don't want front, his hip going into flexion. By back walker, what happens? Hand goes behind, trunk goes behind, and what does it introduces in the hip? Hip extension. If I want somebody's hip extended bones, I use a back walker or I use a forearm walker. So normal walker will introduce hip flexion, but if you use a forearm walker, that will introduce you hip extension. Especially this principle is very important in quadriplegic or high para because they cannot stand like this or para they stand with hip extension. So if you want hip extension, give a forearm walker or back walker. Like all our cerebral palsy child, they have this flexion component, and this is how they walk. And if you give a flexor or forward walker, you are actually asking them to flex the hip, and then you complain therapist. Oh, you tell the therapist, patient, extend your knee, extend your hip. And how can he extend his hip if the supporting surface is forward? The patient is not doing wrong. It is the therapist who is doing wrong by giving flexion walker or forward walker and expecting him to extend the hip. So what will the CP child will do? Even if I go inside, I cannot still extend my hip. My hip is still in flexion.
Right.
So if you want hip extension, give a posterior walker. Imagine the moment he takes the step, you get extension. Like suppose I take a step from this side, see extension here.
So, but I think this is more unstable.
No, because this walker is not a posterior walker. This is a step walker.
Yes.
There are set. Hold on.
Thank you.
Whenever you use posterior walker, we should only use rollators as a posterior walker. Don't use this 1990 straight walker as a posterior walker.
So the walker with the wheel.
Sorry?
The walker with the wheels.
Yeah, walker with the wheel. There are only two wheels and they are inclined like this. The base is larger here and stable. I show that he's getting the rollator walker. They are called as rollator walker. They are always stable, and in safety child, for any safety child, always give rollator walker, not the stable walker. This 1990 walker. This is the rollator walker. So it has only two front wheels, and it can have back wheels or no back wheels. Okay, so you can see that the posterior wheels they can rotate, but front wheel are only unidirectional, and this wheel change can be changed from backward front. Now this walker presently is designed for front walker. Okay, this is how it can be used. But if I want to use as a front, posterior walker, the unilateral wheel will go backward and the multidirectional wheel will come forward. Or you can use this multidirectional wheels like this also. If the person is stable, then he can walk like this. If the person is not stable, okay. I will repeat again. ये बंद कर. ऐसे mute है. Okay, watch this. So if the person is stable and he can manage, you can use multi-directional wheel in front. But if the person is not stable or ataxic, do not use multidirectional wheel. Use unidirectional wheel, and then he can walk better. So if you look at my hip, now because this itself by shoulder going backward, it will get you extension. But when I say extension, it is not hyper extension. Okay, it is trunk going into extension. So my extension of the hip and trunk works better. But the moment, like in bridge principle, if you are here, anterior group of muscle work, abdominal work more. By going here, the bridge principle, the back extension will work. Okay. So posterior walker is better for cerebral palsy child than the front walker, because all our CP child, especially the child with 4+ age, we should use posterior walker, not the front walker. Okay.
So then the muscle work, everything just changes, right? If we are using the posterior.
Okay, sir.
Yes. If you, the beauty of posterior walker, it will activate hip extensor and back extensor more.
Okay, but sir, to create the forward propulsion, then do they have to work more because your body weight is falling backward and your line of gravity will also fall back?
Pratiksha, I must appreciate you have used a very good important point, because by bending forward, your actually line of gravity falls forward. But by going backward, your line of gravity is falling backward and momentum is reduced.
Yes.
So, that is where you have to make a choice. Do you want the moment to use into picture or not to use in the picture? Okay. So the best way to answer that, give them both options. If they are fast enough or their efficiency is fast enough with the front walker, give front walker.
So like this can be used to reduce the speed as well. I'm just asking.
Yes, it can be used as a reduce, like in ataxic. I want them to reduce the speed. Like most of our ataxic, they do this way. So when of the ataxic with your front walker, they lean like this.
Yes.
And they move too much forward. But the moment you give as a posterior walker, even they want to lean backward. See, this doesn't allow me to go backward. I can only go that much. So this will, or some of the CP children, they go too much backward. So I use posterior walker. So it stops their backward movement also, and it gives them a base of support, and they can walk better like this. But as you said, the momentum is gone here.
Yeah.
So in Gait, you have to make a choice. What do you want to improve? If you want to improve the speed, efficacy, and mobility from one place to another, probably posterior walker is not a good choice. Then you have to use anterior walker. But in anterior walker also, you can do one more thing. Instead of going low, increase the height of the walker or give a forearm walker.
Okay. Yeah, yes, sir. But sir, one problem which I generally encountered is if I increase the speed, if I increase the height of the walker, they tend to fall back, like because they are not able to give weight. So
no, see, when I say height of the walker, ataxia mein nahi karna hai.
Yeah.
Basically, this only matters in CP and para, not in hemiplegic. In hemiplegic, we don't give walker. Like for me, this is a very heighted walker. This is a better walker. So you should have only 20 to 30 degrees of elbow flexion. If you are getting too much of elbow flexion, so that means it is a high walker. For my height, this is a high walker. The beauty of this walker, because it is high, I cannot rely on the upper limb. So I have to manage my balance on my own. So if I have to manage my balance on my own, that means I go backward. Okay. So this is how, when you give high walker, your CP child will go like this, because now they cannot no longer rely on the upper limb. Whereas a low level walker, if you give a CP child low level walker, they will rely like this. Okay.
I'm just thinking one thing, sir. We can definitely use this high walker concept when we are progressing with the patient from like reducing the reliance on the upper limb, like even in the spinal cord.
If that is your objective.
Yeah. Okay.
You can have a different objective, or if your objective is not to do that, then don't do it.
Yeah.
You have to decide what is your objective. I am just showing you the assisted walker or forearm walker. Sorry, one sec. clarity of this video is very bad because this is very old video, and that time the mobile camera was 2 megapixel only. Okay. So this is a forearm walker. He is a para patient. So the more he bends, he was more unstable. So that is why we have used the forearm walker here. Okay. Can you see this extension here? This is also called as gutter walker. Because the supporting surface is like a gutter there. That is why it is also called as gutter walker. Okay. Now this was the lady. Now in his case, his back extents are weak. Now this lady, she was very obese, and managing a forearm forward walker was very difficult, and she had a bilateral hip replacement with so much of obesity and severe arthritis of the knee. So in that case, because I wanted her to maintain her hip extension, we used forearm walker here. So by using forearm walker, I could get the hip extensor better. And that is how we started making her walk with this forearm walker. Okay.
So these forearm walkers are readily available, or it is the extensive bar which is attached to the normal walker?
There are in Europe they are readily available, but India forearm walker is not a very common demand. Most of the therapists don't know how to use the forearm walker because the demand and supply is not matched. Most of the people don't make it readily, so you have to order it. But in Sancheti we use very commonly, and like I use commonly, so my workshop people knows this. But this can be attached in your normal walker also. Okay, this is just an extension in a normal walker.
Yeah, we had one patient bilateral ankylosed, bilaterally hip arthrosis kind of a picture. So there we were struggling what to use as a walker. So we used the reciprocal walker, but then we were not knowing how to fix it because he was fixed hip arthrosis bilaterally, myositis ossificans. So I was just thinking this can be a very.
So forearm walker, myositis ossification, you have to analyze where is the problem.
The hip was ankylosed, hip was totally hip arthrosis, it's a fixed.
Okay. So analyze the problem, and accordingly you can give different types of walker. Let me check this piece. So you can see this now. Look at this child, because he was operated for the single event multi-level surgery where they release knee, hip and ankle at a time, and because he was for years walked only with the hip flexion and there is a light hip flexor tendency or tightness, in that case forearm walker is better. For him it's a too high walker, but because I wanted more of hip extension here, that is why we have used this forearm walker here. So if your objective to get a better hip extension, and for stepping like with the push knee or log knee, the more you get hip extension, better is the stepping. Like this girl was not able to walk with the hip flexion, so that is why we have used this forearm walker. You can see there we have got 2-3 forearm walker here.
Excuse me, sir.
Yes.
So you could have used here posterior walker also, no, in that girl.
You can use, but because that girl was for years walked with flexion, the posterior they do not have a range in the shoulder to go posteriorly. Like the extensor range is limited in these patients. So if you don't have a range, then you may not able to use the posterior walker. Like for posterior walker, you require this much of range, and most of the cerebral palsy they are here, so they get only this much range, and they cannot go back. So to put the hand backward, you require rotation also very good and a lot of extension. Like you require 20 to 30 degrees of shoulder extension. If that is limited, then you may not able to use posterior walker. Okay.
Okay, sir.
But that can be very good choice, provided you can achieve the extension.
Okay, sir. Thank you, sir.
Okay.
So, and even in the first video, like SCI video, the posterior walker would have been a better choice. I'm just asking, matlab, because the patient was going into flexion. So to prevent that thing and to get that hip extension movement, could a posterior walker be a better choice?
You are right. Posterior walker is better choice if you got hip flexor control.
Yes, sir, eccentric.
Because paraplegic, they don't have hip flexor. So basically they use hip hiking and momentum to generate the hip flexion. So that is why in paraplegic, we do not use posterior walker.
Yes, sir. Yeah, understood.
Okay.
Yes, sir. Thank you.
Okay. So this slide is basically trying to tell you, like in this area, momentum is causing hip extension and knee extension. In this phase, which is the terminal pre-swing, and for initial swing, it is the gravity or the Ganpat Patil action which caused the let go position. And in the end, it is a pendular action of the tibia. So there are three forces which are working: momentum, gravity, and pendulum. Are you with me?
Yes, sir.
Yes, sir.
Yes, sir.
So please
So
remember,
what about G ground reaction force?
ground reaction forces also basically this line of gravity. I explained to you everything with the line of gravity. You can explain the same mechanics through the GRF also, but GRF are very complex, so that is why I will not introduce you right now. But in the end of the lecture, if you want, I can introduce GRF also. There are slides for GRF, so don't worry. Provided you understand, because GRF is a little bit more complex, that is why I'm not touching that in this session of the lecture right now. So let me see if next slide is GRF only. Okay, up to this everything is okay.
Yes, sir.
Yes, sir.
Okay, now GRF. See, the way line of gravity, it was always vertical down, but GRF is basically the ground reaction forces. So always first law of physics, or Newton's first law, action and reaction are always equal and opposite.
Third law, sir.
Third law, opposite law. Third law. So first law is inertia, क्या?
Yes, sir. Law of inertia.
Second law क्या है?
Law of mass. F is equal to ma.
अच्छा, third law is action and
Action reaction force vector.
Okay, so the third law, the more you land hardly, it will get a GRF like this, and it will be always in the opposite, because the leg was landing like this, the force is like this. In mid stance, the leg is like this, that is why GRF is like this. Okay, so based on the what is the landing position, ground reaction force comes into picture. We cannot measure how our body is going into the ground, but we can measure how the ground is reacting to the body. So it is called as inverse dynamics. This measurement concept is called as inverse dynamics. We directly cannot measure how the body is landing on the ground, but we can measure how body is react, or the ground is reacting to the body. So it is called as inverse dynamics. So we are measuring the ground reaction to the body. So body's reaction towards the ground we cannot measure, but we can measure grounds, like because it is on the force plate. So how the force plate is reacting, that is why it is called as ground reaction forces. And as third law says, action and reaction are equal and opposite. If you measure ground's reaction, we'll also understand what is the body's reaction on the ground, okay? Because they are always equal and opposite in that same direction, right? So now we'll understand the muscle work with respect to the GRF. GRF also causes collapsing forces. Like if you see, if the GRF passes through the ankle and knee, we require less muscle work. But because the GRF is passing anterior to the hip, which moment it is creating in the hip?
Flexion.
It is creating flexion movement. So the muscle has to work for the extension movement. Okay. So in this, you can understand in the both the phases, the extensor are supposed to work, because GRF is creating a flexion movement. Now here, the GRF passing through the knee and hip. So do we require any muscle work?
No, sir.
No. But because the GRF is passing anterior to the ankle, which muscle work we require more here? Plantar flexors.
Yes.
Now here you can see the GRF is posterior to the ankle. That is why we require dorsiflexor here.
Dorsiflexor.
And because the GRF is anterior to the ankle, we require posterior group of muscle, which is the plantar flexor. So from loading response to the push-up, up to this, the GRF is continuously anterior. So that is why plantar flexor are continuously working throughout the stance phase. Clear?
Yes, sir.
Yes, sir.
And now this push-up phase, earlier we say let go position, which is allowing the tibia to fall down. But the GRF, because it is going posterior, it itself is creating a flexion movement arm. So we do not require quadricep or hamstring to cause the flexion. Okay, we don't require hamstring to cause the knee flexion. So because what is GRF generating here? Flexion movement arm.
Flexion.
And now from mid stance to the terminal stance, or so-called push-up. This is a push-up part. The GRF is falling posterior to the hip. right? So what is it creating? Which movement it is creating in the hip?
Reflection.
Extension.
Extension, because it is behind, so it is creating extension. And which muscle we require in this position? Extensors.
Extensors.
But because GRF itself is causing extension, do we require hip extensors?
No.
No. So by this way also
Okay.
I can explain you that we do not require hip extensor from loading initial contact to the terminal stance. Understood?
Yes, sir.
Yes, sir.
Because
Yes,
we
sir.
are passing very close to the joint, quadriceps is silent throughout this phase.
Yes, sir. Yes, sir.
Or here, although it was loading, so yeah, we actually said because it is flexion, it should be eccentric of quadriceps. But because the GRF is causing momentum of knee flexion, quadriceps does not work eccentrically. Okay?
Yes, sir.
Yes, sir.
Yes, sir. Yes, sir.
Understood the GRF concept easily?
Yes, sir.
Yes, sir.
So
I mean, sir, more close the GRF to the joint line, it needs less work. I mean, we can say isometric work, sort of.
No work, because momentum is zero now.
No work.
No work.
Yes, sir. Right,
There
sir.
is no isometric like that. Isometric only comes if there is no movement.
Okay, sir.
But because it is a dynamic movement.
Right, sir.
So see, please understand, muscle work is equal to movement arm into weight. So movement arm zero, muscle work required is zero.
Right, sir.
Closer
Zero.
to the joint, the muscle movement arm for any force. Like earlier we analyzed with the gravity, now we are analyzing with the GRF. In both the cases, it is always passing through the knee or very close to the knee. So we require negligible muscle work or no muscle work in the knee.
Exactly, sir.
So, sir, actually, if we want to utilize this ground reaction force in like a treatment or in recovery, we should emphasize more of a weight bearing. So we are creating compression, so the ground will give us opposite force. Just thinking.
Okay. Who was that? Pratiksha? कौन था?
Yeah, sir. Pratiksha.
Okay. उसका आंसर नेक्स्ट स्लाइड में है.
Okay.
Okay, there are two things in the ground reaction forces. One is direction of the force and second is amount of force. Okay. So what is amount of force? The height is the amount and the line is the direction.
Okay, sir.
The more you do loading, there will be more reaction, more amount. Okay. Are you with me?
Yes, sir.
So basically you can see that, and in this area, in the loading response to the mid stance, because there is too much of weight bearing on the leg, you can see the height is increased here, and then you let go, and at the push up phase before the pre-swing, you see again a second spike because we try to push here. Can you see this?
Yes, sir.
So there are, this is called as Clorley pattern. So there are two bumps here in the GRF. This is a normal. This is how normally the GRF looks. If our cerebral palsy child, because they do not have plantar flexors are very strong, or our hemiplegics because they walk very slow and the landing is very slow, this two bump does not occur, or the height is very low like this here.
Yes, sir.
Okay.
Amount of flexion.
So I gave you a clue for treatment. Pratiksha, you said you want to increase more loading.
Yes, sir.
So do you think more loading will increase the height here?
So direction also matters, no?
Direction. Direction.
It's a force, like.
So there are two ways you can treat this. Like, because you thought that because you want to increase the amount, so you will increase the load on the limb. So you will teach him weight shifting on that leg or weight bearing on that leg, or you add more weight on his body, or you compress on the body and increase the amount of the height of the GRF. That is one way to do it. And that is what most of the people do. They think, okay, we have to give compression. So give more compression, more loading, more contraction, more amount of GRF, more muscle work. But that is one way to do it. It is a very, very tedious job. One of the best or most simplest way to do, which I do very commonly, is, anyone, any clue? Twinkle, you can answer that. We have used this treatment strategy very frequently.
Sit to stand.
Walking. So you are asking to increase the momentum now over here?
Yes.
So to increase that
Okay.
momentum, we basically increase the speed, and like the knee and hip ka thing you said ki in hemiplegics. So we go with the alignment of the hemiplegic side. Like
Then
we
speed is the answer. Speed is
yes,
the answer.
speed is the answer.
Okay,
Yes.
Pratiksha,
Fast walking,
this
sir.
amount can increase in two ways. Either you load more or you load fast. In both the case, the amount, like if you in a short period of time you put lot of force, you will get more height. So the more you increase the speed, you get more GRF. Are you with me?
Yes.
So most commonly, again and again, what is the treatment strategy I am suggesting you to do?
Speed.
Increase the
Momentum.
speed.
Momentum.
Generate
The
the
momentum
Increase
or
the
Increase the
speed
speed.
and
momentum.
momentum.
Okay.
Actually,
Yes,
I
sir.
have one doubt.
The
Like,
most common treatment strategy which is used is the speed.
So that is where we struggle. Like even if we, but see.
Even you know it, you can't apply it because you can't generate the speed. That is what you are trying to tell.
Yeah, actually, well, even if we try, they become so unsafe, and they go for the voluntary co-contraction. They become rigid.
No, we'll first understand what is the problem, how to solve. We'll tell you. Okay, don't worry.
sir, I have one doubt. Like we said, ki we'll increase the compression. How are we supposed to increase the compression? I mean, the body weight already itself is acting as a lot of compression in a hemiplegic patient. He's not
Good
able to bear
question.
that thing.
Good question.
So how are we able
Okay.
to?
NDT strategies, how to increase the compression.
Sir, sorry to interrupt. Just to clear my query, in that NDT strategy, do you mean that the weight bearing on the affected side, like in sit to stand, also we give the reach outs on the floor on the affected side to increase that thing?
Yes,
Will
yes.
that
Basically, compression is the treatment strategy, or weight bearing is the treatment strategy. Now you want to use in sit to stand anywhere. That is up to you. But
Yes.
because we are talking about the gait, I'm only going to talk about compression strategy in the gait with the principle of NDT.
Okay, sir. Okay.
Okay.
No issues. Yeah.
Basically, NDT people, they suggest different techniques. So you can get a compression through the pelvis, or you can get a compression through the knee also. So like I'm keeping the hand on the pelvis here, and so take right step, or when he take left step, and when he goes to right step, during weight bearing, I compress into the hip and knee. So there is a compression. So basically the hand is this guy, because you can see he doesn't have any bum only here. So my hand is sliding down. So probably I will use this way as a compression strategy. So right leg down. And when he starts loading, then you give a compression. So loading and compression, loading and compression. So from loading response to mid stance, then you give compression. Loading response, then you give compression. One way to do it. Second, you can go through the knee also. Hand position, okay. So you keep, his body is very small, so my hand is sliding, so I have to use different strategies now. Initial contact, okay. So automatically go into extension, okay. So probably I will put my hand like this. Basically, put hand above and direction into the foot, okay. Straight, back, forward. Now walk, walk. So this is also one of the way to do it. Again, is this the right strategy? I'm not saying that. This is one of the way to do it. Like whenever they weight bear, you compress to the tibia. Whenever they weight bear, they compress to the tibia. Okay? Sorry, compress to the thigh. Sorry? Who's that?
Sir, but I guess this will be quite difficult because to handle a complete lower limb with compression, even if the patient is complete flaccid, the hip, knee and ankle तीनों control करने से अच्छा speed पे work करे तो that will be better.
You're right, but because people want strategies, so we have to teach them strategies.
Yeah,
so
actually it was just
this is one of the strategies taught to us in NDT. I will show you the person doing the demo of the same thing.
So same thing. One of the patients tried while climbing on the stair, na, sir, in the beginning of the video.
Climbing on the stair, it is okay because
so same thing.
There you can control very easily. But in walking, because it is a so much fast movement, you cannot control so much. Like watch this guy. He's doing the same, using the same strategy. So this is one of the technique. This is from my NDT course in 2014. This is the video. One of the therapist participants doing the same strategy as a treatment because it was taught to us. Again, posterior view.
So when do we use this strategy? But
What if I say never? I use only this strategy when the person is able to generate momentum and I can also move with that, then probably I might use it. Like you can see this guy, he was having a good momentum, he was walking better, and then you can use it. But I will say, why do you need it? Anyways, he can walk.
Yes, sir, exactly, because it was quite easy in this case, but usually in hypotonics वो इतना पूरा patient संभाल के करना, it will be quite difficult.
Actually, it is a stupid strategy. I will give you a simple solution. उधर बैठ तक जाओ और फिर turn करके आओ. See, anyways, this guy is walking very easily, and that drop which is there means he's actually shifting weight on the affected side more. So that compression strategy anyways is not required. He's anyways compressing on the right side. But because it was taught to us as a treatment strategy, they try to apply on one of their patients. This was their model, so that is why they applied on their model. Like you can see this guy, same guy could sit down and get up. He got so much control. In that, are you going to use that compression strategy?
No point in using that. It is already present.
He's got so good control. He can sit down and get up. So what is the use of that strategy? So there are
one question. So can we complete the? Can we correct the gait completely?
Completely. Now, when you say correct completely, it depends on what do you think is the problem. What do you think is your problem?
So as in?
It is open-ended question. I'm not going to answer that directly. When you
Depends
say
on the patient, basically, where that person wants to stop. If he is happy, that's okay.
जब आप लोग बात करोगे ना तब आपका हेडफोन निकाल दिया करो, डायरेक्ट बात करो. हेडफोन में वो रिजोनेंस आता है. ओके, सुनते टाइम पे हेडफोन यूज करो, कोई बात नहीं. Guys, see, one of the, like in today, I gave you whole lecture on gait analysis. How much did I emphasize on the kinematics, angles? Did I emphasize like 30 degrees of flexion, knee degree? Did I ever talked about too much on that? I just use that as a reference point. Yes or no?
Yes.
But you can see that in day-to-day life, we explain so much, like our teachers said, there is a less 30 degrees of flexion, more. They talked about kinematics, like angles a lot, right? And when you are analyzing and treating, you are focusing on how much he's doing hip flexion or knee flexion, and deviation from that you think is the abnormal thing. Okay, so whenever you are treating, as I said earlier or asked this question, depends on what do you think is the abnormal thing in the patient. Like if you think kinematics is the abnormal thing, you will focus on treating the kinematics. If you think kinetics, like muscle forces is the problem, you will focus on that. If you think speed is the problem, you will focus on that. If you think step length, stride length is the problem, you will focus on that. So what do you think is the problem is more important question.
So about for how long we will go on treating?
How long, there is no answer. Human behavior, we don't get satisfied ever. Whenever we solve one problem, we always want new demand, new problem, new solution. It keeps on going on. Unless and until you are out of money, or you are out of energy, or you are out of time.
Okay, sir.
Does it depend on the patient's goal? Like, where does patient want to stop? Like, see, I have a patient whose aim is to just go to the washroom and come back. That is what he wants. That's it. He doesn't want to go out of the house because he's a oldie, and see, he is satisfied with staying at home. So,
yeah,
but oldie, that might be true, Pooja. For oldie, that might be true. But I have seen the same goal for adults with 20 to 40 years of age also. When they are very bad, they said, at least toilet tak gaya to kafi hai humko. Again, human behavior. Once you achieve one thing, can we do more?
आगे वो demand बढ़ती
Right,
है.
sir.
Do more?
Job
So,
पे जाना है बोलते. Right.
I must tell you one fundamental principle of life. Again, away from the topic, but more important psychologically. हमको हमेशा पूछा गया था, what is your goal of life?
10th क्लियर कर लो बस, फिर सब हो जाएगा, फिर लाइफ सेट है.
हाँ, so हमको हमेशा पूछा गया कि what is your goal of life? Please remember this quote, very important. Our goals or objectives always situation based, time based and age based. The moment the time changes, age changes, our goal changes, everything changes. So there is no one permanent goal throughout the life. Like people say, I want to be happy. Define happiness. So it is, although it is very emotional goal, but you cannot measure it.
But
And
it can be one of the goal.
it can be one of the goal, but science says something which cannot be measured, cannot be changed, cannot be altered, or cannot be improved. Anything which can be measured can be changed. Can you measure happiness?
Emotions cannot be measured.
You cannot measure happiness. Like suppose I gave you JP Vaswani. Everybody knows Vaswani, Sadhu Vaswani, JP Vaswani.
Yes, sir.
Do you think these guys are happy?
Not even ओशो वाले ही happy नहीं है sir.
Yeah, अब happy है ना, लेकिन उनका happiness का expression क्या रहता है? They are always kind. For us, happiness, oh wow, oh wow. So, like facial expression of happiness may be related to people. Like बेवड़े को दारू मिली वो उसमें खुश है, उसकी happiness वहां तक ही है. Like I have
सब अपने अपने perception पे है कि कौन कितना किस में खुश है.
So first important, we are scientists, we are science student. So please understand, anything which you want to change, it has to be measured first. If you cannot measure, you cannot change. And the more the measurements are one second, hold on, don't disturb, one second, hold on. Ratio level, interval level, ordinal. More there are ratio or interval level, it can be changed better than ordinal level. You know what is this now? Nominal, ordinal, ratio, interval, ordinal.
Scales.
Classification hota hai. Like centimeter is the ratio level. So there is absolute zero and difference between 2 points is always equal. Like difference 5 minus 2 will be 3 and 8 minus कितना आएगा 3 के लिए प्लीज 5 will be 3 और 1 and 2 का डिफरेंस जितना है ना उतना 2 और 3 का डिफरेंस सेम रहता है, right? That interval is always same. The more you have this kind of outcome measure, you can change better. Whereas, like if you say ordinal scale, you take any physiotherapy scale, all physiotherapy scale are ordinal scale. Like you check stream format, or you take Barthel index. Are they absolutely like difference between, I say 55 to 56 or 50 to 60 and 60 to 70 is the same interval?
No, sir.
The more you go higher, actually the improvement both are there, difference दिखता ही नहीं है. Initially you say a lot of difference, but in later it is not equal. So the more you have ordinal scale, it is very difficult to change. The more you have internal level or the outcome measure, it is very easy to change. Like in Gait analysis or Gait treatment, what is our common outcome measure used? Anyone?
So in DGI is used.
Dynamic Gait Index.
Is what? The ordinal scale. And if any of you has actually used all dynamic Gait index in hemiplegic, tell me how much change you could show.
So we get lost. At least I get lost in between on it.
सबसे पहले dynamic Gait index किसके लिए बनाया था? Anyone? Dynamic Gait index is a disease specific scale and it was only meant to measure imbalance, or it is a balance fault risk scale. It is used only for geriatrics. We are stupid people to use dynamic Gait index in stroke patient.
Yes, sir.
Okay. Again, work balance scale is used in stroke. Work balance scale का original objective क्या था?
Balance.
It is a fault risk scale. Again, geriatric population, not meant for stroke patient. Give me stroke specific outcome measure.
Step length, stride length.
Sorry?
Step length if you check.
Step length. अभी line पे है आप लोग. Okay. So please, all these outcome measure which we use in college now, they are so stupid and they cannot show any change. Whereas you take very simple measurement like step length, stride length, speed of walking, or distance of walking, they change very fast. Like Sonia, your patient 10 days back, how much distance was walking an hour? After 10 days, how much distance is walking? Did he change or not?
Yes, it has changed.
Does his speed of walking change or not?
Yes, his speed is
Does
also.
his step length change or not?
Yes, sir.
And can you measure it accurately?
Yes, for sure.
Can anybody doubt that this measurement is wrong? Like in ordinal scale, like if you say perception, like spasticity तेरे लिए 2 ग्रेड है लेकिन दूसरे के लिए 3 या 1 भी हो सकता है. Anybody can question, like हमारे एग्जाम में हमेशा एग्जाम में करते. Do you think it is 2? No, I don't think it is 2. It is 3. ऐसा करते थे ना हमने सब MMT के साथ में हमेशा हमने 2 बोला तो हमेशा वो प्रूव करेंगे 3 या 4.
तो वो थेरेपिस्ट के लिए अलग हो सकता है.
बिकॉज वो ऑर्डिनल है. अभी सेंटीमीटर तूने लिया, तूने 50 सेंटीमीटर बोला, तेरा टीचर आके कोई बोल सकता है 50 सेंटीमीटर नहीं है? एनीबॉडी कैन क्वेश्चन यू?
नहीं.
Sir, excuse me, sir.
Yes,
sir,
please.
just want to quote one of the, Buffet. So he says, numbers are the fact, rest all our opinions.
Absolutely right.
Exactly.
So उसी से बेस्ड मैं उसको बोलता हूँ, physics people and science people say, especially for physics people, this is the quote I have taken from a physics lecturer: anything which can be measured can be changed, anything which cannot be measured cannot be changed or altered or improved or declared. So whatever you are measuring, it should be measurable. Like step length is a very much absolutely measurable thing, and your patient will always believe that you have showed improvement. Like हम लोगों ने MMT किया या spasticity check किया, तुम्हारा patient verify कर सकता है कि तुमने कम किया या नहीं किया है?
No, sir.
And always patient satisfaction. Please understand, it is not important how good therapist you are. It is not important how good you are doing in therapy, how much time you are spending. The most important thing, can you produce the change and can you measure that produce change? Are you with me?
Yes.
Yes.
Like
Completely,
cerebral palsy children, you see children are going to the therapist for years and years, and what improvement they get after 2-3 years? The parents can't say if he's improved or not. The maximum they say that अभी 5 मिनट ज्यादा बैठ रहा है. So उन्होंने मेजरमेंट कौन सा यूज किया है? टाइम. ओके, अभी 1 किलोमीटर चल रहा है, उन्होंने मेजरमेंट कौन सा यूज किया है? डिस्टेंस. अभी फास्ट चल रहा है, अभी मेजरमेंट कौन सा यूज किया है? टाइम. स्पीड. So all these are interval level measurement, not ordinal measurement.
Basically, we should use spatial temporal parameters of gait as an outcome measure.
And let me tell you, evidence in gait analysis and treatment showed that after every treatment, the only parameter which shows significant change is option 1: kinematics, spatial and temporal. स्पेशल का मतलब होता है स्पीड लेंथ, स्ट्राइड लेंथ होता है, और टेम्पोरल का मतलब होता है टाइम वेरिएबल, स्पीड और टाइम टेकन बिटवीन स्टांस फेज एंड स्विंग फेज, लाइक दैट. ओके,
Spatial and temporal, sir.
Temporal.
Spatial and temporal दोनों.
Spatial variables the most.
Which variable changes first?
Spatial.
Temporal changes.
एक दिन में टेम्पोरल वेरिएबल बदल सकते हो आप लोग कोई भी पेशेंट में. Like speed, you can change the speed in day 1. Okay, are you with me?
So please tell this again, please, sir.
Sorry?
Please, can you repeat this, sir, please?
Okay, and let me explain what are the variables. Spatial variable of step length, stride length. Like how much you can improve the step length, stride length. Obviously सब आदमी की स्पेशल स्टेप लेंथ, स्ट्राइड लेंथ नहीं सेम ही, ज्यादा नहीं बढ़ पाएगी. बढ़ के कितना बढ़ेगा तुम टेम्पोरल और स्पेशल वेरिएबल लाइक stride length only has to be equal on both the sides. Our objective is not to increase the step length, our objective is to keep the spatial or step length and stride length equal. So Vikrant, our objective is not to increase the step length or stride length, our objective is to increase or make both side equal. Vikrant.
Yes, I'm there.
हाँ, so आपने बोला था special variable. So special variable we are not supposed to increase. We are supposed to make them equal on both sides.
Okay, sir.
Okay. Temporal variable. Temporal variable के under your time and the best temporal variable are cadence and speed. What is cadence?
Number of speeds per
Number
minute.
of steps per
Steps per
minute
minute.
is cadence. Can I increase number of steps per minute on day one? एक मिनट में वो 15 स्टेप चल रहा था, मैं उसको 25 स्टेप कर सकता हूँ कि नहीं कर सकता हूँ?
कर सकते हो सर.
With practice, एक दिन में human behavior, motor learning says the more you practice, you get better at it. So can you change step length in one day? Sorry, cadence in one day.
Yes, sir.
Yes.
We can change.
What is speed? Distance covered per unit time. So in 5 minutes you walk 10 meter. Can you make it to 12 meters in 5 minutes?
Yeah.
You can. So distance improved per unit time. Speed improve हुआ कि नहीं हुआ?
हाँ सर, हो गया. Temporal.
Can it happen in single session? Yes, you can happen. Again, motor learning principle. The more you practice, you get better at it. So can neuro show improvement in day one?
Yes, sir.
So is it my opinion or it is a fact?
The fact.
So don't believe me, believe the facts. Okay.
Right.
So when people says neuro patient doesn't show improvement, because the neuro people who are using outcome measure, which are very stupid and ordinary outcome measure, they are bad. They did not use good outcome measure.
Yes, sir.
और ये मेरी language नहीं है. It is the same way my teacher aggressively has told me not to use these stupid outcome measures. When I gone to Australia for a motor learning course, my teacher strongly said that use interval type of measurement, or they call this non-standardized outcome measure. They don't use DGI, work balance. Sometimes they use Barthel index. That's it. Otherwise, they don't use all these things. They use speed, cycling, cadence.
Motor learning course from motor learning course from Sydney.
Bankstown Hospital. That website name is strokeed.com.
So single sessions you are talking about, the motor learning will happen.
Sorry?
In a single session, what is it possible to
Yes,
establish
motor learning can happen in single session.
Session, it might be increased, or is it the permanent learning?
Okay, so motor learning के stages अलग-अलग होते हैं. In a single session, whenever you improve, how do you measure motor learning? We don't measure motor learning. We measure performance of the activity. And when we say performance improve, that is called as motor learning. So performance can be improved by different way. In a single session, the coordination can be changed.
Yes, sir. That I understood. But motor learning, to establish motor learning,
improved, performance is improved. If performance improves, we say motor learning improved. But does it last longer? It is called as temporary or transitional change. To make it more permanent or long-lasting, or deep well or shallow well concept, अगर पता है आपको motor learning के principle से, to make it more deep well, which doesn't change as a behavior, you have to repeat more frequently, long term, then it becomes permanent change.
Yes, sir.
Understood? Manasi,
lot
of motor learning concept.
Yes.
Absolutely, sir.
Manasi wanted to learn about motor learning. किधर गई Manasi?
Yes, sir. Yes, sir.
Okay. Guys, अपन गेट पे बहुत ज्यादा है. मैं वॉकिंग शुरू करूं क्या अभी? सॉरी, पेशेंट का.
सर मैंने आज का वीडियो भेजा है वो पेशेंट का, अभी सुबह का जस्ट.
वो भी करने वाला हूं. मैं थोड़ा सा पहले असिस्टेड वॉकिंग के कांसेप्ट बता देता हूं पहले. We will go to that, okay? Because already it is 5 o'clock. And I have a lot of video to show you. Do you think we have wasted time discussing all these things? Or
not at all, sir.
Not at all, sir. Not
okay.
No, sir.
Everything you speak was equally important, sir.
So if anybody thinks that, please object, no problem.
Objection overruled, sir.
Sir, can you show us how you are using momentum during treatment?
हाँ वही दिखा रहा हूँ, वही बच्चा, अभी उसके अलग अलग एग्जांपल दिखाऊंगा मैं. One second. First, I will tell you how to do the assisted walking. धीरे धीरे मैं momentum कैसे यूज करना बताऊंगा धीरे, okay? Just let me check the assisted walking videos. The maximum assistance, okay? Today is basically stroke case, but the same principle I use in quadriplegic due to spinal cord injury or hearing injury. So this is a complete assisted walking. Can anybody tell me what am I doing and how am I able to lift this? She is near about 5.5 lady with huge and quadriplegia, 0, okay? From shoulder, everything is 0. And I am able to make this patient walk. She is C4 spinal cord injury.
You are shifting his body weight one leg to
Another
not
leg, yeah.
shifting.
Okay, weight shifting. Okay, key important point. Okay, I'm going to play that in replay mode.
Moment.
Okay, so understand, whenever you make any patient walk, your body and the patient body has to be
Same direct, same
1 unit.
1 unit.
1 unit. When I say 1 unit, whichever direction you want the patient to move, you have to move in the same direction. Okay, look at this position. Because I want her right leg to move and trunk to go back, I go back. So the hip on this side goes into extension. So it provides a mechanical stability because line of gravity is falling behind. So the GRF and line of activity creating extensor movement. So I don't require hip extensor to extend. And I support. And I unload this leg and step. So this leg is only putting into abduction, and that girl in the down, she's assisting to step forward. So look at that. Weight shift, now one direction. So whenever I shift, my body goes completely on that side. There are 2 types of weight shift, backward and sideways, okay? So watch this. Initially, you might require more weight shift.
An assisted walking. What are we achieving?
Okay, what are we achieving? Okay, let me finish this. So just see how we are doing assisted walking. I think some of the team member will answer that question. What are we achieving? I am not going to answer directly. Anybody want to try? What are we achieving?
Sir, basically
Verticality.
verticality.
Very good, verticality 1. So what is the use of verticality?
The anti muscle might comes in.
Joint compression technique.
Anti-gravity group of muscle will activate. Anything else?
So feeling,
Weight bearing, very good.
तो उसका feeling of confidence सर उसका level बढ़ेगा.
Feeling of confidence ठीक है, psychologically बढ़ेगा, okay, but that is the secondary objective.
Secondary object है, but
So sometimes what happens, we don't get the single movement in picture like a recovery wise, but this is the gait is stored. So we might get some improvement in the gait, even though in bed they are not good, but when it comes to functional tasks, they are good. Like,
Okay.
Some kind of muscle.
Probably those who have not attended the hip lecture or trunk lecture, I have answered this question. Many a time I use walking not to improve walking. My objective of walking is answer now. People who have attended trunk and hip.
Orientations, vestibular stimulations.
alertness.
नहीं ये अगर टिबिया होता तो ये आंसर बराबर है ट्रॉमेटिक ब्रेन इंजरी में. और कुछ
Muscle activation.
You are closer to that. How do you get muscle activation?
Joint compression techniques.
You are getting closer. The bigger thing, what I want.
Increased tone.
Which tone?
Postural tone.
Postural tone.
Postural tone.
So basically, most of these quadriplegic, they are hypotonic. So we want to improve the postural tone. My objective in this quadriplegic is to improve her trunk control. And by getting standing, her postural tone in the trunk and lower will improve, and it will improve indirectly her stability. So many a time walking may not be used for walking per se, We can use walking for improving postural tone. You can use walking for activation or extensor group of muscle, compression, sensory feedback, orientation. So, or sometimes we can use for cognitive stimulation, vestibular stimulation in comatose patient. So, walking is not always used for walking. There can be indirect results also. Okay.
It can also do the job of treadmill training, right? Like the repetitive
What
sensory motor
about
training and
Same patient we have done treadmill training also, but in treadmill training, we are how do we do treadmill training in this particular patient? Anyone?
body weight support.
Harness,
Treadmill
harness,
training.
harness.
harness
So
लगा
what does the body weight does?
It takes off the body weight.
It takes off the body weight. And what was the treatment principle we wanted to use?
Use
Compression.
body weight for compression.
Compression. And that compression, if you take away, then the typical body weight will not be there, and again it will not work. Okay. So again, this is a brain injury case, traumatic brain injury. So now it is a single person assisted. So he doesn't have control, but I am just shifting weight and he's stepping with my weight shift. So even if they don't have control, we use push knee brace and we make them walk. Watch this different angle. Some of you may not agree with me because it looks very crude, but it is your choice. Because I want weight bearing and walking, so I use, and this is done for only few days, 20 days, and the person will become more. He will get more stiffness in the trunk, and you can see that within few days they get better. So his left side was better than the right. Right was hemiplegic. So here, please understand what am I doing? Sometimes, Yes. Go ahead. Anush asked.
Would there be any improvement in CPG?
Sorry?
Would there be any improvement in CPG in such cases? Central processing generators, central pattern generators.
बहुत बाद में आता है बच्चा. CPG के लिए बहुत repetition चाहिए. वो CPG is different concept.
Okay.
CPG, you are absolutely right, but for CPG you require to stimulate a lot of locomotor pattern. That will also be one of the way to treat. Like if your objective is to improve locomotion, but basically my objective is to improve verticality, compression, tone, truncal stability. That's it. Like key point. Like so how to make walk in this patient. So this gives me a stability and my pelvis will extend. So this is how I extend. And by doing this, only you can get a stepping. If you don't get that stepping, so I am not pushing. Okay, I am not pushing here. Okay, so what happens? Sometimes people they push. That is also one of the technique. But first you try only doing abduction and then he steps. Okay, if they don't step, again look at my pelvis. So I go here and I extend, and this is how he can step. I extend and step, extend and step, and look at the upper body also. So my body and his body is one unit. Okay, if they don't step. This I use in hemiplegic with zero control, and they are not able to walk. So this is the normal leg, so they can step very easily. So what I do, I shift and passively put the leg, and normally they step. Passively put the step, and they can step. So you can stand in the back first. After a few days, you don't require so much of support. You can just hold hand at the pelvis, just body weight shift and body weight shift and forward. Again, next, I am showing all the demo, then I will show you all the patient. You go from behind here. In behind, what happens? The unloading is more easy. If you are sideways, you have to shift like this and step forward. Shift like this and step forward. Shift like this, sideways and step forward. These are different ways. Again, and here, take it forward. Sometimes if they got little bit control, but they are not clearing. So what you do? Take left step first, and just do this. Tight. Just do this weight shift, and they can step. So now he can step on his own. So just a small weight shift, they can step. So you can give a weight shift from here, or you can use limb as a lever, or you can use pelvis as a lever. Okay, left step, normal step, and go. And momentum, guys. Those who said how to generate momentum, remember, momentum is basically time bound. Like when they take a left step, most commonly people wait and then they step. Then the momentum doesn't work and the stepping does not work. Whenever I train walking in hemiplegic, I do not tell them the patient to focus on the affected leg. They have to only focus on the normal leg. So left leg, okay? So left leg. The moment he takes step, I shift. Moment he takes step, I shift. Don't give time. So after stepping, he should step. You can take a break. Again, step. So when he takes a normal step, because this is the step which generates the momentum. The moment he takes a step, body weight comes forward and stepping becomes very easy. So even for passive, now I am doing passive walking or assisted walking. He takes a step and I drag the leg. He takes a step, I drag the leg. After 2 days, when you don't require them to step, you have to just do the weight shift here. Take a step, weight shift. Take a step, weight shift. Take a step and weight shift, and the patient will be doing that. So I will show you these videos of the patient. So again, trick. Repeat. Go backward, extend, abduct, abduct, abduct. If it is only hemi, extend and just abduct and let him take a step. Let him take a step. If that doesn't work, your toes can hook in the back and take a step. Take a step. In this, we are using push knee and AFO. Okay, that shoe inside AFO and push knee. So it is not a normal leg here. We are using push knee and AFO in the foot. So this whole leg acts as a 1 unit. You have to just work on the stance phase. So in this assisted walking, my goal is not to teach them swing at all. My goal is only to teach stance phase. So when he does swing phase is passively done by me, and he is supposed to do the stance phase. Swing phase passively, stance is only active. Okay. Clear, guys?
Yes, sir.
So one of the important principle you need to understand. Usually common mistake done by therapists, we focus too much on swing phase. In initial phase, you are not supposed to focus on the swing phase at all. Our only goal is to improve stance stability. When I say stance stability, I am not talking mid stance stability. I am talking whole stance stability. So like when I am talking about stance stability, your goal is to improve the stepping exercise. Like you just put on the push-knee brace and ankle, just do step and just do stepping. Like you can just do as a stepping exercise forward, backwards, forward, backward. So once you are supposed to only work like this. Once they are able to generate easy momentum like this, then take a step. So in hemiplegic, I tell them to do 1, 2, 3, 4, and 5, and take a step. 6, and take a step. So you let them time to generate the momentum, and then you can start. Okay.
Sir, assisted walking will be difficult with obese patients, right? Like if the patients are very hefty.
Okay. You said assisted walking can be difficult in obese patient. Difficult is relative term. If you know how to manage your body mechanics and the patient body mechanics, like if you see my height is only 5'4", and I have handled very huge patient also who are more bigger than me. So it is not about the strength, it is about the timing and coordination. So I focus on my safe alignment. I take the patient in more safer position and then just work on timing. If you think it is more difficult, you can get one more assistant, or that assistant only required for 2 days, then you can take away the assistant. But if you are not sure enough that to do that type of walking, don't do it, no problem. You can use the body harness, okay? Or make them just do wall standing and do the stepping exercise, what I told you, just like this. Like one of the patient who is obese like this, how did I treated her? I will show you that video now. One sec. I'm searching the videos. Okay, once for the time being, you can see this. this guy is hypotonic. So what I use, this is the push this is the leg press machine, and there is a metal rod here. So what we used to do it, we used to tie here his trunk to this metal bar, and then he's using push knee press and take a large base of support here. And you can see, you can give something here for the right hand also to support, and then you can do this step exercise only. Okay, so if your patient is very obese, just put them in a very stable position and just do the unaffected leg exercises, and that way also you can manage that patient very easily. See, again the same patient, you can see that like this person, because this girl is assisting me to pull that, because I may not able to push it. So this is how I started making her walk. We have the same patient walking on the treadmill also, bodyweight supported treadmill also we have done for her. Like you can see that this is the same patient, indoor bodyweight supported treadmill training. This is ground training. We have also done treadmill training. So if you don't have a strength, you can put them in this bodyweight support like this, and then do the passive assisted walking. Pratiksha?
Yes, sir.
So if you cannot manage obese patient, you can do this way.
Swing left. Swing right. It's okay. I know.
But the problem with this is that because there is too much of unloading, so you can work on CPG, but the compression might get lost. You know what is CPG, right?
Yes, sir.
Central pattern generators.
Yes.
So then manually we can give compression, right, in these patients who are tied to harness. I mean, now the way she was working.
Sorry, harness?
Manually can we give compression
No.
to the hip?
See, compressions doesn't mean compression. Compression means purposeful compression. In weight bearing, it has to be time bound, situation bound, angle bound, phase bound.
Okay, sir.
Okay, so you can't use that, or you can use this option. Like I have used this harness here, but this harness is not for unweighing. This is only harness only for stability, that he's not supposed to fall. So in this case, like, see, what is the problem with this patient? Can you tell me, anyone?
Sir, could you repeat the question?
What is the problem in this patient? Open-ended question. Just analyze this patient.
So the problem is maybe the alignment, that the flexion movement is more at the hip, as you said in the starting slides.
Which
then
hip? Left hip.
Yeah, the affected matlab.
So you will try to focus on the hip here, right? No.
More external rotation of hip.
Sir, again the alignment is changed. Basically, the patient is the pelvic movement that is present should normally be present, is not present on the left hip, the affected leg.
Why? That is more important question.
So, but he is on unstable surface, no?
Unstable surface, okay.
He is standing far away from the treadmill. If he goes a bit ahead, and maybe if we the right hip, if we take
He's not willing to go. That is the problem. Sonia, you can answer this. Your patient has a similar problem. Sonia, are you there in the lecture?
Yes, sir.
What is the problem I told in your patient? Bigger problem?
Sir, is it that he is not able to take?
Fear.
Yeah, and weight he is not able to take on the left.
Do you think his foot is forming good base of support here? He is unable to take weight. So that is why the right step is not going forward. Whenever the right unaffected step cannot go forward, that means the affected side is not forming a good base of support. And to increase the base, he is going to external rotation. On top of that, he's got static AFO. Maybe because he's got a lot of plantar flexor tightness, that is why they are trying to maintain in 90 degree. But all this is increasing the complexity. So that is why we use the harness here to take away the fear. And there is a continuous surface which is changing, which doesn't give him time, because otherwise what happens, whenever he takes a left step, for taking a right step, he will always freeze, he will hold. You can see that there is so much of increase in tone in the left side. So they freeze and they increase the tone, and instead of bending, they make take that leg into extension. So that is why in this kind of patient, you have to just teach them stepping exercises on the ground, or you can take them on the treadmill like this and do the assisted walking. Now see what he is doing. Do you saw the change? Now can he walk better? What does he added this time?
Sir, he is assisting the pelvic movement maybe.
He's shifting the pelvis.
He is
Yeah.
loading the hip.
Loading. Basically left side में shift कर रहा है, क्योंकि patient continuously right में था. The more the patient is on the right, the left will go more into extension, and the more he shifts here, he will be able to unlock it better. So he has to keep shifting the weight on the left side. अभी वो right में गया तो देखो leg extend हो गया, bend ही नहीं हो रहा है. And see the initial phase. The moment he does this weight shift we are talking about, and you can see the knee is bending so easily. But in the end, the more he is on the right side, the leg goes more into extension. See, bending is so much difficult. So sometimes unloading also depends on how you are doing unloading. Like unloading in this particular patient, this patient has spastic dystonic. In that case, the leg becomes more straight or extended, or the tone in the extensor increase a lot. So in that case, you have to go for more of weight bearing and weight shifting on the same side. Now see what is the second thing they are doing. So he is using his left knee to what is he doing with the left knee?
Knee bending. Release. Knee
He is doing hip flexion to add more knee flexion.
Knee flexion वो unlock करने में help कर रहा है बस. Okay, so sometimes because this guy is a typical spastic dystonist, and they extend the leg and they cannot bend at all. So one of the solution is not to move away from that leg. You have to do a lot of weight bearing or a lot of stepping exercise on the same leg, and then they get reduced tone. Okay. Look at the same guy. Look at the line of gravity. Pendulum is on the right side. He never shifts on the left side. सोनिया, तुम्हारा पेशेंट भी थोड़ा बहुत ऐसा ही है, खाली तुम्हारा पेशेंट हाइपोटोनिक है.
सर इनिशियल फेज में तो बहुत ज्यादा एक्सटर्नल रोटेशन था, अभी तो बहुत ठीक हो गया है.
Because you did lot of standing activities, so his tone is improved, and he is now relying on that tone, and he thinks the affected leg is a reliable limb for weight bearing.
Yes.
So understood the reliability concept?
Yes, sir.
Again now, obese patient. Somebody asked me a question about obese. This lady, she is the T4 para, severe spasticity. She was little bit hypotonic in the trunk and mild spasticity in the lower limb and no balance at all. And so see how we make her walk. So here I am dragging the leg, okay? Because she is hypotonic, I am not moving too much of trunk. We are just holding the trunk in straight position, or in this case you can use a forearm walker, or you can use harness. Okay. These are very crude technique. If you got harness, you can use harness. Okay. Because I do a lot of home visit and we don't get harness everywhere. So we should find the solution. You cannot say that we don't have harness and you can complain about it. Again, hypotonic para, no control at all. And harness, we are not suspending the harness. We are allowing full weight bearing on the lower limb. So only harness for support, not unweighing. Okay. And doing assisted walking. So this is hypotonic para. Again, severe coming on my side. It's just this. Okay, go. Where the patient don't shift weight on the affected side. So you just shift the weight on that side and step forward, backward, step forward, backward. So passively stepping. This angle is better. और मैं actually बीच में छोड़ रहा हूँ, मैं धीरे नहीं कर रहा। स्वामी की तरह। So see here, we have given a stable support. Here benches are used as a stable support, so he can rely on the table. Earlier Dinesh was supporting him, but he was not very comfortable. So here he is able to walk, and we are giving minimum support here. So now he is relying on this affected leg. So therapist assisted here. So again, somebody who is obese, doesn't have good control, you cannot manage their walking, just make them stand like this. Now you can see that how I'm making her stand. This is the sidebar of the walk parallel bar. She can lean here, she can use the forearm support, or you can allow her trunk to be touching that rod here, and then you do the stepping in one place. So you may not need to teach them walking, just do one leg, one position stepping, that's it. And that itself is a very good strategy for treatment. So now my right hand is here, but sometimes the patient is not stable, you can hold the pelvis there, okay, for the support.
Sir, do we focus on speed or in this activities also? Will that help in generating momentum later while walking, or speed is not important in this exercise?
There can be, if you think the patient is able to manage that stability well, then you can focus on the speed also, because the more they do faster, they will be able to do the stepping in walking also faster. Speed is always important, don't worry, as long as you can balance. Now in the same patient, so now again, sometimes the assistant sometimes keeps the hand very high, then that hand is not forming a good base of support. See how much high he's lifting, so the patient was not very stable, so I told him to take that hand down. Can anybody notice what else I did here? Watch this clue here.
Clippers are removed.
To clear the ground, to clear the ground, you take 1 foot out.
Because I put on the knee brace, so she cannot shorten the leg. Right. So you have to lengthen the opposite leg. So how can you lengthen the opposite leg? By applying a shoe on the normal side and no shoe on the unaffected side. Right. So not every time you have to give a shoe raise. You can just use one leg shoes and other leg no shoes. That itself will give a shoe raise on an unaffected side, and the stepping becomes more easy. So whenever you have thought that you want to give a shoe raise, so you should do this testing with one shoe only, like unaffected leg shoe, and make them walk. If that improves, then only give shoe raise. And look at what I'm doing here. I'm just shifting the body weight on this side. Initially, I have to passively step the leg. Afterwards, the moment I shift the leg, she will step on her own. See, now she can step. This is yesterday's video. Earlier, I used to step for her. See how I'm shifting. I think today somebody has sent me the video where you are using your leg to step. Pratiksha or Pooja, who was that?
Sir, I have sent where I'm pushing with my other leg, like I'm assisting.
Pooja, I think you have done that. So you are doing good, but you are not shifting the weight from the upper body. So sometimes you have to shift the weight from the upper body also. Once you shift the upper body sideways, like you do the weight shifting here, you may not require to step with the affected leg. Sorry,
Sir, I would like to ask you something. So, sir, I have tried in that lady to push, but then the thing is, I don't know. I feel the resistance from the unaffected side. Could that be possible, or I am not properly?
That means she's not allowing you to shift on that side.
Yes,
so
sir.
probably the this side base is not stable. So give a walker, give a parallel bar or a stable or strong man on this side, then you can shift very easily.
Sir, I have done it with a hemi walker, but sir, she is not shifting.
Hemi
the weight
walker is because it is unstable surface, it is movable. She is not confident. Give a man or a parallel bar or a window or a railing. Like I will show you how I used railing at most of the people's house. They have this balcony railing, so you can use balcony railing as a parallel bar. So whenever you have any problems, you can find solution around. Like in this patient, I used balcony as a railing for walking. Okay, in the same assisted walking, now see how I'm using parallel bar. This guy, you remember this guy from trunk course? Anyone?
Yes, sir.
What was his problem?
Pusa syndrome.
Pusher syndrome. When you saw that day, he was much better. After that, he had a hypotension attack, and after that, he lost tone and orientation, and he was on too much of antidepressant, so he lost all the control. So he deteriorated after that. So here, what you can see that. So I'm Pooja, your patient was not allowing you to shift you on the same side. So this guy also got a pusher syndrome. He doesn't allow me to push on the unaffected side. So you can see that his orientation is continuously on the affected side. Usually hemiplegic, they keep their body weight on the normal side, but here he's keeping the body weight on the abnormal side. So he doesn't allow me to push continuously. So watch. So you may not push, you just clear and take a step. Like you can see the line of gravity is still on this side, but I used a stable or fixed support here. So same session, see, you can see that I am using push knee and shoe insert both, and I am using shoe on this side and no shoe on this side. Why?
ground clearance.
For foot clearance.
So
as you understood, the purpose of gait is only to do the foot clearance. We don't say that we require hip knee flexion. So now I am not giving him too much of support. I am just giving a mild weight shift and I am telling him to drag this leg. See, I'm just giving minimum support here and asking him to drag that leg. So that is how he's partially dragging that leg. See, weight shift. See, look at the pusher syndrome. See how, what is his orientation? Do you remember what is the problem in pusher syndrome?
Orientation to verticality is gone.
Perfect word, Pooja. Orientation to the verticality, because he thinks this is his normal verticality, whereas what is my verticality is this. Because they think this is their normal verticality, that is why they push on this side. Like he's inclined this way, he thinks that whenever he stands straight, he thinks his body is like inclined like this. So he is trying to correct to the center, but actually he was in the center, but he goes here. So the problem is verticality.
Verticality.
Okay. Or orientation. So I am trying to maintain his verticality, his minimum, and then make him walk. So now I am telling him to just stand, try to maintain the verticality and stand straight. So just teach them verticality for short period. Now, because he was not doing good, so I said, okay, stop and just do the stepping forward, backward, and try to maintain vertical position. And there are 2-point pressure. See, one hand here, from here, either this hand is used to push inside like this, and there is a third pressure here. 1, 2, and third point here. So 3-point pressure you can use and try to maintain the trunk straight. And just do stepping forward, backward, forward, backward. So always remember, this is hypotonic with no control, and you are supposed to just only teach stepping. So you try walking. If that doesn't work, now his push knee brace has gone down. So how do you apply the push knee is also important. If you apply the push knee very low, then the knee goes into flexion. So you have to have a long push knee brace, or you should apply the push knee brace little higher. If your push knee brace goes down, the knee cannot be maintained into extension position. Like the similar case, in the beginning, we require the person to support for stepping. Like here, we don't require him to push. He can shift the weight, and I am just dragging the leg. So you can just assist. He is a assistant. He can also make him walk after a few days. Okay. And now the assistant has to help for stepping. After a few days, he can step on his own. And especially this patient, he's very uncooperative. He doesn't shift body weight. He doesn't want to walk. In that case, the therapist has to work more. And within few days, then they learn stepping like this. So the therapist is not required, and they can walk. Because here the push knee is applied here, usually we allow the hemiplegic to take step first with the normal leg, but because here we have push knee brace here, we allow in the beginning the affected leg to go first. Okay, otherwise if you put the unaffected leg forward, we cannot bend the leg, and then you cannot clear the foot. If that is the case, you want to use unaffected leg first, then you have to remove the shoes or increase the shoe raise on the unaffected side. Okay,
right.
So foot clearance, our objective is to just make the foot clear, that's it. So again, watch this patient. If somebody is not taking good step length, like somebody was using step length as a treatment strategy, if you want to control their step length, you can use this way also. Now I have used a ladder here because I have this ladder. If you don't have ladder, you can use a marker or a chalk. Just do the marking on the floor and tell them to walk with that much step length. Like you have to walk from one box to another. Okay, so that is a we call it as visual augmented feedback.
So I can use this in my patient.
Your patient, was that Sonia? Konta?
Yes, yes, sir, Sonia.
You can use that as long as your patient is reliable on that
He
leg.
has a lot of fear.
If he has a fear, then wait for some time, and after some time you can use this. Now, similar patient, this lady, zero control, severe arthritis of the knee. She cannot extend the knee beyond 20 degree, like the knee is always in 20 degree. So I cannot get the hip and knee into extension. So earlier we did assisted walking on the ground with the push knee brace, what I showed in the another patient. Afterwards, from there, we came here in the parallel bar and we are using a stable base of support. And this is how we are teaching her walking with the flexed knee only. This is the affected leg. So we are teaching her stepping with the flexed knee only. This is her first day of parallel bar walking. Usually I don't use parallel bar in hemiplegic, but because this guy, the lady has a complexity where she couldn't rely on the affected leg, then you give a stable support on the another side. Okay. Now for the same patient, when you walk, make somebody walk in the parallel bar, you can't turn like this. So you can go backward walking. Look at the backward walking. And look at that weight shift here. So I shift the weight and she can do the backward walking. Many a time, if the patient cannot walk forward, teach them only backward walking. And after few repetition of backward walking, the front walking automatically improves.
So do we need to stand behind when we, assist in backward walking? Like if we can control the pelvis,
like in her case,
yeah, say in her case.
Because I was standing in front while front walking, I use the same thing. You can stand in the back also, but the biomechanical principle says basically you should be away from the direction of movement. Like in forward walking, here I'm just giving minimum support. Like for forward, this is the movement of her backward walking. So you should be behind her. Like behind here means because the movement is here, I should be back. When you teach somebody forward walking, you should be at the back. समझा क्या बोल रहा हूं मैं? One second, let me show you.
नहीं समझा sir.
One sec. Whenever you make anybody walk, you should never stand in front of the patient, because when they walk, that is the direction of momentum is generated. But if you stand in front, you actually reduce their momentum.
Okay.
So never ever stand in front of the patient while walking, unless and until you want to reduce their momentum and you want to slow them down. Like in ataxic, I stand in front of them because they walk too fast. I stand in front, but other patient I always stand in the back. Like this is the lady. This is the same day we walked on the parallel bar, and the same day you can see that now she's walking with the hemi walker with the flex knee, and this all achievement is within the 20 days. Okay.
Sir, do you also ask them to walk at home? As a carryover process, or
Yes. Like this hemi walker, she bought it at home and she's walking on her own at home.
Okay.
Like this is her on the last day before the discharge, she was walking independently like this. But you require continuous supervision.
Because most patient walks in front of therapist, but at home they feeling a sort of fear.
Never take away the continuous supervision. Like level of assistance, maximum assistance, medium assistance, and supervision may be two type of supervision. There is a close supervision and a distance supervision. Like close supervision, like I'm very close to her. Distance supervision, I stay a little bit away from her. So you are there, but you are not actually walking with her. Okay. So
Right,
in close supervision and just general supervision. So you can have two different type of supervision also.
Right, sir.
Again,
can you play that video again with that hemi walker?
Hemi walker you want? Okay.
I am a little bit confused about the way she's walking the hemi walker. The way she's holding.
Okay, like hemi walker.
Yeah.
I will show you when I gave her assistant in the beginning first. That was the time when she was walking independently. This is hemi walker assisted.
I have one doubt in this hemi walker.
Yes, please.
So like in this hemi walker, we are giving the walker on the unaffected side, but ideally we want to increase the weight bearing on the affected side. So, matlab, is the not point contradictory on both the ends?
Yes, you are absolutely right. See, whenever you are increasing the challenge, you should always increase the base of support. Okay. So I am in the beginning when she learns balance or confidence, this hemi walker will give you a larger base of support in the beginning, and then slowly you reduce the base of support and take away. Hemi walker will not be long term. If I don't give anything as a support here, she may not walk only, and the walking will be delayed. So here for few days you just give a hemi walker, and within 1 month they take away the walker.
Okay, sir. So rather than this hemi walker, normal walker could be a better choice.
We don't give normal walker because for normal walker we require both hand for
Both
support,
hands.
and most of our hemiplegic cannot hold both hand.
Right.
Yes, that
So
is
that is
correct.
why hemi walker is better than the normal walker.
Sir, I wanted to ask, how do you recommend to hold the hemi walker? Like,
okay,
should it be on the sideways like a crutch, or it is more of like a complete walker in the front? Because I saw you corrected the way she was holding.
Yes, you are absolutely right. Actually, there are different ways we tell them to hold hemi walker unit. So this is full side walker. So sometimes side walk, because the more you go sideways, that means you can see from here to here, huge base. Okay. Then second way is that I rotate it forward and I allow her to step into this. Like
Yes, sir. I saw that. That's why.
so in the beginning, see here now I am now rotated the walker in front. So I am reducing mediolateral base. So as Twinkle asked me that you are giving too much of base. So in the beginning, I want a larger base. Then slowly in the same session, the more I take it more inside, you are actually reducing mediolateral base.
Yes.
Like, see, can you see this now? The walker is coming in front now, and she can step into it.
Yes.
So that the mediolateral base is reduced.
So the same way, would you move to the stick?
Yes, same way from this we move to a four-legged stick with a larger base, then small-legged stick, and then no stick.
Okay, sir. Okay, sir.
Now this lady at home, I was treating her. So in the beginning, I gave her walker. Sorry, cane. So in the beginning, you can see this. Again, zero control, only mild tone in the lower limb, and we are teaching her walk at home. So usually you see this kind of cane is very commonly available in every patient's home. So what am I doing? See, now this is the cane, this leg and my leg. This whole area is a base of support for her. My body is acting as a support from here so that she can't lean on this side. So I'm not pushing her. I'm just giving a constant. Don't lean on this side. Okay. And she can step with that. And here, when you don't use any push knee brace, you allow the unaffected leg to take first step. Okay. Not the affected leg. And if you are using push knee brace, then you take the unaffected leg first.
With shoes. With shoes.
See how she's leaning on that side. In her case, initially I used push knee. You can see the push knee brace here. This strap, because this was not her push knee brace. It was temporarily used from my OPD, so it was not fitting to her leg. So you don't allow or you don't give push knee brace blindly to every patient, because sometimes it is only required for 1 month maximum. After that, it will be wasted. So you can use your OPD braces for a few days. Like I locked the knee, so now she can only work on the hip and ankle support here. In the beginning, I was continuously supporting her. Now I am not supporting her, and she is managing on her own. And I act only as a close supervision person here, and that is how they step. So for her, in the beginning, we just made her stand, step forward, backward with the push knee with this leg, and within 10 days, she walked like this.
Push knee brace and long knee brace, the purpose will be same.
Long knee brace, because long knee brace, the stirrups in that long knee brace are very small, and they are made up of plastic. They bend. So that is not effective. So don't use long knee braces which are available by Tyner and all the other companies. Like you can see that initially I'm working as a support here, and that is how she walks. So I weight shift, I do the weight shift, and then she takes a step. And by the end of 1 month, this is how she walks. Now no cane, and she is walking independently with the push knee brace. Okay. And after 1 month, when she was able to walk, we made her walk on the outdoor also. Like on day 1 with zero control, I made her walk outdoor with push knee brace, and it was full passive stepping. Afterwards, she started learning how to step on her own. So you don't require to stop for a long time to learn the active stepping. You can do the passive stepping, and afterwards we have removed the push knee brace, and this is in the OPD. Because we removed the push knee brace and she did not have a good knee stability, you give a hemi walker in the beginning, and afterwards you can take away the hemi walker also. And again, this is a close supervision continuously required for safety. Now you can see that how does she is holding the walker in front. Earlier the patient was holding sideways. Okay, Pooja.
Yes, sir.
Pooja Sawant, are you there? Pooja Sawant.
Yes, sir. Yes, yes.
वो पीछे तुम घूम रही थी, दिखी है तुझे?
Yeah. Yes, sir.
ये पूजा है, ये पूजा है. ये वीना आंटी को तू खड़ा कर रही है उधर.
हाँ सर. सर वो अब तक आते हैं?
वीना आंटी नहीं आ रही है वो.
Sir, I have one doubt.
Yes, please go ahead.
Actually, there's this one patient of mine who is having complete hypotonia in the lower limb. Actually, first we needed 2 therapists to, support the leg and make her walk. Now she is able to walk with 1 therapist, and also individual walking is present. Alone she can walk independently. But with AFO she can walk in a proper way. The moment we remove the AFO, she just bears the weight on the lateral border of the foot. And then she loses the balance. So in such cases, what needs to be done to,
There are 2 problems. Either you got overactivation or you got flail foot. That is why she is twisting. So what is the solution? So the foot is
overactivation is not present. It is complete hypotonia.
So flail foot hai. So the foot is not forming a good base of support. So you cannot take away the AFO. You have to keep the
AFO. Continue with AFO.
Yes, sir. So, sir, agar ऐसे patients है, so till what time do we need to, train that? Abhi with
time is relative. Time is relative. It is your training. It is becoming very less, or the tone is not coming faster because probably you are doing less weight bearing type of activity. Do lot of sit to stand, stepping on stairs, and walking more frequently, and you will get tone faster. You have to use postural tone, or you can use loaded sit to stand.
Yes, sir. I'm trying all the weight bearing and close train activities, but the tone, it's taking too long. Maybe she's not practicing once I come back,
So,
she's just practicing.
Give homework. Wall standing दे दे.
Yes, sir. वो maybe मैं नहीं रहती हूँ तभी करते ही नहीं है, तो इसलिए it might take a longer time for the tone. So that
Actually, कभी-कभी थेरेपिस्ट का गलती क्या हो जाता है, हम लोग जब वॉकिंग करते हैं ना, we make the walk so complex, and the patient think that I can only walk with the therapist, I cannot walk with the relatives. So whenever you talk to the patients and caregivers, talk like walking so easy, इतना stupid है, इतना simple है, कोई भी कर सकता है ऐसे. You have to make that walking as a very, very तुच्छ task.
Yes,
so simple task.
Change the perception.
It is quite lazy over here. That is why she is not doing, because at home I don't take her walking. It is the caretaker only that makes her walk, but she is not practicing. That is might be the.
So you are not very adamant.
Yeah, could be.
You have to be very aggressive and adamant. Whenever you go back, every session, ask how much distance did you walk, or you make a notebook. Write down, you have to walk this much, and if they complete, they have to fill up, and the patient has to fill up that. Okay. Then it is called as compliance improvement. Now watch this. Nishita, are you there in the session? She's one of our therapists from Bombay. This is a very big tragedy. They both of them got engaged, and after that he got a brain infection, fungal infection, and he's gone into brain injury. And this is his status after 3 years now. She was the girl who came with me to aquatic therapy course to Switzerland, Nishita Rana. So now watch how she's making him walk. He's a severe spastic dystonic. So much assistance, and his neck continuously goes into extension. This is a very good video now. Sometimes she goes too much of in extension. Earlier we used to use push knee A4. This is the current video she has sent me in last week. And this is how this leg is used for stepping forward. So sometime, as I showed you that earlier the girl was sitting down and holding here, pulling the leg. Sometime I tie dupattas here at the ankle or knee, and then the person in front can just pull, and one person in the back, and then two person can make the patient walk easily. Again, goal of all this walking is not to train walking. Goal of all this walking is
to improve postural tone, to orientation.
Very good. Motor control in standing.
Motor control. Yes,
okay. So he had severe dystonia.
That's you. That dupatta is like ergonomically sound, like, है ना sir?
क्या?
दुपट्टा जो यूज किया ergonomically it good, good है ना?
Ergonomically, because she doesn't have to bend. Earlier she used to sit down and pull,
exactly.
And it was causing more back pain to her.
Exactly.
So this is ergonomically very simple.
Right.
You need to work hard, but the hard work can be converted into smart work also.
Smart work, yes sir.
Like he's got so much of TA tightness. See how does she makes him stand also. And you can see her height. She's only 4. And he's around 5'5" or 5'8". He had so much of dystonia, like in sitting, he will just lift his limb and continuously move. You must see his initial videos. Very good case.
So when we discuss about circumductory gait, because it is a very frequently seen gait deviation.
Circumduction अगले संडे का टॉपिक है बच्चा, उस पे अपन पूरा टॉपिक बात करने वाले हैं.
Sir, also about so last time after ankle lecture you had told that we would be discussing about orthosis selection and all those things in detail.
Yes. कल का लेक्चर ऑर्थोसिस सब कुछ उसी में आएगा. Don't worry. Next lecture उसी में. Now this guy who was pusher syndrome, after 1 week, this is how I am trying to make him walk. So sometime I have to push and then he can take step. Sometime I have to drag his leg also. And look at that pusher syndrome. Continuously is pushing into my hand. Here he could step, and you can see that here I have to assist him for stepping.
Sir, if we don't give the patient this shoulder sling, then
shoulder subluxation हो जाएगा.
नहीं, ऐसा जरूरी नहीं है. Not all my patients get shoulder sling. If you can improve the shoulder control faster, you don't require that sling.
Okay, sir.
If there is if you think there is a trunk is hypotonic and the shoulder is hypotonic, then you should give. If the trunk is not hypotonic, then don't give.
So, but मेरे पेशेंट में ऑलरेडी सबलक्सेशन है और वो स्लिंग भी नहीं पहनता है.
जरूरी नहीं बच्चा, हर बात स्लिंग जरूरी नहीं है. तेरा जो पेशेंट सोनिया बोली ना?
हाँ सर.
नहीं, तेरे पेशेंट का सबलक्सेशन नहीं है. डोंट वरी
सर, लेकिन वो दिखता है लिटरली.
लई जरूरत नहीं बच्चा.
ओके, ठीक है सर.
ग्रेड सिंगल फिंगर, ये वीडियो दिखाया था लगता है मैं तुमने लास्ट टाइम.
हाँ, दिखाया था सर.
ये एनालाइज में कर लीजिए. Then in assisted walk, you can have treadmill type assisted walking. Like he is a head injury case with severe plantar flexors and more tone, so you can use FRO here. Here I am using FRO to assist his knee extension. His trunk is hypo, but lower limb was spastic. So see how he is assisting into extension. Stepping he can do it. Extension is done by the FRO. Okay, I hope you know what is FRO. Huh?
Yes sir. Floor reaction orthosis.
नहीं कैसे काम करता है पता है क्या?
तो क्राउच गेट में यूज करते हैं, इतना पता है, बाकी पता
हाँ ठेव इथं. किसका पेशेंट है? उनमें से किसी ने भेजा क्या मुझे ये वीडियो? Now you can see that he just using AFO and not too much of circumduction gait, but it is forming good base of support. So you can take away this cane very soon.
तो सर्कमडक्टरी गेट अगर इनिशियली प्रॉपरली अगर ट्रीट नहीं किया या फिर फिजियोथेरेपी में लेट किया तभी आएगा ना वो लेटेस्ट स्टेजेस में.
Can you hold on the patient's
next Sunday.
सर्कमडक्शन को इतना बदनाम करके रखा ना लोगों ने बेचारे को. It is not always the problem. Sometimes there can be very simple solution for that also.
देखो आपको शूट कर रहे हैं. अच्छा.
So this is CP with a dystonic and a hypotonic trunk.
Come on. Very good.
Look at the key point. We always try to keep the hip into. What are we working on the hip?
हिप लॉक कर रहे हैं वो.
Extension. Lock शब्द नहीं कर रहा.
Extension.
आवाज पर नहीं क्या extension.
You have to work continuously on hip extension. Again, look at this. Push knee plus AFO.
Push knee plus AFO.
So now, earlier I showed you therapist on this side. Now the therapist on that side. From that side also I can do the weight shift. So how do I do the weight shift from the unaffected side? So earlier this was the affected side, so I pushed him on that side. So earlier we push like this, okay? So now this is the affected side. Therapist can stand this way. So this is how I hold and I stay. So I pull him like this. This is one way to do it. Or this is the hand which is coming on the pelvis. So shift and go forward. Shift and go forward. And shift and go forward. Please remember, whenever I am shifting, I am not pulling from the hand. Look at my body mechanics, my body mechanics. I shift. Okay? So what common mistake therapists do? They stand straight and they pull and the patient doesn't work. So whatever you want him to do, you do on your own. Like shift and walk, shift and walk, shift and walk. So he and me are one unit now. So I'm just holding him like this straight. So we are in the same unit. The shift and walk, the shift and walk, the shift and walk. Are you with me?
So when we make the patient walk like this, but then there is nothing near the foot end. So is there a possibility that patients might just directly put the leg into external rotation only?
They do. Like if they are doing a lot of external rotation, good question. What is the solution?
Constraint.
Okay. So if he is doing like, if somebody is walking like
तो इसको ऐसा कर लो.
so whenever you stand like this on this side, they always lean like this. So when they walk with external rotation, I go in the back, I hold like this or this way, and then I do this. So this is one way to do it. Or you go on this side, take the affected side upward and forward like this, and then just step. I shift hand upward like this.
So
one second, let me finish this. So the hand clue, this is now the hand clue. if you are having a little bit tone in the upper limb, you can use hand glue. So you shift this way. So this hand can be used to pull forward also. If the same hand can be used to shift the weight also that side. So here I am doing too much of weight shifting just to understand, because the picturization might be less effective. So you can just do minimum weight shift. So it doesn't look like that, and you just do the minimum weight shift and go like that. Or the same hand can be used to pull forward to reduce the external rotation. Whenever you want to reduce the external rotation, guys, so what happens if they are doing external rotation? It is not external rotation, it is the truncal retraction of the upper body and pelvis is back. So just take the upper body forward and pelvis forward and look at my foot, it comes straight. So you are not supposed to work on the external rotation of the hip, you are supposed to work on the upper body trunk. So whenever this hand goes forward, upper body comes forward and the external rotation will completely go. Are you with me?
Right, sir.
So either take the hand forward, take upper trunk forward, or take the pelvis forward.
Pelvis forward.
Pelvis forward also, like I can keep the hand here, take left leg, and you can guide just through this. So don't allow him to go backward. So whenever he's stepping, don't allow him to go retraction. Just hold here and walk. Okay? Therefore, it will follow this. So this is a FRO. Basically, there are different designs of FRO. This is one of the design where this is how you from the back you are supposed to put, and the moment I load, it goes into extension. Okay. The moment I load or I try to take the left leg forward, this goes into extension. So FROs are meant to assist knee extension. Okay, by mechanically locking. Tomorrow, when we are going to talk about index flexor spasticity and hyperextension, then I will explain you this in detail again. So there is one more design. This is one of the original design. There is another caliper type of design also. I think I have told you in the last lecture. Shall I take your videos for discussion now?
Yes, sir.
Yes, sir.
I'm just taking randomly, okay? ये तो तुम्हारा वीडियो नहीं. Sonia, I think this is your patient, right?
No, sir.
नहीं, ये किसी और ने भेजा है फिर.
डिस्कस कर लेते हैं.
So circumduction, कौन था circumduction? Pooja?
Yes, sir.
What do you think his problem is?
Hip flexion is not there.
Hip flexion is not there. What else is not there?
Ankle dorsiflexion.
Ankle dorsiflexion is not there. So treatment क्या होगी इसमें? So
Facilitate.
why he is doing circumduction? Anyone?
Clear the
To
ground.
clear the ground.
For clearance.
To clear the ground.
Clear the ground. So what is more problem? Hip or knee or ankle?
Ankle.
Ankle.
So solution क्या होगा?
So either we can give mechanical assistance or we can facilitate ankle, plantar flexors and dorsiflexors.
नहीं, facilitation के लिए time लगेगा. Day 1 में change हो जाएगा मुझे. आज के आज improve हो.
अगर शू रेज दे रहे हैं हम लोग अनअफेक्टेड साइड पे तो दैट विल ऑटोमेटिकली हेल्प विद द फुट क्लियरेंस.
सर एक पैर निकल के चला.
सॉरी,
शू इंसर्ट दो ना. शू रेज क्यों दे रहे हो?
हाँ सर, वही शू
डॉर्सिफ्लेक्शन कंट्रोल कर दो तो ऑटोमेटिकली वो कंट्रोल हो जाएगा. अगर फिर भी नहीं हुआ तो देन यू गिव अ शू रेज. Priyanka, are you there in the lecture? This is Priyanka Katri's video. Now again you can see that similar problem in the ankle. She can do the stepping, hip knee flexion is not bad, only ankle is the problem. So if she got so much control and she is in IPD right now, so that means she is acute case. So are you going to advise shoe insert for this patient? Anyone?
I think, sir, it may not be needed.
Why? Good answer, but why?
Because I think we have scope for improvement. We should.
Good. आपने flu pick up किया because it is acute case. So within 2-3 days, if she's improved so much, she will walk independently also. Or you should have your own air pose in the OPD. So this is a shoe insert. Okay. So the previous patient, you can use this shoe insert and it will improve. Or in this particular patient, you might use this shoe insert for a few days, but later on, don't make her buy because sometimes this is a dead investment.
Sir, if we use the same, like if we make a general AF and which we keep an OPD and use for many patients, so sir, but their measurement specific, right? And if it is too big or too small.
Averagely, we don't want like snug fitting. This shoe insert, they are medium size or small size. That's it. They can go with any patient. And AFOs basically they require a size base, so you make a large size base AFOs. So large can fit to the small people. ये किसी का है क्या वीडियो को तुम्हारे में से?
Yes, sir. Yes, sir. This is mine.
Okay. So what is your question in this patient?
Sir, first of all, that forward propulsion is not happening with this patient. Patient is not able to use the use the move forward through his lower limb. He always used to pull himself with the upper hand only.
See, Somnath, if you look at our basic principles of Gait, can he do the forward propulsion? Yes or no? Everyone?
No.
He is doing. He is moving from one place to another.
He is doing.
What is missing is
extension.
Speed.
Okay, speed.
Speed is missing. He is doing that, but speed is missing. Now look at the step length of right and left leg. Then you will get the solution. What is the right step length and what is the left step length? And which side is more problematic or weak?
The right side is more problematic.
Right is weak.
Left is more
No, sir, left.
Left is more problematic.
Okay, right वाले कितने लोग हैं? Right वाले बोलो right.
Sir, it's right, I think.
Okay.
But I think the
right shot.
The left.
Sir, 1 minute, sir. The right shot. Right step is
नहीं रुकिए right या left पहले बोलो बाद में अब explanation देना.
left. Sir, सवाल बताओ फिर से एक बार सवाल sir please.
Which side is you think problematic, right or left?
Sir, left is problematic.
Left. Okay. बाकी कौन हो left वाले? Swapnali said left. Anyone else?
नहीं.
Okay. His left side is problematic.
Yes, sir.
Understand,
right
guys?
is short.
Whenever you are not able to take bigger step on opposite side, that means the swing phase side is not a problematic. The weight bearing side is a problematic. So left side is the weaker side. Now in weakness also there are two types of weakness. One is the ankle weakness, one is the hip weakness. Ankle weakness is taken care by this AFO. So his hip is weak and his hip stability is not good. So that is why his right step is not going. On contrary, both sides are static AFO, but with the left he can take a bigger step, but with the right he cannot take bigger step. So it is not the ankle range which is limited, but because the hip is not stable on the left, he cannot take right leg step bigger. So this is the problem. So where is the problem?
Hip, right
left
hip, left hip, sir.
Left hip stability is a problem with extended hip. So solution. Now what are the problems? Problem is, what is the problem? Is it a weakness, tightness, sensory path impairment? क्या है अपने? Repeat the 5 impairments.
The strain, coordinations,
range, spasticity,
and
sensation.
Spasticity and tightness is one impairment. Okay. So out of these 5, what is the problematic? Those who are attending this lecture first time, there are 5 impairment we have to look at. One is range. Do you have limited range? Second, strength. coordination, spasticity or tightness, and sensation. Out of that, which component is affected?
Strength, I think.
Strength.
Very good. Left hip strength. Which muscle specifically?
So stabilizers.
Hip extensors. Stabilizers or hip extensors, you can say, or especially long joint muscles. So you can use hamstring as a hip extensor or a PFL as a external rotator to stabilize the left hip. So you have to work on the left hip extended stability. So what exercise will you do? How will you teach him? Stability with neutral hip.
Step up.
Stepper. Which height stepper? Low height or high height?
Sir, low height. Sir, पहले बिना height के ही चलेंगे ना sir. Like पहले without stepper, we can just take a step forward, backward, forward, backward.
If you do that, he can do that with the hip flexion also. Right now, what he's doing is the same thing. He is already with the hip flexion.
I think the higher we go, the more extension we get.
That is why high stepper. The more you get a higher stepper, he has to extend the left hip more. Video दिखाओ क्या तुमको? High stepper वाला.
हाँ sir.
And we require stable, like because he doesn't have balance, so you tie them to the some behind support like this guy. He was supported to the back support there, and he's doing stepping here now. He's doing upper limb here. I have showed you this video earlier, that stepping exercise.
Yes, sir. In ankle control, last Sunday you saw taught us.
Stepping exercise.
Sir, can I ask?
Go ahead, please.
Sir, as long as you are discussing with that, he is having the issues with the hip extension problem, hip extensor probably. So my question is that I have worked with the hip extensor is weak, but my question is that his ankle plantar flexor is too much overreacted. But there is the range issues is there.
You cannot do anything for that right now because that is a very chronic case, and the tightness is very severe. You may not able to get the good range in the ankle, so you have to adapt the range or accept the range.
Okay.
And in old CPs, we don't play too much around the ankle, and I don't do a lot of stretching.
Sir, it's not the case of CP; it's a head injury case.
But how many months old?
So 6 years.
6 years. So it is already old case. So the plantar flexors are tight or they are weak. In both the cases.
Plantar flexor tight, too much tight.
What is the strength?
Strength probably more than 4.
So if it is a head injury case, the protocol changes little bit here because head injury cases, they have low initiation and low active participation. So the one of the best treatment here, you may or may not work on the hip, increase the speed. How do you increase the speed?
Sir, I used to do that with the increased speed, but again, problem is that whatever I feel that unless until you don't give anything to his hand, he will not come forward. That means that he is having.
You cannot take anything away from his hand. I am not saying don't give anything a hand because he will require large base of support. So one of the ways to increase speed, do lot of treadmill walking with harness or support. Or in the same walker, you stand in the front and you pull the walker faster.
Okay.
Or I stand in the back and I push the walker faster. So you don't give him too much time. So head injury cases, they don't have control problem. They have initiation problem, or they call slowness of problem. हर चीज के लिए बहुत slow react करते हैं. So we have to push them very fast. So the more you make them fast, they react to the momentum fast.
Sir, यहाँ पे excuse me sir, यहाँ पे posterior walker दे सकते हैं?
यहाँ पे posterior walker देख के complexity बढ़ेगा. तेरा patient cognitively poor है और उसका initiation तो और भी slow हो जाएगा. So instead of posterior walker, you give a forearm walker. So you are giving a more stable support, and then you give the support.
Forearm walker could be the solutions.
Forearm support is better in his case.
Yes, sir. So one more thing is there. Because of that left, you are talking about the left things, but there is a ligament discrepancy is there because of the fracture shaft of femur is there. That's why he is also using the overactive plantar flexor for the left. even
limb length expensive ज्यादा मैटर नहीं कर रहा है. देखो इतना अगर देखूंगा ना मैं ये पेस
सर,
है,
मैं हिल रेज देके रखा हूँ, लेफ्ट में बहुत ज्यादा हिल रेज देके रखा हूँ.
तो फिर ठीक है, तूने ऑलरेडी कंपनसेट कर दिया उसको. सो अगर शॉर्टनिंग है तो भी उसकी वजह से बॉडी वेट उधर बहुत ज्यादा शिफ्ट होगा.
सर प्रॉब्लम क्या होता है सर, अगर मैं उसको वहां पे जो एंकल के स्ट्रैप है, कभी कभार वो वहां से उठा लेता है, मतलब एंकल के स्ट्रैप को भी इतना पुल करता है.
तुम्हारे लिए दूसरा वो मेरे पास एक एफओ है, वो लास्ट टाइम दिखाया था ना मैंने, वो यूज.
हाँ, वही उसको यूज करना. मैं मॉडिफाइड जो आपने एफआरओ बोला,
मॉडिफाइड कैलिपर किया था ना, जो एफआरओ के साथ जैसा यूज करता हूं.
हाँ, lateral
गुड स्ट्रेचिंग, लाइक यू कैन सी दैट ही इज ऑलरेडी इन प्लांटर फ्लेक्चर हियर.
यस सर, एंड इवन दैट,
too much of tightness.
यस सर.
So you can compensate. और इसी केस में मैं क्या करता हूँ, in the back I put up cushion there which is rigid, like I use newspaper and stuff there.
Yes sir.
And
yes,
I
sir.
allow the heel to weight bear.
Yes sir, I have done that by increasing the heel bar, giving the heel bar.
So you can use the heel bar in the beginning, or basically whenever you get a traumatic brain injury case, guys, the treatment doesn't rely on the kinematics. The treatment is only speed, high activity, high intensity, high aggression, because this guy is a low aggression person. So in cognitive or brain injury, cognitive treatment is more important than your therapeutic treatment.
Okay, okay.
So initially you have to work a lot on cognitive treatment. Okay.
Okay, sir.
Or like this, this guy, we are using supported harness. Now you can use supported harness and push knee also on the treadmill. Afterward we used FRO in the same guy. That was with the push knee brace. This is without the push knee brace. And afterward we used FRO also.
One more thing I want to ask you that regarding the case, what prognosis are you expecting from this patient as a whole?
Traumatic brain injury prognosis first depends on the cognitive improvement. So cognitive, does he follows command?
Yes, sir, yes, I have, definitely. He speaks.
Can he do self-care activity?
He tried everything. He used to try.
Sitting, self-care activity.
Yes, sir. But transitional activity is not good. But he can feed himself. He can take care of himself. He used to do. Yes.
For feeding, how much time takes? Normal or less? Or more?
Normal, sir. He used to.
Probably is better.
Yes, sir.
You can treat him like a CP diplegic.
Okay. Actually, sir, yesterday after showing that your loading, plantar flexure loading, foot loading, no, with the flexion, I have done that. Probably I got some kind of relaxation. I got some kind of increasement in the plantar flexure range. Dorsiflexion range, sorry.
Dorsiflexion range weight bearing में करके तुमको stepping up down करना पड़ेगा.
हाँ, वो किया था कल फ्लेक्शन करके, और फ्लेक्शन पोजीशन में उसको लेके उसको पैर के ऊपर लोडिंग डाल के, और सुपिनेटेड प्रोनेटेड फीट भी है, तो मैं राइट फीट इज मोर प्रोनेटेड, तो उसको मैंने प्रिवेंट करके लेफ्ट फुट को स्टेपिंग करवाया.
वेरी गुड. और यू कैन गो ऑन स्टेयर्स आल्सो.
ओके. सर एक्चुअली स्टेयर देने से क्या होगा, जैसे ही वो खड़ा हो जाएगा फिर वो प्रोनेशन हो जाएगा, तो इसीलिए मैंने उसको फ्लेक्शन पोस्चर में.
तेरा रेंज प्रॉब्लम है, मतलब मेजर तेरा रेंज को मैनेज करना पड़ेगा.
हाँ, इसीलिए मैं तुम बोल रहा हूँ सर.
अगर रेंज प्रॉब्लम मैनेज नहीं कर सकते तो मत लेना स्टेयर्स पे.
ओके.
वो स्टेयर्स का वीडियो दिखा रहा हूँ, 2 मिनट. Okay, for your patient, these are the exercises you can do whenever you get severe tightness and severe tone. You can use this type of exercises. So like I gave a task where he is supposed to weight bear like this and reach forward. Okay. left side is affected. This is one task. Look at the setup. So I am stretching only soleus now. Hip is flexion, knee into flexion. So whole extensor tone is taken away, and the left hand is also up here. So the whole body is getting lengthened here, and then weight bear, and then take step. Or you are giving a task. So this is the setup, and this is the task where he has to do that exercises. Or you can do the stepping up down exercise also. Is this a stepping? No, this is a flexion training. Like, but in the same thing, we keep the affected leg up and the right leg comes up down, up down. This is eccentric stepping. Now here he has taken this leg forward, but you can use the unaffected leg up down, also for giving stretching and strengthening both at a time. Okay, so I use sometimes stepping for stretching as well as strengthening also. Look at his walk. This is basically the tomorrow's next lecture's topic. मैं तुमको एक स्टेपिंग का वीडियो दिखा रहा था, 1 sec please. This is that video. Okay. So if he cannot step, just give a setup like this and reach. Her right side is affected. So look at this stepping. She is from 0. She's going at 3rd step. So you can go step up down, up down. Now the task is complex here. She can hold here in the beginning. Now she's got good base. So I wanted her to only focus on the right leg. So I'm not allowing her to hold the left railing. But in the beginning, you can allow the left leg holding here, and right leg usually comes to the first step. But here I am giving 1st, 2nd, and 3rd. So 3 steps up directly. So you get a lot of stretching and strengthening of the plantar flexor here. Clear? Somnath, clear?
Yes, sir.
Or you can use this sit to stand also.
Sir, that I used to do early, all the things.
This sit to stand, high sit to stand. And now there are 2 ways you can do. You allow him to sit, or you only sit in short range, up, down, up, down, up, down like this. Don't allow him to completely go down. Then you can get more stretching.
Sir, he is having the problem with that. He don't want to come forward. Whenever moving forward is the issue. So my question is that you use a bottle in the hand, will it works?
No, forward in which position you are saying?
In sitting, sit to stand.
Sit to stand. Hip is then posture. Then we have to stretch the thoracolumbar fascia. Probably he is not able to, or he don't want to. There is a difference. So
don't want to.
Passively आता है range है.
Yeah, हाँ आता है.
So then he is scared of coming forward. So you have to increase the base of support.
Okay.
So use a walker or keep him close to the wall, or give some larger base in front. So his problem is fear and less base of support.
Okay.
Again, this is one technique. Again, see how I'm holding the knee into flexion and telling him to do sit to stand. So this is also how you can do the stretching at a time.
So these are the things I'm doing already.
So then he's scared. Just increase the base of support.
Okay.
So if you increase the base of support, then it becomes very easy. Again, this type of sit to stand also you can do. See, look at the compression here. Not sit to stand, stepping. He's supposed to stand here like this. And this is the affected leg. Left leg up, down, backward, or the same leg can go eccentrically forward.
Okay. So, excuse me, sir. So one question, sir. If the patient has chronic tightness in the plantar flexor, still we do. So we shouldn't do all these stretches now. It might.
You can do.
Still, sir. Even in contracture we can do.
Yes.
So wouldn't it hurt the ankle joint at the insertion?
It basically contracture depends on what is your definition of contracture. If the R1 R2 is same and it is in +10, probably you may not get improvement. But many a time, sometime when I get that type of severe ankle tightness, the problem is not the ankle. I work on the hip and knee. I do a lot of mobilization around the hip, knee, tension fascia, external rotation, internal rotation, and I get around 10 degrees of improvement. After that also, if your hip is very absolutely normal, there is no stiffness in the hip and knee, and only ankle is tight, then it is ankle problem. Then you need to do Botox. If Botox doesn't work, then you need to do the release.
Release. Okay, sir.
Okay.
If R1 R2 is equal.
But depends. Sometimes if they have got more stiffness or tone in the hip and knee, you have to treat that first.
Okay, sir.
Pooja, whose video was this? पूजा और प्रतीक्षा किसका वीडियो है?
सर मेरा है प्रतीक्षा.
प्रतीक्षा हाँ.
Yeah.
What is your problem?
Sir, he is a 1 year old, cervical like a Brown Sequard syndrome. Cervical has been fixed in flexion, C4, C5, C6 level. So right side it shows the hemi kind of a picture. Previously the hyperreflexia were there, but now the reflexes are coming back to like a normal. But my problem is he walks very slow. That is one thing. The second thing is, as you can see, the ground clearance is not that good.
Okay, so there are good thing what you already did, Pratiksha. First, for ground clearance, you use a figure of 8. So, guys, you need to answer this question. What is her problem? Stance problem or swing problem? Everyone, stance problem or swing problem?
So stance problem.
Stance on the right. Stance on the right.
Right is affected. अपन right का ही बात करें बच्चा.
अच्छा sir.
Stance problem.
Her problem is not stance. Why? Because if you look at the left step length, it is such a big step length. So whenever you get a big step length on the opposite side, that means stance stability is very good.
देरी है एकटू जाना.
Okay.
So this is the indirect assessment of the stance stability. If the opposite leg can go forward easily, that means stance stability is good. Her foot clearance is a problem little bit. She's already clearing the foot. So basically for her, I don't need to do anything. For few days, I might give a shoe raise, work on walking. Her hip knee control is also very good. So work only on hip knee flexion and shoe raise for a few days. Afterwards, draw lines like this on the floor. Tell her to clear the lines and she will get hip knee flexion. Don't work on the ankle. Ankle is very stable, neutral. Only work on hip flexion and you will get stability.
So stability he has, but the problem is I want to increase the speed because he takes like one round to and fro 10-15 minutes in
Shoe raise then. If your speed is the problem, shoe raise or the walker, what he's pushing on his own, you push for him.
Okay.
So shoe raise on sound side, na sir? On sound side.
On side. Always shoe raise is always on sound side.
Right, sir. To clear the ground easily on the affected side.
Yeah. Right. Okay. अभी ये किसका वीडियो है? Whose video is this? Sonia?
It's my sir. It's mine.
Okay, Vikrant, tell me your question.
So he was a spastic quadriplegia. He had a severe crouch gait. Now he's quite little bit upright. So sir, my question is, would he be able to get straight as we want normally? He was being asked for multi-level release at ankle, knee, and hip. But I'm looking after him since 6 months. Now he has got a good control. Previously he was also having a bad endurance and he got easily fatigue and all because of his overweight and weakness of the trunk and all. So now he has a good strength, everything. But still there is a little bit crouch when he walks. And the worry is when he is not able to touch his heel on the ground. I prescribe FRO for him. When he was walking with FRO. I'll put FRO video tomorrow, maybe in next lecture. So I wanted to see what else I can add in this patient. So there are many videos.
How was his walking with the FRO? Did he require support for walking with the FRO or he could walk without support?
So even without, sir, I put one more video of him, sir, while walking.
No, answer this question.
So what?
when he walks without FRO, does he require assistance?
Nothing,
Or
sir.
with
Nothing.
FRO, does he require assistance?
He doesn't need anything, sir. He walks by himself to my clinic.
So
He
if
come by walking.
somebody he can walk without anybody's support, so why are you giving FRO? Because the moment you give FRO, his biomechanics will change and he will require walker or somebody's supervision for walking.
Sir, now it is possible. FRO we are being given to him since 6 months. Now I discarded FRO. Now he is able to walk without FRO, but still there is a little bit crouch.
See, crouch, because this is a CP and probably he's 20 plus, right?
No, so he's 16 years of old. 16 years
16 years.
almost.
So anybody who is after 10 years, the spasticity component is gone. It is more of mechanical, and there is a permanent lengthening of the plantar flexors, and their body is used to this flex posture. We call this suspension strategy posture. So this posture is his stability strategy. It is how he is most stable. If you change the ankle and try to push backward or put more knee into extension, his hip will flex more and he will become more unstable. Whenever he walks with the FRO, he will require walker or cane.
Okay, sir.
So right now, don't give him anything.
Okay. So can you please see this video when he walks?
Good anklet shoes, good anklet sport shoes.
Okay, sir.
There is a shoe in the market called as Zig-Tac, which has a zigzag pattern in the sole, which gives a suction effect and it gives a very good stability, and use anklet above ankle. So it gives ankle stability also indirectly. So in this kind of patient, I only give anklet shoes and don't give any assistive device and allow them to walk.
Okay, sir. So can you please see his video while walking? I ping you, the group.
You have sent me video?
Yes, sir. His walking video is there. So can please go ahead a little bit. It's not that. So yeah, आज का है. Yesterday I put it.
Okay, 1 sec.
So what's the posture called?
That is crouch posture.
Crouch.
And that strategy
No.
is called as suspension strategy.
Suspension strategy.
डार्सी आम्फ्रेड खोल के देखो, उसमें दिया है. विक्रांत कल किस में भेजेगा तुमने?
हाँ सर. सर और भेजो एक बार जस्ट रिसेंटली. सर आप सर you please continue with some others video. I'll just send you once again.
Okay.
So which book in which book is it mentioned about?
डार्सी आम्फ्रेड. न्यूरोलॉजिकल रिहैबिलिटेशन बुक का नाम है, ऑथर का नाम है डार्सी आम्फ्रेड. Sonia,
yes sir.
What is your question and what things you could achieve in last week?
सर ये बहुत पहले का वीडियो है, अभी मैंने रिसेंट वीडियो भेजा आज का अभी का.
भेजा का तुमने?
हाँ मैंने भेजा है सर.
So what was that case? The previous one?
CP diplegic. Actually, the biomechanics of CP diplegic is very different. So
you can check now.
Can we share CP Gait also?
Yeah, you can share. See, I am open to anything.
Okay.
It's okay.
Okay.
See, my job is to teach. I am not going to restrict you. We are going to only because I always forward the question, because anyways we are going to discuss in next week. Why to waste time in this week? That is what my problem is. Now, what do you think? What is changed here, and how do you measure his improvement? Anyone? Non-standardized measurement.
Speed.
Very good. Speed is improved.
So stability has also increased.
Stability. How can you measure the stability?
So the weight bearing on the
stance time on the
opposite side stance space is
stance time
with
step length.
Yes, में क्या फर्क पड़ा है बोलो. Very good point. So if you see, his right step length is improved a lot. Earlier he was not going more forward, right step length, but in that video he was better. Like you can see that. You see the right leg is coming forward.
Yes sir, right leg अभी आगे आने लगा है.
जितना right leg आ गया, that is an indirect outcome measure and a very effective outcome measure. See this. Now right leg is without cane also he is able to take more forward. So his reliance on the affected leg is improved.
Yes,
which joint is more affected in this guy? Hip, knee or ankle?
Ankle.
Anyone else has any other opinion?
So wait. Okay.
Anybody with the hip?
Sir, ankle, sir. Because sir, he's putting his affected side first.
Okay. So ankle is the problem. So do you want to work on the hip also or only ankle?
So both.
So the answer is both. Why do you want to only fix up only upper lip? Still, how she's using him walker? Usually, walkers are not to be given in hemiplegic.
ये बहुत पहले का वीडियो.
Good, but I like your choice because first of all, you are used walker without the wheels, so that mechanically that walker is more stable compared to the wheel walker.
So one more thing is that there is no resistance as you were using that papers, sir, to reduce the friction. So there is the floor is like acting as the same resistance free. That's why he's could easily
it is
pull.
giving more resistance. Very good. तुमने ग्रुप पे डाला है ना?
Could you please open the video, sir? Yes, sir. Same video, sir.
So look at this portion. Whenever you walk, whenever you analyze anybody's walking, guys, do not look at the kinetics and kinematic. Always look at the stability first. Can you move from one place to another with stable base, stable posture? Okay. After that, speed. Analyze his stability first. Okay. He's walking slow, not because he walks slow, because the constraints are of the environment. Environment is very small, very congested. That is why probably he's walking very slow. But he can walk faster than this, okay?
No, sir. I asked him to walk with smaller base, and that line is there, no, sir. वो लाइन के आजू बाजू चलने बोला उसको मैंने with internal rotation of the hip.
तुमने और constraints बढ़ा दिया तो तुमने speed खराब कर दिया. Never reduce anybody's speed.
Okay,
Do
sir.
not analyze anybody's walk with lower speed than their natural walk. Whenever you change speed, you change the kinematics, and whenever you change kinematics, you change kinetics. When I say kinematics means angles. When you change angles, you change muscle work. So you cannot analyze the muscle work in natural environment. Allow at their own pace. Now he's gaining his own pace. So his ankle is very stable. Both sides step length is very good. So ankle is not a problem in your patient.
Right, sir. So previously he's walked with the broad base, like side to side walking, sir, waddling sort of.
Don't reduce the base. No need. He's faster with a larger base. See, understand. Whenever we walk, we shift the weight anteroposterior, and that is how we generate momentum. Cerebral palsy people, they move sideways, and that is how to generate the momentum. If you reduce the small base, you are reducing the momentum. If you are reducing the momentum, you are reducing external forces. If you are reducing external forces, you are causing more active muscle contraction, and you are reducing energy, increasing energy expenditure. So efficiency of walking is going down. So by reducing base, you are causing more damage than helping.
So, but he was walking previously the same broad base of support. Then, sir,
allowed him.
What was my role in after treating him then?
Only increase the speed. Now imagine, if you want to increase somebody's speed, can you walk at a higher speed with a larger base?
No, sir.
No. So by default, the base will come slower. So increase speed, base will automatically reduce. So whenever I want to reduce somebody's base, I don't reduce the base. I only increase the speed, and base will become automatically small.
Okay.
So reduction in base should be natural phenomena, not a forced phenomena.
So, sir, in hypertonic CP child who used to go for that wide base of support, so how will you increase the activity of the muscles by narrowing the base of support only, no?
Hypertonic कौन सा?
In hypertonic CP. Hypotonic CP.
Hypotonic CP, because basically hypotonic CPs, they are hypo in the trunk. Okay, so when the trunk is hypotonic, you cannot increase the speed.
So hypotonic means might be all over. Then it's not only trunk.
Trunk सबसे ज़्यादा hypotonic होता है. Lower limb में तो होगा. तो trunk अगर hypotonic हुआ ना, तो speed increase करना मुश्किल ज़्यादा होगा कैसे? Then you can increase only speed with harness and treadmill.
No. My question is that you are saying that don't reduce the base of support in case of. So my question is that on of the treating hypertonic CP is that narrowing the base of support, you challenge the more.
See, if your aim is to improve walking, if your aim is to improve strengthening, then it is okay. But if your aim is to because in hypotonic stages, we are focusing on their trunk control, hip stability, trunk stability. And in the phase of walking, if your aim is to improve his speed of walking or walking improvement, then give a harness, give a treadmill and increase the speed. And that way also indirectly you increase the tone and trunk control also.
Okay.
Because hypotonic will require larger base, larger support for walking. And they may not walk independently like this. This last word which I used, like I don't reduce the base of support in patients who are walking independently.
Okay.
Hypotonic don't walk independently.
Okay. It's not like that, sir. Hypotonic might be walking independently.
If he's walking independently, then you don't need to reduce the base of support. They will automatically increase the speed, they will reduce the base of support.
Okay.
Why I'm saying that? See, hypotonic large base is their balancing strategy. If you take away the balancing strategy, large base of support, they will fall.
Okay.
Most of the time, external rotation, large base, they are their strategies of balance or stability. Never ever take away their strategies of stability. If you
even if you're talking about that, if the child is able to walk in hypotonic CP, so at that time we used to constant with that, like by giving the constant with the walk in the pole, something like that. So reduce the.
Yeah, आप challenge करो उसको, orientation बदलो. Yeah, what I do, I add weight or tell him to walk with the complex task, like you can give something in hand to hold on and then walk.
Okay, sir. Okay.
So balancing strategy को अवे मत करो, balancing strategy को challenge करो. That is the better way to treat.
Okay.
Don't take away the balancing strategies. Okay.
So in this patient, if I increase the speed, na sir, he come to more crouch. He gradually gets down.
That is acceptable, because whenever we run, we always flex from hip and knee. Nobody walks with straight hip and knee. That is the dynamics of running. That is a natural high speed walking.
So, but more if he goes on the crouch posture, there will be more stress on the knee and hip. He'll end up with the pain, sir, at the end.
No. That is now. See, if that is the case, all the runners should land up in pain. It doesn't happen like that. See, so, but loading is never the problem. A transient loading is not the problem. A continuous, or like the wear and tear concept, continuously, if you are longer time, that is how it causes damage. Otherwise, repeated loading, all runners, they should have a lot of injury, but they don't have. Ulta, it will cause a compression rarefaction phenomena. It will give better nutrition to the knee.
But sir, running may, sir, they come to they go to flexion and they go to extension, sir. In this case, he never goes to extension. He goes to more flexion if he walks more.
नहीं, see, crouch का patient भाग के कितना भागेगा? सबसे पहले they already have a less stable, and when they start running, they do the dragging of the.
Sir, no running. I'm not talking about when they walk with speedily at his home. That time, sir.
See, first of all, crouch patient, CP patient, we don't challenge their ankle a lot. We want to have because you are looking him at the age of 16. I am looking at him at the age of 25 or 40. So if I stretch too much plantar flexors and if I load too much, what will happen? As you said, there is a damage and there will be more lengthening and they go more and more crouch. So in crouch, usually I don't do a lot of playing around at the ankle. Whatever the tightness I have with them or whatever the flexion pattern I have with them, I accept. And I give a larger base of support, allow them walk at their own pace. And whenever they get poor balance, we give them assisted device faster or earlier. Because if you don't give assisted device like walker or something like that, they go more in more crouch and they will damage the mid-foot break or they will damage the ankle. And there is a concept called as mid-foot break. The foot goes in too much of pronation and they become more crouched. So by age of 40, they cannot, or 30, they cannot walk at all and they will be wheelchair bound. So whenever you are looking at the CP, especially the 10 plus CP, you have to look at them at the age of 30, 40, what will be their alignment and what will be the effect of weight and obesity on them. And accordingly, you should do plan treatment for them. Don't think short term for cerebral palsy.
Right, sir. So in this patient, what I'm planning is I'm strengthening his endurance. I'm working on his endurance.
I like what you said in the beginning. Already you gave as a treatment. Focus only on endurance, and that is the best strategy for treatment.
Right, sir.
Strengthening is never a strategy in this patient. You will improve coordination, endurance, long distance wall, stability, less fall is the treatment strategy.
Right, sir. Thank you, sir. Yes.
Who's this patient? Is this? Anuj Babu, तुम्हारा है क्या?
Pin है बेटा.
Yeah.
But ये upper limb दिख रहा है.
So,
Lower limb का problem क्या है?
So it's in the next clip. That's his first time standing.
Okay, first time.
So, but still, yeah. But I make him, walk with the help of.
I must appreciate your effort.
Yeah.
You did two good things. You used wheelchair as a dynamic walking device. Wheelchair is stable as well as mobile.
Yes, sir.
Wheelchair as a walking device here.
I had to, sir, because it's a very poor family and they don't have
that is the best way
very limited resources over there.
Very good strategy. See, because he is dystonic, we are not supposed to talk too much about the gait. Here we want more stability, more distance of walking, and endurance. That is the treatment strategy.
Yeah. I try my maximum to make him walk more and more and to make him stand independent. We're doing the
Independent
best. But
standing is not your should be goal. Assisted walk should be your goal. I will show you the progression of your patient. Same patient can walk like this. I have the similar kind of patient with me.
Isn't this a mixed CP case? It's
Sorry?
a mixed CP case, right?
Sorry?
It's a mixed CP case, right?
It is spastic dipole, dystonic quadriplegic CP.
Okay.
There is a earlier they are spastic core. As the age increases, they become more dystonic. Initially, they are actually spastic.
Okay.
And initially, they are more of hypotonic in the trunk and spastic in the lower limb. As the age increases, they become other way around. The tone becomes more dystonic, and the lower limb also get more dystonic. And afterwards, what is this? Their control will go down. Like if you want a CP type case.
So the control goes down with age, does it?
Yes, control can go down based on the weight.
Oh. Okay. I have sent one other video also. Later I stopped using the wheelchair and I moved on to normal chair. Made him, hold the chair, and instead of his sister, I sat on the chair. Okay, so this is also a mixed CP.
This is how sometimes they adapt their different strategies of like. Can you see we understood external rotation strategy is the stability strategy in this child. Internal rotation is a stability strategy.
Oh.
See, look at the right leg. The right leg more goes into internal rotation and gives hip stability, and that is how she can rely on the right leg better. Her right side is affected more than the left, so she used internal rotation as a stability strategy. Otherwise, you saw external rotation as a stability strategy.
So I have one question. So how do these patients adapt those strategies?
Problem solving. They keep walking, they do that, and they feel stable with their own dynamics, and they find their own stability.
Yeah, their intelligence is too high.
Intelligence से कोई लेना देना नहीं है, मजबूरी से लेना देना है. You don't
require
intelligence when you are majboor.
So, what was your role in this case, sir? What was our role in this case? That lady working with internal.
So, like this girl, she got so many problems. I am not supposed to solve her all the problems. Like in her case, we focus more on her treadmill walking, stepping strategy, and we allowed her what are the pattern of walking in the beginning. We only work on her endurance and fitness.
Okay, sir.
So, but what can I do to?
Matlab, sir,
Sorry.
what can we do to the patient?
one second, guys. Whenever you get such a complex patient, do not work on everything solving. Only work on speed of walking, stability.
Speed of walking, stability,
Coordination,
coordination.
distance of walking can be very simple goals. Again, Anush, your patient at a better level.
Sir.
A CP diplegic in the beginning and how इसका walking video देखता हूँ. So I don't correct his posture. I only improve his task activity. Walking की तो कह रहे हो.
Okay.
One second. Let me check his walking. Like मैंने exercise डाले लगता है video पर अभी. So see, he has a dystonia, traction, lot of rotation. He walks with external rotation and backward movement. We taught him how to do sit to stand. He was going to the school also. His mom said that he cannot sit down and eat. So my strategy was to squat down and upward. Then we taught him how to cross-legged also.
I used that same strategy of yours, sir. Instead of asking him to stand up, I asked him to come lean forward and then stand up, like in squats.
Right. Like
You had
Vikrant.
you had mentioned that in the last weekend class.
So here we change the task. Now look at this task. With that, he's so much stable. And he's supposed to be squatting with the board and with the bottle, which is not supposed to stand, fall down. So with dystonia, see how he's managing. So sometimes task can be very effective.
So only thing is to make the task challenging.
Again, similar diplegic case, CP diplegic, quadriplegic in the childhood. See how does he walks. He finds his own stability and then he walks. He's got problem everywhere, trunk, hip, knee, ankle, but he can walk independently. Now, in his case also, what is our treatment strategy? He used to go to all the center for therapy. They used to do bed exercise and all that. Sit to stand. We did not do any bed exercises. My treatment for him, treadmill training, cross trainer, and we used to put him in the harness and we used to put on music and let him dance. Sit to stand, only simple exercise. Nobody had ever tried him on treadmill. And
by cross trainer, is it the elliptical machine in which we have to hold that?
Elliptical, yes, elliptical. Cross trainer or elliptical, same.
Elliptical.
Same. Done.
Anyone want to ask me question with the videos, please? Or otherwise, it is 7 o'clock. We have to stop.
I have to. Sorry. Okay.
Sorry.
So, I did not upload a video because it's too long to like download and upload. Can I just like screen share my thing?
You can share the screen. Screen share stop karta mera.
Okay.
You can share your screen.
Okay. Just give me a second. Sorry. Okay. So, it's a video of him walking and it's a video of him doing sit to stand. So I'll share both. Can you see it, sir?
I can see it.
Okay, so this is a video of him walking. So I don't know what is exactly wrong with his leg because I don't know if he doesn't have increased tone in his quadriceps because I checked it with I checked his tone. He's wearing a foot up splint also. So I don't know what exactly is his problem.
Okay, so. Simple. Understand one point. His stability problem or mobility problem?
So I think it's both because ankle mein mobility.
Stance problem or swing problem?
Okay, let me just see once more.
Anybody can answer, okay?
So I think stance may be problem hai because the opposite leg ka
step length
chota hai.
Okay, stance problem is there partially.
Yeah.
But if you look at his hip, How much he is doing hip knee flexion?
Internal rotation.
External rotation is a stabilization strategy. It is a stability strategy, so that is acceptable.
Okay.
And if you see with the cane also, he is not very stable.
Yeah.
So there is a stability problem as well.
Kind of a circumdactory gait.
Circumdactory gait is also there, but the anchor is not very bad. I think hip is the.
So he's put up a foot up splint there, niche. मतलब ankle, it's pulling the ankle and dorsiflexion.
Dorsiflexor assist splint hai wo.
Yeah, yes.
So it pulls the foot upward.
Yeah, it pulls the foot upwards. Yeah.
His plantar flexor are also weak. If you tell him to do toe standing, he may not able to do. If you tell him to do one leg stance, simple assessment in this case, tell him to do the one leg stance or teach step up, step down. When they do the stepping up, step down, they will do lot of hip flexion or lateral weight shifting. So if they do lot of lateral weight shift,
I did not do step up, step down, but I did step forward, step backward because I did not have a step. So step forward, step backward. दिखाओ क्या एक बार sir?
दिखाओ.
हाँ, एक minute, sorry. I just have to find it. Just give me 1 second. Sorry.
So you think that there is no tone problem in the lower limb, right? Tone is okay.
No, I'm just asking. Why, like, is there a tone problem?
The supine assessment. What does your supine assessment says?
Okay, I'll show you my supine assessment. Just.
नहीं वो मत दिखा, वो बता. Tone कितना है या low?
I think it's normal. I don't know.
Normal है, ठीक है. Tone is not bad.
It's normal, no?
So
थोड़ा सा है ना, like very little.
Standing में postural tone ज़्यादा आ रहा है.
हाँ ना, yeah, that's what. But then, is that affecting his walking and sit to stand?
So fear is very much high because
fear is high.
Fear is very high. Like look at the sit to stand.
Yeah, I'll just show you the sit to stand also.
You are doing 90-90 sit to stand. Always do high sit to stand first.
I did the high also. I'll show you the high one also.
See, look at that. Left foot is not forming a good base of support.
Yeah.
And alignment भी maintain नहीं किया आप लोगों ने. So base में wide base होना चाहिए पहले. And you are allowing him to use his right hand for sit to stand. Don't allow right hand for sit to stand.
Okay, don't. Okay, fine. Support नहीं लेने का. And I'll show you the thing that I did.
जितना तुम support लोगे उतना left foot adduction में जाता है.
Okay, this is the step forward, step backward thing that I did.
Okay.
Oh God.
You are smart. सब तुमने upload करके रखा लगता है hard drive में.
नहीं सर, ये कॉलेज से वीडियो आया है. This is थोड़ा weird. The next video is proper. It's not playing, but.
That's okay. Let me just understand. See, he doesn't shift weight at all on the left side.
Yeah, so that's what I was trying to do. Take him on his left leg. Sorry, the affected leg, and then tell him to do forward, backward.
So this video tells you that the left lower limb is not forming a good stable base of support. He's scared to shift the weight.
Yes, yeah.
So either it is an ankle issue or it is a hip issue. I think it is more of hip issue. Hip extension is not good. Start lot of
strength is not good, or is the tone high? So that's what
tone high will be always there. Whenever you don't get stability, tone will always get high. Whenever the fear is high, postural tone is high. So we don't need to manage the tone. You need to manage the stability. Just give him better stability and he will do better. Like here, you don't give him anything to hold. So give him a cane or something like that here. Let him do the step up, step down, or take him close to the wall. You are playing in the center of the hall. Don't work in the center of hall. Go close to the wall. Like he is supposed to face like this towards the wall, and you sit here. He's facing here, and then do the stepping, and he will do absolutely okay. He will not touch the wall, but be close to the wall. So it is called as perceived limit of stability. Whenever you are in the
this
open
plinth now, this plinth sir comes up and down also. So I was planning कि वो plinth ऊपर करके थोड़ा
plinth ऊपर करके hand support के लिए use किया तो भी चलेगा. इसको high करा.
हाँ, yeah, that's what.
But still, plinth wall is a very stable surface.
Wall,
perception wise. So don't work here. Go close to the wall.
Okay.
And when you do sit to stand also, always do sit to stand close to the wall. And he will show better sit to stand. And you only hold the foot with a large distance, and he will do better sit to stand.
Okay, sir. Let me just.
Because whenever you are doing that, the foot is not getting supinated, so the ankle is not tight, ankle is not spastic. So it is mainly the hip.
This is, I think, a little more stable.
Much better. Your alignment is very good. You use a 3-point pressure, 1 pressure, 2 pressure, 3 pressure. So very good, stable. So you are the moment you provided a good stability, he is stepping better. So hip is the issue.
Okay, hip tone is the issue, right?
Control is the issue. Hip extensor and abductors control is the issue.
Hip extensor and abductor control. Okay.
But don't work on strengthening of hip abductor and strengthener. Work on stepping. We call that stance stability.
Okay, stance stability. Work on stance stability.
You a stepper here, increase the height, and he will get better.
Yeah, I was actually looking for a stepper, but I didn't get a stepper, so I just thought कि थोड़ा a stepping आगे पीछे कर.
Stepper नहीं है तेरे पास, इधर आके बैठ. Can you see this bar here?
Where?
ये जो उसका बेड का रेंज है ना, रेंज बेड का जहाँ पे बेड की तरफ.
हाँ या
उसके ऊपर स्टेप करने को बोलना. You don't actually need a stepper. इधर स्टूल है, इतना बड़ा स्टूल है.
So
even if he doesn't step on that stool, tell him to try to step on the stool.
So बेड भी सर नीचे आएगा और मेरे ख्याल से. हाँ? बेड भी सर और नीचे आएगा.
बेड भी नीचे आएगा. और एक स्ट्रेटजी बोलता हूँ इसमें. सॉरी. Stop screen share कर.
Okay.
If you got some patient like this and they are not very stable or you cannot manage, and if they are very obese, then what to do?
He was mostly scared only, not like he was motivated and all, but he was scared.
Scared only.
He was students and all, so he didn't trust us.
That is the most important thing, because the moment they think
he does independent walking with his therapist, but he never did it with us.
Because he doesn't rely on you, reliability issue. So understand. So this is my affected hip. So because you got a high bed, so what you can do? Let him. This is my normal leg. So let him sit like this, like he is supported here on the hip. Okay. This is how he is standing here. This is the affected leg. Start like this. Weight bear, shift, weight bear, shift. So he is learning stability. So leg up, down, leg up, down. This is the normal leg. Okay. Okay. So he is learning hip stability. So he will not be scared to take this leg high because it is more supported. And now you are working here. So now you give a reach out. Now you give a tightness. Or you just shift, weight shift and unload. Weight shift and unload. Slowly take away this leg down. Okay. Keep the hand there. Then do the stepping like this. You may not require to support or balance this like after a few days. And just work like this. Once you do that, go closer to the wall. Unsupported. Okay. Then you do a stepping like this. Okay. Then go high stepping like this. Or if you cannot hold like that, just supported standing now here and then come forward. Hold. Then come forward. Hold. What is there, bacha? So supported standing and give a high reach out, like at a higher where he has to reach forward. Don't do just stupid shifting forward. Come forward. Hold. The task has to be like this, where he has to come forward. Like now, because this is the paralytic side, I have to reach. I have to come forward. Then I get a hip stability here. Okay.
Okay. Understood.
So you have to give a setup. Now this is a stable setup. If he's still scared, okay, stand. Try to touch your head here.
Okay. So I did this in sitting, like come ahead.
You did in sitting, but his problem is hip in extended hip.
Yeah.
Okay. So his problem is stance stability. So guys, always remember motor control principle. Whatever the problem is there, you have to work in that task or that alignment at least. If you can't check the task, like walking is the problem. Now his problem was standing, so I am doing standing related activities where I am just changing the position of the opposite leg.
So what to do to improve the sit to stand?
Sit to stand, same. Because your left leg is affected.
Yeah.
So this is the affected leg.
Yeah.
Normal side. So start with the normal side. Different. Sorry. Okay, stand close to the wall. Okay, and tell him to stand like this from high bed. Okay, and keep the hand forward like this. Don't allow him to keep the hand down. So if he is close to the wall, normal side on the close to the wall. Initially, he will touch. Afterward, he doesn't require touch, and then tell him to come forward like this, or just bend forward, bend forward, bend forward, bend forward, and stand. Bend forward and stand. Only do this in the beginning. Then you do the full stand.
Okay, understood.
If that is not possible, then you take the affected side to the wall.
Okay.
Okay,
understood. Yeah.
So can you please take my video? I have already sent on the
group पे
भेजा and personally भी भेजा था आपको सर.
कौन बोल रहा है? सॉरी, सोनिया बोल रहा क्या?
सर पूजा गटा.
हाँ. तुम्हारा वीडियो डाउनलोड किया मैंने ऑलरेडी. ये पर्दा है कुछ तो नहीं क्या क्या Pooja has tried this ankle strategy, and she was successfully able to do the dorsiflexion activation here.
Yes sir, it worked awesome.
Actually तुम्हारे दोनों वीडियो ना बच्चा उसमें वॉकिंग बहुत ज्यादा नहीं है, ज्यादा स्टैंडिंग है. दूसरा वीडियो मिल नहीं रहा मुझे.
भेजा था मैंने आपको 3 व्यू में भेजा था, एंटीरियर लैटरल एंड पोस्टीरियर व्यू
भेजा है, वो मैंने डाउनलोड भी किया था. एक मिनट फिर से डाउनलोड. I think this is the video. So that the way you are putting your foot on her foot,
yes sir.
Is it good or bad, guys? Pooja, you don't comment.
Sir, we can't see the video.
You can't see the video? Screen share नहीं हुआ अभी तक.
Oh sir.
One sec, sorry. Okay, now can you see?
Yes, sir.
Yes, sir.
See, whenever she is stepping, Pooja is putting foot on her foot. Okay. I think done. फिर से anybody?
It's good only, no sir. She's guiding her leg.
Yes, it is good because she is working on her foot stability. So sometimes by putting the foot on the foot, she is pronating the foot and she is getting better knee control. So it is not bad. Okay, what you used as a pushing is good enough. So her swing is not the problem. She is doing better swing. Her problem is stance stability. So if you look at Pooja, her left leg is never going forward. So what you can do, you can just stand in one place, just like what you are putting that knee right now close to the knee. See the way you are closing. Just put her like this. You put close to the knee and just assist her here and do the stepping in one place. Let her learn how to do the stepping in the one place and get a stance stability, and then you can walking. Okay. and you probably might not require shoe insert or anything like that. She will recover directly. Just do a lot of sit to stand, stepping, and after doing that, then you make her walk.
Yes,
What
sir.
is your
Sit to
question?
stand. So sit to stand. I did like you had shown in the last ankle control lecture. Like put the steppers so to increase the dorsiflexion range. So close kinematic chain exercise.
I think
So
you are shown.
yes,
Sent me
sir.
that video also.
Yes, sir. That video also I have. And sir, walking I have with lateral and posterior view also.
Okay. So good. Only you have to adduct her knee. Like here, the knee is going to abduction. So earlier you kept your hand, then you removed. So for more sit to stand, you can keep that hand there.
My doubt in this in general, like whenever she's standing or walking, like sir, her knee is remaining only in 10 to 15 degrees of flexion somehow. I'm not understanding why.
That is due to plantar flexor weakness.
But sir, if I'm telling her, see, I'm telling her to make the knee straight, she's able to make straight with my instructions.
Because she got knee control, but plantar flexor are not good. So whenever you get knee flexion, it is most of the time plantar flexor weakness.
So same is happening in walking also while in stance. So basically it is always remaining in 10 to 15 degrees, and that 15 degrees only it's not reducing.
Well, you can accept that 10-15 degree, don't bother, because with knee degree 10 degrees of flexion also she can manage the stance stability. That means her knee control is not very bad. So don't worry. You have to work on plantar flexor, like you can do sit to stand, or you can do heel slide, heel raise, like wall standing and then heel raise. Last lecture we had shown you that.
Sir, overhead reaching. Overhead reaching.
Overhead reaching, actually that task itself will not allow her to go on toe standing, because reaching I can manage with multiple ways without doing heel raise.
Now with the activation of that your glutes, capucci and all.
Overhead reaching with the glutes.
With the point kept on point.
Sir, see that 10 like that some degree of knee flexion is remaining.
So don't worry, that is due to plantar flexor weakness. Or if you want to challenge, so usually if somebody is doing like that and I want to challenge the plantar flexor, I give push knee brace for some days so that the plantar has to work more, and then I remove that. Like our last lecture I have shown you on patient where we use push knee brace for some time and then we remove that. See, she can extend better. It's okay. You don't do anything. Do a lot of sit to stand and walking. It will come. She's improving.
Yes, sir. So, and sir, do you feel that I need to give something for her, like any ankle foot orthosis is required for her? Okay.
She'll recover. She doesn't.
That lateral foot placement will go automatically.
The more she gets control, it will go automatically. तुम्हारे पास खुद का है तो दो temporary. Otherwise, she will walk directly.
Activation is in this video, yes. With that last lecture strategy I used.
You want to see the ankle strategy? What was your question?
I was just telling that video is here where you were talking about the dorsiflexion activation with the reach outs in the opposite direction.
The more she does reach out, you can see the dorsiflexion here.
This is from the last time's lecture.
So the more she go backward, the activation will become more and more effective. Watch this. This is one of the strategy we have studied in last ankle control lecture. So the more she go backward, abdominal will kick in, hip extensor, hip flexor, knee flexor, and dorsiflexor will kick in.
Yes, I'm resisting as you had told. So I'm resisting.
Her base is very soft here, and she's sinking into that. Either put one or two pillow here, make it more unstable, then it will be more challenging. Okay. Okay, we'll stop here.
Please also, sir, one my video, please.
कौन बोल रहा है? Sorry.
खुशबू. Sir, should I send it again?
कहाँ पे भेजा तुमने?
ग्रुप पे ही भेजा था yesterday.
ग्रुप पे 1 sec hold. मैंने डाउनलोड कर लिया सभी ग्रुप पे. खुशबू जैन, हाँ.
So in this patient, while walking, he is taking his affected hip more into abduction, that is close to the walker, and his body he's also throwing forward. Otherwise, his standing stability, मतलब balance is good.
केस क्या है, हेमी है कि पैरा है?
नहीं हेमी है सर. राइट साइड क्रेनियोटॉमी इज डन, लेफ्ट साइड हेमी.
वॉकर यूज करने की जरूरत नहीं होती, यूजुअली वॉकर देते नहीं अपन.
सर बट वो स्टेप ही इज नॉट वॉकिंग ओनली देन, अदरवाइज
ठीक है, उसका हैंड कंट्रोल बहुत अच्छा है, तो इसलिए यू कैन मैनेज दैट. अभी
हैंड तो सर स्ट्रेंथ सब कुछ अच्छा है. लेग का भी ही इज वेरी गुड, but his plantar flexors are weak, that's why he is also keeping his knee flexed.
Absolutely
But
right.
while walking, he's throwing his upper body too much forward on the walker. So
He is
should I
not
give him
throwing because basically he doesn't have ankle, his body is leaning forward because ankle is not good. So option 1, you can give static AF for few days. Option 2, give push knee brace for few days. Try both, whichever works. You can continue using that for few days, and after that you can remove that and do lot of sit to stand and stepping exercises on the unaffected side.
So sit to stand is not doing without support. So should I allow
You can
him
do
or
with the
should
support
I?
like walker दो, खाली high chair दे दो ना बच्चा, आप high bed से करो.
High bed से मैं कराती हूँ, but he takes his both hands support on the bed and then he goes up. पूरा bend forward करने के बाद भी he doesn't come up.
It's okay, सपोर्ट जितना चाहिए दे दो, लेकिन ज्यादा लोडिंग करो. अगर नहीं कर रहा है ना, वॉल स्टैंडिंग करो, बैक सपोर्टिंग द वॉल and just shifting forward backward. Or if he also doesn't do that, only work on right side in standing, like stepping up, sideways, forward, or mini squat in standing. Don't do full squat, mini squat in the standing.
Okay. Okay, sir.
Probably
Sir, one more video I have sent, if you can see. That is a short one.
इसके पहले भेजा
उसके ऊपर, हाँ उसके पहले ये. So she is 4 to 5 months old. I am treating her, but her leg strength is good in supine flex, dorsiflexion, plantar flexion is good. In standing, it is not that good. I'm trying that stepping and all with unaffected leg.
Look at the step length. Analyze the step length. Left step length is never going forward. Problem.
And she is also keeping her leg abducted, and whenever she is going up.
So that is stabilization strategy.
Reliability.
Sorry, sir.
वही तो बीच में बोला. Where is the problem, guys?
Stand stability.
Reliability.
Hip problem, ankle problem.
Can you play the video again once?
Ankle problem.
Ankle problem. Work on ankle range also. Range is also limited and strength is also limited. So here you keep the affected leg on the step and then do the stepping up on the normal leg.
Okay, okay.
Usually we do this down and then up down. In your patient, you will put this on the small step first and do this right leg up down, up down. Afterwards, do the high stepping. Do full squat possible, or you do at least low sit to stand. That will get you good range here. Or do a mini squat and stepping with forward backward with the left leg. समझा क्या last?
Okay, sir.
खुशबू?
Yes, yes. Yes, sir. Sir, should I give her AFO?
No need.
No need. Okay, thank you.
AFO किस लिए देते हैं अपन? अगर plantar flexor weak है, dorsal flexor weak है. So both are good. Only range is the limitation problem. So range you don't give AFOs. You want
supine में तो उनका बहुत supine में she can take full resistance in both, but in standing she is not able to take weight on that leg. Even if I tried stepping, side stepping,
she has used to this strategy where she is keeping the tibia backward. Teach her left leg big step, left leg big step, left leg big step.
Okay.
That's it. And within few days she will walk better.
Okay, sir. Yeah. Thank you.
So in the video that we saw last, like for my patient with the hemi walker that she was walking.
खुशबू. कौन बोला? खुशबू बोला ना?
पूजा सर.
पूजा हाँ बोलो.
सर इसमें आपने बोला AFO का जरूरत नहीं है, बट एंकल बाइंडर विल इट बी हेल्पफुल? वो जो लैटरल वेट बेयरिंग करे तो एंकल बाइंडर दे सकते हैं क्या फिगर ऑफ 8 वाला?
तुम्हारे पेशेंट में ना? हाँ, इसको फिगर ऑफ 8 दे लेना, कुछ दिनों तक चलेगा.
हाँ.
स्टेबिलिटी के लिए चलेगा. या समटाइम आई यूज स्पोर्ट शू आल्सो. स्पोर्ट शू गिव्स मैकेनिकल स्टेबिलिटी. आर्च सपोर्ट अगर अच्छा रहता है, सो यूज एंकल बाइंडर एंड स्पोर्ट शू बायलैटरली. Or if she doesn't get stable, then you can give a shoe insert a type of AFO. उसका वजन कम है तो आई थिंक शी विल मैनेज विदाउट AFO ऑल्सो. उसका पैसा क्यों खर्च करना है? घर पे स्पोर्ट्स शू होगा कोई तो वो यूज कर. ठीक है. Okay, we will stop now. Feedback.
Sir, one more video I have sent that. Is it?
Who is that?
Somnath. That CP child, diplegic.
CP child we can do in next lecture also. Don't worry.
Oh, no, okay. No problem, sir. No problem. No issue.
CP child, like a lot of people, you guys are coming with CP child. You can talk in next lecture also.
Okay, sir.
Okay, you only start, Somnath.
Yeah. Today's sessions is that probably it's a revision of that all the lectures you have taken in the lower trunk and up to ankle, probably. Yes, sir. And for me, it's a clinical reasoning. How will you understand that? Where is the exact problem regarding the gait, basically? It's a good.
Okay. Can I go start?
Yes, sir.
Can I go next, sir? I have to leave for work in 20 minutes.
Go.
Sir, I think like what the video you had taken, like the gate made easy thingy. I think it was sort of the same thing. I think you had taken more during that day. So I mean I literally have like my notes ready of that day. So I mean it was just a revision sort of. So yeah.
You were one of the model in that, I think.
Yeah, I was a very fat model.
Okay. You want to continue or shall I tell someone else?
No, I'm done. Yeah.
Okay, Pooja Gada.
Yes, sir. So it was a fantastic lecture today. Sir, the thing that I loved was that Gait biomechanics, how you revised and how you made us only fill that table, that concentric, eccentric. So basically, this was a 15-mark question in our biomechanics, and हम लोग ये रट्टा मारा था. So today I was regretting that why didn't someone like you teach us so that we didn't have to by heart it. We had हम लोग ने सिर्फ रट्टा मारा था, वो समझा कुछ भी नहीं था, आज तक नहीं समझा था. Concentric, eccentric, कैसे क्या, so that was a very good thing. And now I think I'm sorted for lifetime. अभी कोई biomechanics grade का पूछेगा तो मुझे मतलब logically मैं बता पाऊंगी, मुझे वो रट्टा मार memorize का जरूरत नहीं है. So that was a very good thing, and I'm glad because I think हर physiotherapist को ये gait biomechanics आना ही चाहिए. So that was a very good thing. So thanks a lot. And apart from that, yes, I think sir the अभी हम लोग ICF मतलब चल रहा है, everything is on ICF. So sir, but ICF का basis ये है कि clinical decision making impairment, कोई भी impairment क्यों है, उसका clinical decision making and then how to form the management strategy. But वो हम सिर्फ theory में ही पढ़ा है हमने, but practically हम कैसे apply करते हैं, that I think you have taught us. एक simple चीज़ है कि stability problem है कि mobility problem है, फिर hip है कि ankle है. Since now भी दो अभी पता चल रहा है कि knee का involvement actually बहुत कम होता है actively, वो सब passively हो जाता है gait में. So that was again a very good practical demonstration of how to apply ICF. ये सिर्फ थ्योरी में पढ़ा है, ICF अप्लाई करो, impairment and clinical decision making and all those things. So that is a very good thing, sir. And yeah, so thank you for giving solution for my patient also. It will be helpful. Thank you, sir.
Thank you. So guys, video चालू करो सब लोग.
सर सिर्फ और एक क्वेश्चन है, मतलब इट्स नॉट अ स्पेसिफिक पेशेंट रिलेटेड क्वेश्चन नहीं है, जनरल क्वेश्चन है. तो सर कोई भी मतलब ऐसे न्यूरो पेशेंट्स पर चलो भी स्ट्रोक का ही ले लो, तो नॉर्मली वन ऑफ द फर्स्ट क्वेश्चंस दे आस्क इज कि हम लोग कब चलना कब तक एक्सपेक्ट कर सकते हैं या कब तक आप हमें चला सकते हो. तो आपके ओपिनियन में मतलब इन योर ओपिनियन हाउ शुड वी आंसर दिस क्वेश्चन, मतलब सिंस इट्स अबाउट द गेट.
I will tell you how I answer. So whenever I check any patient, I check for important thing, can he sit without hand support? If he can sit without hand support, he will walk within 1 month.
So and in the first session without hand support.
First session without hand support. Like whenever you assess, you let the first 2 weeks let go. After first 2 weeks of hemiplegia or stroke, if he can sit without hand support, that person can walk within next 1 month. Okay. If he cannot sit without hand support, he might take minimum 3 months. Okay. But that is a randomization. It is always based on how much you are working in standing and walking. If you are working in supine, then he will not walk. Okay. So sitting without hand support is the key to tell somebody can walk or does not walk. Like sometimes people online ask me, this is my case. I just ask them to send me only 2-3 video, like sitting without hand support, sit to stand, and if they can stand or step, that's it. If they stand and step, I understand what is their stand stability. I understand their sit to stand as a dynamic control, and sitting again as a stability in the trunk. So sitting will give me a rough idea of trunk control. Stepping will give me a stand stability, and sit to stand will give me a dynamic control. So if these three things are there, I make them walk within 10 days to maximum 1 month.
So actually it depends on many factors, but just a rough approximation patient को देना हो तो yeah, this is a very good strategy or how to know the prognosis. Okay, thank you.
Sonia.
So I learned about more of the evaluation part. मतलब मैं just ऐसे randomly exercises देती थी, तो मुझे नहीं पता था कि मतलब कौन से joint पे क्या problem हो सकता है. तो अभी I learned कि कैसे evaluation करना है, कि कौन से joint पे problem हो सकता है. And I used to work more on the knee. मतलब knee extension, more of the quadriceps, but then I got to learn कि quadriceps knee भी इतना कुछ important नहीं है. We want to work more on the ankle and the hip. So मुझे वो एक आज समझा, क्लियर हुआ. और गेट का बायोमैकेनिक्स तो मुझे पहले भी नहीं समझा था, तो अभी एटलीस्ट थोड़ा बहुत क्लियर हुआ है आज के लेक्चर से.
Okay, this Gait made easy. There are 2 lectures already available on YouTube. Okay. In detail, I have explained that. I will share that link on the group. You can watch that later also if you want to watch again and again. So that is purely Gait. Here I only took some part of that explanation and then explained here. Each lecture is, I think, 1.5 hour lecture. So you should have some time to listen to that lecture. Vikrant, are you there? Mansi? Okay, Khushbu, go ahead.
Yes, sir. Sir, attending your lectures actually have completely changed my perspective to see a neuro patient. I never thought of looking at a patient, neuro patient, biomechanics and all. Now it has like every time when he sit to stand or anything, I look at every joint, everything. Otherwise, I used to think that it is all about the brain. But today also I learned the new things, that how environment matters, how the gravity matters, even in all that, how we can use that in our treatment. So there are too many open doors. Otherwise, it was so limited that no, after this we cannot do anything. It will take time. It is going to take time. It was like that in our mind, but it can be fast. It all depends on our way of treatment. So it is really very helpful, sir. And your when you see our videos and help, that is even very better way of teaching. That's what I think, sir. Thank you.
Thank you. Manasi? Manasi? एक बार लीव कर और फिर से ज्वाइन कर, आ जाएगा. Anuj, you can start.
Yeah, good evening, GB sir.
Yes, go ahead.
You just made the Gait so simple. You broke it down into its basic fundamental pieces. It looks like a periodic table now, like hydrogen, helium, all those things. it's nobody has made it so easy or simple as you had done it. So that's the best part. And nowadays I don't look into everywhere in a patient. I don't look everywhere, and I don't need much equipments also. Like people, when they say you're not carrying any equipments, I say I don't need any equipments. I just need a room. And even if there is a bed or anything, even if I don't have that also, I'll make use of the gravity also.
Wow.
So they say, oh, So
Very well
they
said.
said, where did you get such an attitude? I said, I've been to some places. There are some people. I had mentioned about to you. I had mentioned about to you to some of my clients. I did say
Can
that
you repeat that
there is
sentence?
an
What you said? What you don't have?
what?
I like that sentence.
But I don't need any equipments. Whatever I have, if even if there is a room, it doesn't matter. Even if it's not a room also. Even if we are outside also, we'll just make use of the gravity. If there is water, we'll make use of the water also. You give me a swimming pool, I'll make a mega clinic out of it. So they asked me how do you do that? So I said, like I said before, I met some people. I mentioned about you. I mentioned about you to some of my clients. I said there is an HOD. Uh, I said I told them about your name. I showed your blog. There is a blog which you had created. It's still there, right? So
Yes, it is there.
yeah, in that Gajanan Balarao, aquatic therapist and NDT specialist. So I showed them your picture and Suryakant sir also, not just you. You both of your cousins, right? So I've showed about both of you, and I told them, in the beginning, I wasn't so, I wasn't so good at this. Even now, I'm not so good. I believe there are a lot many to learn from you all, and I'm trying to make use the maximum out of it by watching, even if it's a webinar. It doesn't matter. Even if it's a podcast, also I listen to it, and that's how I learn. I said, in order to learn, I see my brother. He got opportunity to go overseas and take his MBA and also, but I didn't never got an opportunity. But that didn't really stop me. Like when I think I try to see the positive out of everything. If though I didn't get an opportunity, but when there is somebody like you went over to so many places, and whatever you have learned, I think you have went across to Europe and Australia also. You learned motor learning from Australia. So I tell some of my friends and some people in my family that I might not have got an opportunity, but opportunities came over to me. See, in the form of certain people. So what you had learned from outside, you're teaching us. So that's a great blessing, and I'm making use of it. So
I must tell you, Anush, your personality changed a lot. Usually, Anush cannot give compliment at all. He didn't know how to talk to girls also earlier. He was so rude, and now you are so soft spoken. And the way you are using words and you are playing with the word, I must appreciate that.
even Manish Bhai also speak the same about you, but it's not how it seems when it comes in front of you. Honestly.
Good, Anush. I'm proud of you. Proud of you.
Because of even if it is a minute, which you're teaching us, I consider it as a fortunate moment, and that is why I watch, this webinar sessions recording will be available for 7 days time, right? So I will watch it every day. I don't miss a single sentence. If there is a sentence, if I missed it, that is why I'm asking, what did you say, sir? Then I note it down. For example, the suspension strategy posture, which I have mentioned, and the book in which it is mentioned about, I look for it. I'll go where I can find it. Even had taken membership in several NCBI, NIH, all these. Like NCBI stands for some excellence something, some medical. It's some
NCBI is
medical
a British
related
library,
body.
basically National
Yeah,
British Library.
yeah, and even Harvard HMX also. I took membership in Harvard HMX. It's online version of platform created by Harvard Medical School itself. And I took several CME, completed several CMEs of Harvard Medical School, completed course related to neurology from EDX. Then then took membership in Physio Plus, Physiopedia, covered I think the first part of neurology from that. When just like that, whenever you are teaching something, I'll dig into it. I'll see what you're teaching. Okay, I'll
Anush,
not miss a
I will
point.
give you a
Okay.
very simple way to learn better.
Okay.
Actually, you are trying to tell me that you are learning, but you are actually not learning. You are just understanding the concept. I want from today, you need to teach at least 2 therapists, any concept. The more you teach other, you get better at it. Right now, you are just absorbing the information. Teach others, you will get too good at it.
I do that. I am not coming across many a therapist over here, but instead of therapist, when the clients come over to me, when they ask me certain doubts, I explain the entire thing over to them in the layman's term itself to them.
So what you are doing, you are doing appreciation of others. I don't want you to do appreciate others. I want you to appreciate yourself first. Whatever you learned, it is too good right now. Just apply it. And whenever next time you tell any patient, do not give my name, only give your name.
I give your name.
No,
so
don't
that
do
they
that.
get.
No, don't do that. Listen to me. There is a strategy behind it. Do not give my name. By giving my name, you might be appreciating. I don't need it. I don't know whom you are talking to you. But saying that I learned, it doesn't matter where did you learn. Take it as your own strategy. Take it as your own thought process. Take it as your own fundamentals and apply it. I'm not going to come and question you. How can you use my concept and apply like that? It is not like that. I will never object. So please do not take my name next time.
Okay.
It is your learning. You paid for it. You spend time on it. Take ownership to yourself. Say that I do. Okay. Will you do that next time?
I'll do it. I was so inspired when I was so, yeah. Can I say this one thing?
No, one
I
thing.
was so
Anush, next feedback. I don't want you to appreciate me.
Okay.
I want you to appreciate yourself. What have you done or applied, and how did you taught others? That is what I want to listen. Because in your feedback, it is more of my appreciation, which I don't like.
Okay.
Okay. I want my concept of feedback is not what I did, how good I am, how did I taught you. My feedback concept is what did you learn? How did it affect your life? How did you apply? That is what I'm more interested in. Okay.
Okay. There is a new thing which I learned in this today's webinar session. That speed also does matter. I never knew that. I never took speed too seriously, but now I'll take it seriously.
I like
walking
that.
speed.
Very good. That is a good feedback.
So, and we and in the walking thing, like you had mentioned in the last weekend session, you said you need not correct the ball X thing in order to get the walking possible. So in today's webinar, I got the brief note why it's not really necessary.
So bow leg need not to be treated, right?
Yeah, ball leg we need not correct it, but I corrected it because they wanted it also to be corrected. I said when they started seeing their upper limb recovery, they said, okay, if he can do that, then I said, if you got a ball leg, we can correct it also. I said, then okay, they said, okay, let's do that also, because they, I gained their trust that if I do that, I won't delay the gaining the results. Then we started working on it also. We started getting the results also. That's how we did it.
Okay,
but,
new strategy for your treatment for bow leg. Do not work on bow leg correction. I want you to work on knee extension, which is terminal 10-degree extension in loading.
Okay.
So make her stand on one leg and do stepping, high step, up, down, high step, and that's it.
Okay.
Okay.
Okay. Okay then. Thank you, sir.
Mansi.
So can you hear me now?
Yes, I can hear you now.
Yes, sir. So all of whatever said and done, speed is important. We need not put a lot of stress on hamstrings because momentum is doing the work. The importance of gravity in walking, gait was simplified. So overall, I think what I take away from this lecture is identify the problem first, because we saw so many videos. We think knee is the problem. We think balance is the problem. This is the problem, but ankle is the culprit, and which we ignore. So identify the problem and then solve the problem. I think this lecture was a kind of problem simplifier. Simplified and then solve it. The videos that came were from so many different environments, sir. One was from, many of them were from hospital, many of them from the home. So when you see the environment also, you also learn, oh, you can use this. The way you told Pooja, I guess, to use the hospital bed or to use the hospital this. So that is also important, how we use our environment. And then you become a problem solver so well. So that is what is takeaway for me. Or of course, increasing the speed was something new. The video which I saw, internal rotation strategy, that was something new, sir, which I saw. How the patient are compensating with internal rotation strategy. That is the first time I have seen something, sir. And all good, sir. I would like to appreciate Anush Babu because he doesn't appreciate himself. So I will appreciate the video which he showed, wherein the wheelchair stability is also there and mobility is also there. That was awesome. It was really good. I have seen it for the first time. And in future, I'll also use it, maybe. So I'm appreciating him. And thank you so much, sir. Very good, wonderful lecture.
Thank you.
Thank you. Thank you so much.
Twinkle, Vikrant, are you there or we are stopping the lecture?
Yes, sir, I am there.
Okay, you can start video also.
Oh, sorry, sir. Yeah. So, sir, in today's lecture, actually, I didn't attend your previous lecture for the lower limb training. This was my first one. So, but I am your student since a very long time. So, I was already able to correlate many things. And, sir, I never missed that chance to appreciate you because you were the person who created interest for neuro. Matlab in my life, especially, I was very scared about the neuro patients and everything, but you were the one who built up that interest. And after that, I've applied everything that you have taught to me on different patients. And the very correctly that you said ki we get results on the very first day. It is very true because I definitely get results on the very first day when I'm treating my patients, and it is all because of you. And I was able to correlate many things. It was just that in hypotonia I was lagging somewhat behind, but all my doubts were cleared now, and I hope I'll apply them in a proper way on my patients too. Thank you, sir, for that thing.
Thank you. Thank you. Vikrant, we are closing. I think you are not there. Okay, guys.
Just a small request, sir. Next time,
yes, Pooja, go ahead.
in the last lecture, can you take biomechanics of the gait deviations also, like the altered gait, like today how we did for the normal gait. So, are you going to take in the last lecture about?
Because the last lecture is about the gait deviation, different gait deviation. Some gait deviation I am going to by default take. If you got any question, you can ask anytime, no problem. You can ask in the start of the lecture also, or you can put in the group also, and then we'll take it. Okay, so don't worry. Okay, bye bye.
Bye, sir.
Bye bye. Bye bye.
Thank you so much, sir.
Thank you.
Bye, sir. Thank you.
Thank you. Thank you, everyone.